So, very good morning, everyone. It's a beautiful day today. It's a lovely weather in Delhi. I don't know about other cities. And today, great lectures are lined up. Those are very important, like pulse oximetry, capnography. These are the initial lecture, and eventually we have good cases today. Sleep gastrectomies, they are with increasing obesity. So I hope all the residents are prepared for today's academic feast. So let us start. Our moderators for the first sessions are Dr. Bhavna Rastogi and Dr. Madhvi Chaudhary. So Dr. Bhavna Rastogi, ma'am is professor and head in Subharti Medical College, Meerut. Ma'am has more than 45 publications in national and international journal, and she received an outstanding female faculty achievement awards by Swami Vivekanand Subharti University. Ma'am, areas of interest are regional anesthesia, airway management, and critical care. We welcome you, ma'am. Our other moderator is Dr. Madhvi Chaudhary. Dr. Madhvi Chaudhary is professor in anesthesia in Pramukh Swami Medical College. Ma'am has more than 9 national publications. She is faculty in state and national conferences and workshop. She is an ATLS faculty, instructor of ACLS, BLS, BCLS, and CCLS. We welcome you, ma'am. Dr. Madhvi, ma'am, are you there? I don't know, Dr. Madhvi. I'm trying to reach. She's online, but she's not responding. Dr. Bhavna, can you please introduce our first speaker?
You're on mute, ma'am. Dr. Bhavna, ma'am, please unmute.
Good morning, everyone. Our first lecture is on pulse oximetry, and our first speaker is Dr. Anjana Sri. She is a neuroanesthetist from Sri Chitra Trinool Institute of Medical Sciences, Trivandrum. And her achievements are like she has won the quiz on Indian Society of Neuroanesthesiology, and her area of interest is neuroanesthesia and neuromonitoring. Dr. Anjana Sri, please start your lecture.
Warm greetings to all faculties, students, and my dear friends. Today I'm going to talk about pulse oximetry, which is a simple yet a vital device that we use in our day-to-day practice. It is also called as the fifth vital sign. It is a non-invasive method of monitoring hemoglobin saturation. In 1986, ASA standards for basic anesthetic monitoring, it has been included, and in 2020, they said for measuring blood oxygenation, pulse oximetry can be employed, and whenever it is utilized, the variable pitch pulse tone and low threshold alarm shall be audible for the anesthetist. It works on the principle of differential absorption of light, which is explained by the Beer-Lambert's law. So whenever a light passes through a substance or a solution, some amount of light will get absorbed, and this absorption depends on the path light that the light has to travel and the concentration of that substance, such as the capacity to absorb the light, that is hemoglobin in our case. So the concentration is explained by Beer's law and the path length by the Lambert's law. So in the electromagnetic spectra, the red light at 660 nanometer and the infrared light at 940 nanometer, these two lights are used by the pulse oximeter. So this is a graph that is showing on x-axis the wavelength of light, and on y-axis the extinction coefficient. Extinction coefficient is a measure of how strongly a substance can absorb a particular light of a particular wavelength, that is explained by the Lambert-Beer law. So the green line is the deoxyhemoglobin and the blue is the oxyhemoglobin. So at 660 nanometer, the hemoglobin, deoxyhemoglobin has a higher extinction coefficient, so it absorbs more red light. And at 940, it is for oxyhemoglobin, which absorbs more oxyhemoglobin at infrared spectra. it has higher extension coefficient. So for oxyglobin, there is more absorption. And the blood has a arterial AC component and also a DC component. AC component is the pulsatile arterial blood, and the DC is the non-pulsatile tissues like capillaries, venous blood, skin, bone, other surrounding tissues, etc. So the SpO2 is calculated from the AC component of the AC component, that is the arterial blood, and the DC component act as a baseline for the light absorption, which act as a background signal. So how SpO2 is calculated from is by calculating R formula, that is the ratio of AC to DC of red and the AC to DC of infrared light. So when this R value is plotted on a calibration curve by the different manufacturers who produce this pulse oximeter. So whenever the R is low, there is more infrared absorption, that is more oxyhemoglobin. So it chooses higher SpO2, that is near to 0.4, it is near to 100%. When it becomes higher, R value is higher like 1, it will be 85%. Coming to physiology of the oxygen transport, that is oxygen dissociation curve, which is a sigmoid shaped curve, which shows the relationship between partial pressure of oxygen and the percentage saturation of hemoglobin by oxygen. So it has a two portion, that is a flatter portion and there is a steeper portion. So in the range of more than 60%, 60 mm of mercury of PO2, the curve is flat, and whenever there is a large drop in PO2 at this part, it causes minimal changes in SpO2. This is called as a buffer zone, or a zone with good oxygen reserve. So when SpO2 is less than 90%, the curve becomes more steeper. So even a small fall in SpO2 shows a rapid decline in the PO2. So this is called a danger zone. So SpO2 helps to differentiate these two zones. Coming to the equipment, it has three parts: the probe, cable, and console. Probe, as I said before, it emits two spectra of light, that is red light and the infrared light, which is detected from the opposite side by a photodetector, photodiode. So there are two types of probes, that is reusable probes and disposable probes. Reusable probes are we commonly use, which is economical, but if it is not fitting properly, there could be some motion artifacts and some ambient light interference can be there. Disposable probes are usually well fitted. It has a self-adhesive wraps and better motion stability, but it is costlier. And the cable is the part which connects the probe to the console, and different manufacturers cables, even they are actually not interchangeable, although it may fit into other manufacturers' monitor. The console is the one which monitors, which shows the values of SpO2. So most oximeters that we use shows this SpO2 values as a part of multifunctional physiological monitor, or a part of anesthesia machine monitoring system. And some handheld monitors are also available, which helps during transportation of the patient. Pulse oximeter shows an average value of SpO2 and pulse rate. So normally by default, it is kept as 10 seconds by most of the manufacturers. So when we can increase the averaging time, which improves the accuracy during the probe motion, like whenever we are transporting a patient. And a shorter averaging is useful during anesthesia induction emergence. Especially in neonates, we can use shorter averaging time. And during suction intubation, such scenarios. Different sites we can apply this pulse oximeter. Most commonly we use is finger. It has a good accuracy also, and it might be affected in certain scenarios when we raise the arms or lower the arms because of poor perfusion or venous congestion. There might be a fall in SpO2. Also, while keeping the probe, we should keep in the finger which it fit properly, and also better to avoid the BP cuff in the same hand or IV infusions on the same hand. And the probe on the index finger during recovery might have a risk for corneal injury. And the probe performance during arterial cannulation, so you can keep it better on the opposite hand while some procedure. Other sites, based on the types of pulse oximeter, there are two types, like transmission and reflection, where the detecting diode is kept either opposite or adjacent. So transmitters is used in finger, toe, and earlobe, and reflectance on the forehead, nasal bridge, tongue, and esophagus. Applications of pulse oximetry is it helps in monitoring oxygenation and peripheral circulation, determining systolic blood pressure, and avoiding hypoxemia. For monitoring oxygenation in various clinical scenarios, like during anesthesia induction and emergence, to detect early desaturation, and during one lung ventilation, to assess the effectiveness of intervention to improve the SpO2 or oxygenation, and for regional anesthesia and monitored anesthesia care to differentiate hypoxia from restlessness or to prevent inappropriate sedation, and to confirm the tracheal tube placement, and various complications like embolism, aspiration, and esophageal intubation or inadvertent bronchial intubation. And various clinical settings like post-anesthesia care unit or during transportation of patient, and when we are using post-operative opioids to avoid the risk of respiratory depression, we can use pulse oximeter. For monitoring peripheral circulation, the lithotomy position, the toe SpO2 probe can detect the perfusion. The toe SpO2 can detect the decreased perfusion in the feet. And during shoulder arthroscopy, for detect the brachial artery compression in limb fractures to monitor the distal circulation. During mediastinoscopy for the vessel compressions, and sympathetic block. After giving sympathetic block, we can see increased peripheral flow, which is reflected as an increased better SpO2 pulse amplitude. And for determining the systolic blood pressure also, it can be used by slowly inflating the cuff, and we have to see the pressure at which the SpO2 pulse waveform disappears and correlates with systolic blood pressure. And also for avoiding hyperoxia, especially in premature neonates, to avoid retinopathy of prematurity. SpO2 is also used for assessing the fluid status. So most of the monitors use perfusion index, and Massimo has split variability index also. So perfusion index is the ratio of pulsatile to non-pulsatile arterial flow. It helps to detect the local perfusion at the probe site. It can tell whether it's a vasodilated or vasoconstricted state. Pleth variability index is nothing but the respiratory variation is also included with PI. It can predict the fluid responsiveness intraoperatively. So advantages of pulse oximetry is, yeah, it is highly accurate, especially SpO2 more than 70, because it is tested in healthy volunteers. Because of ethical reasons, more than 70 only is tested. And reliable in dysrhythmias, and it has a faster responsive time. It is non-invasive, patient-friendly, and can assess perfusion. Especially whenever there is a high signal pulse with a low BP, it indicates adequate cardiac output. And whenever there is a low pulse signal with low cardiac output, a low BP, it could be mostly because of a low cardiac output. Some limitations of pulse oximeter is sometimes it might fail to determine the oxygen saturation, especially in certain scenarios like vascular and cardiac surgeries, and hypothermia, hypotension, renal failure, or low hematocrit, and artifacts, cautery use. So always go with the clinical signs too. And during poor perfusion conditions, like whenever we are applying an external BP cuff for poor positioning, Raynaud's phenomena, cardiopulmonary bypass, vasoactive drugs, etc. And also in higher perfusion or higher oxygen partial pressure situations, like whenever the PaO2 of more than 90 becomes a little insensitive to detect the hypoxia. And delayed hypoxic event detection can be there whenever the peripheral probe site has a hypothermia, or whenever associated hypotension, or the averaging time is too long, or associated motion or artifact is there. And also poor probe contact or venous obstruction can also lead to poor detection. In certain scenarios like methemoglobin is nothing but oxidized form of hemoglobin. So Fe2 plus becomes Fe3 plus, where methemoglobin cannot bind to oxygen, and also it increases the affinity of oxygen to normal hemoglobin, which prevents the unloading of oxygen to tissue. Here what happens, the red light and infrared light, the 660 and 940 nanometer, both absorbs the light equally, so the R value becomes 1. Whenever R value is 1, it always shows 85%. So it is either an overestimation or an underestimation of actual SO2 levels. So such scenarios, co-oximeter can be used. Co-oximeter use more than 2 wavelength. So in pulse oximeter, only 2 wavelength of lights is used. Co-oximeter can use more than 2, 3, 4 wavelengths at a time. Carboxyhemoglobin, it has a light absorption spectra near to the oxyhemoglobin, so it can show a falsely high hemoglobin level. In sickle cell disease, there is a replacement of adult hemoglobin, normal hemoglobin, by HbS. So their oxygen dissociation curve shifts to right, and patients might show a lower SpO2 compared to the baseline, but most of the studies have shown there is no clinically significant bias in this. And also some studies have shown even though it is there, it will be plus or minus 2% underestimation can be there. And other scenarios like severe anemia, where low Hb, there is a total reduction in HB, so it can show a false normal value of SpO2. And nail polish, dark colors, black, blue, green colors, or mehendi, all can show a low SpO2 reading because their absorption spectra is near to 660. And in such scenarios, we can keep the probe in a side-to-side manner. And dyes like ICG, methylene blue, all can decrease the pulse oximetry reading when you inject the dye. It is not a true desaturation. It is shown in the monitor like that because its spectrum of absorption is near to the deoxyhemoglobin, 660 nanometer. Some reported complications have been seen, but like pressure injuries and ischemic injury, whenever the probe is very tight or very prolonged use without a change in the change or any change of the probe, we are using it for a longer time with hypothermia, there could be a risk of pressure source, and there have been reports of burns in neonates whenever associated poor perfusion or hypothermia is there, and when we use a wrap around tight probe is used. Such cases, we can prevent this by site rotation, frequent site rotation, frequent checking of the fingers whenever we apply it for a longer time. So commonly we are using Massimo and Elcor pulse oximeter. So Massimo has a signal extraction technology where even it is accurate during there have been studies and they show that there is accuracy even during motion, and also low perfusion, also with skin pigmentation. It has shown more accurate, and along with the SpO2 pulse rate perfusion index and pleth variable index, they use co-oximetry. Total hemoglobin saturations also can be seen. So pulse oximetry is a non-invasive, real-time, universally applicable monitor with a life-saving potential across all clinical settings. Thank you.
Good morning. Thank you so much. Dr. Madhvi, please can you introduce our next speaker?
Yes, can you please start my own video? It's my privilege to introduce Dr. Sangeeta Yadav. She is professor in RML Hospital, her area. Hello, good morning.
Good morning, ma'am.
Can you hear me?
Yes, ma'am.
Morning, ma'am.
Hello, it's my privilege to introduce Dr. Sangeeta. She is professor in RML Medical College, and her area of interest is pediatric and obstetric anesthesia, trauma and resuscitation. Welcome you, madam. Your topic is capnography.
Yes, ma'am. Good morning, respected chairperson and delegates. Today I am presenting the lecture on capnography. Why capnography is important? Pulse oximetry reflects the state of oxygenation, while capnography, it is the indirect measure of hypoxia. It provides information of metabolism, pulmonary function, and cardiac status, and it is effective in early detection of various adverse respiratory events before the life-threatening problems occur. And it has been observed like SpO2 and end-tidal CO2 prevent 93% of avoidable anesthetic mishaps. So in this lecture, I will briefly cover the history, guidelines, nomenclature, physics of capnography, equipment, normal capnograph and its component, abnormal capnograph, and the uses of capnography beyond operation theatre. Capnography first developed by Carl Friedrich Luft in 1937. In 1978, Holland was the first country to adopt capnography as standard of monitoring during anesthesia. The Indian Society of Anesthesiologists has designated capnography as a desirable standard in its anesthesia monitoring standard recommended for India with effect from 30th December 1999. From 2011, it is the integral part of minimum standard monitoring. So few definitions which are important like capnometry. Capnometry is the measurement and display of numerical CO2 value in a gas mixture. Capnometer, it is a device that measures and displays CO2 reading. So what is capnography? Capnography is the graphic display of instantaneous CO2 concentration versus time, which is known as time capnogram, or expired volume, which is known as volume capnogram, during a respiratory cycle. Capnograph is a machine that generates a waveform, and the capnogram is the actual waveform. Capnogram is the actual graphical plot of CO2 versus time or volume. So what are the various methods for measuring CO2 in a gaseous mixture? Most common method used is infrared spectroscopy. Other method you should also know, which can be asked in your exams, like mass spectrometry. It is the gold standard technique. Raman spectrometry, photospectrometry, gas chromatography, and ultraviolet absorption. Infrared technique. This technique analyzes only those gases which contain at least two or more dissimilar atoms. It is used to measure CO2 and volatile anesthetic agents. It cannot analyze oxygen and nitrogen as they contain only one atom. So infrared light is passed through a sample chamber. There is a detector or a sensor on the opposite side. The amount of infrared light reaches to the detector is inversely proportional to the amount of CO2 present in the gas sample. The light falling on the sensor changes the voltage in the circuit, and CO2 is absorbed at a specific wavelength, that is 4.26 micrometer. So what is the principle? Principle is Beer-Lambert law. Beer law is the absorption of light passing through the medium is directly proportional to the concentration of the gas. Lambert's law, the absorption of light passes through the medium is directly proportional to the length of the path the light need to pass through. So what are the types of capnography? There are two types of capnography, side stream capnography and the mainstream capnography. In side stream capnography, the sensor is connected to the distal end of the breathing system by a sampling tube, and in the mainstream capnography, sampling chamber positioned within the patient gas stream. Mainstream capnograph, a cuvette containing CO2 sensor is inserted between the breathing circuit and the endotracheal tube. The infrared rays traverse the respiratory gases to an infrared detector within the cuvette. Therefore, CO2 analysis is performed within the airway. While in side stream capnograph, the CO2 sensor is located away from the airway. The tiny pump aspirates the gas sample from the patient's airway through a 6 feet long capillary tube into the main unit. So what are the advantages? The main advantages of mainstream capnograph: fast response time and suitable for neonate and children. Other: no sampling tube, no obstruction, no effect due to pressure drop, no pollution, no deformity of capnogram due to non-dispersion of gases. The main disadvantage is the earlier ones, they were heavy, so caused traction on the circuit. Newer sensors are lightweight. There is an increase in dead space. Long electric cord facial burns has been reported with the earlier version, but now eliminated with the new version. Sensor window may clog with the secretion, difficult to use in abnormal positions like prone position and non-intubated patient. Disposable, and they are expensive. Advantages of side stream capnograph: easy to connect, no problem with sterilization, can be used in awake patient, easy to use in unusual positions like prone position, and can be used in collaboration with simultaneous oxygen administration via nasal prong. The main disadvantage is there is a delay in recording of few seconds, 1 to 4 seconds, due to movement of gas from endotracheal tube to the unit. Sampling tube obstruction, water vapor pressure change affects CO2 concentration, pressure drop along with the sampling tube affects CO2 measurement, deformity of capnogram in children due to dispersion of gases in sampling tube. So what are the main differences between the mainstream and side stream capnography? CO2 sensor is inserted between the breathing circuit and endotracheal tube in mainstream, while in side stream it is located outside the breathing circuit. There is increased dead space in mainstream, minimal dead space in side stream. Mainstream one heavier, while the side stream one they are lightweight adapter. Waveform is real time in mainstream. There is a delay of 1 to 4 seconds in side stream. Difficult to adapt in non-intubated patients and in prone position in the mainstream capnography, while in the side stream it is easier. Other method by which we can measure CO2 are colorimetric CO2 detectors. These are disposable detector containing specifically treated litmus paper. Color change indicates CO2 concentration, used only in intubated patients, single use. Main disadvantage, easily impaired by moisture or secretions, required at least 6 breaths before analysis. There is no information about the actual value of CO2, and false positive result occur with esophageal intubation when it come in contact with the gastric air or gastric secretions. So what are the various uses of capnography? Changes in expired CO2 may reflect alteration in metabolism, circulation, respiration, airway or breathing system. Confirmation of correct placement of endotracheal tube and LMA, continuous monitoring during anesthesia and moderate to deep sedation in postoperative care unit transportation, gauging effectiveness of resuscitation during CPR, determining the adequacy of ventilation and perfusion and to identify various complications perioperatively, titrating the end tidal CO2 level in patient.
Hello.
Good morning, respected. Alteration in metabolism, circulation, respiration, airway or breathing system. Confirmation of correct placement of endotracheal tube and LMA, continuous monitoring during anesthesia and moderate to deep sedation in postoperative care unit transportation, gauging effectiveness of resuscitation during CPR, determining the adequacy of ventilation and perfusion and to identify various complications perioperatively, titrating the end tidal CO2 level in patient with suspected increase in intracranial pressure. So let's discuss the normal time capnograph. In normal capnograph, we have 4 phases, 2 angle, 2 axis. Phase 1. Phase 1, there is an initial stage of expiration when there is no rise in CO2 due to expiration of the gases from the anatomic and apparatus dead space. Phase 2, there is a sharp rise in CO2 concentration as mixing of alveolar gas and the dead space. Phase 3, maximum concentration at the end of alveolar plateau is referred as end tidal CO2. EtCO2 is the best reflection of alveolar CO2. Phase 0 is the inspiratory phase. When the patient inhales, there is a abrupt fall of CO2 to 0 and it remains to 0 until the next expiration. There may be additional phase 4, that is the terminal upstroke before phase 0, may be seen in pregnancy, obesity and children. About the angles, we have 2 angles, alpha angle and the beta angle. Alpha angle is between the phase 2 and phase 3. The normal value is 100 to 110 degree. There is an increase in the alpha angle seen in bronchospasm, VQ mismatch and the lung pathology. Beta angle is the angle between the phase 3 and phase 4. The normal value is 90 degree and there is increased in rebreathing and mechanical obstruction. So let's see various capnography graphs, which is important as an exam point of view. So whenever a capnography graph is given to you in exam, so you should see the systematic approach for its interpretation. Okay, so step 1 is the waveform present. Step 2, read the upper and lower values. Okay, so height and frequency. Step 3 is the waveform touching the baseline, that is 0. Step 4, how is the expiratory upstroke, that is very important, whether it is steep, sloping or prolonged. Step 5, how is the expiratory plateau, whether it is a flat, sloping, prolonged or notched. Step 3, how is the inspiratory downstroke, whether it is steep, sloping or prolonged. So few important capnography graphs. So can you identify this graph? This is the normal capnograph. This is the graph of esophageal intubation. In esophageal intubation, there is a gastric washout of the residual CO2. Therefore, there is an initial few upstroke of CO2 and subsequently there is the zeroing of the CO2. So this capnograph is showing low CO2 with normal plateau. So this is seen in hyperventilation, hypothermia or hypotension. In this waveform, we are seeing there is an increase in CO2 level. So increase in CO2 can seen with hypoventilation or with increased CO2 production. Can be seen in fever, release of tourniquet, pneumoperitoneum, adrenal response, malignant hypothermia, thyroid storm, convulsions. This is the graph of curare notch or known as curare cleft. There is a dip or indentation that can appear on the plateau phase of capnography waveform during controlled ventilation, specifically when a patient begins to breathe spontaneously or attempt to breathe against the ventilator. So this graph is of rebreathing. Rebreathing refers to the condition where exhaled CO2 is not adequately removed from the breathing circuit and it is inhaled again by the patient. This can be detected on capnogram via rising baseline or elevated end tidal CO2 that does not return to zero during inspiration. It is seen in exhaustion of CO2 absorber, malfunctioning of the expiratory valve. So here there is a sloping waveform or shark fin appearance. There is a loss of plateau. There is an increase in the alpha angle, specifically seen in asthma, bronchospasm, COPD, obstructed endotracheal tube. This is the leak in sampling line. In phase 3 there is a peak at the end. So this is the graph of pulmonary embolism or the disconnection. You see when there is a normal capnography and then there is a sudden drop in end tidal CO2 to zero or near zero. So this occur in tube disconnection, tube dislodgement, occlusion, kinking or massive pulmonary embolism. This graph is of cardiogenic oscillations, also known as the ripple effect. These oscillations are caused by pulsation of the heart and great vessels and their impact on airflow within the lungs, usually seen with ventilation with low frequency. So this graph is showing malignant hypothermia. So initially there is an inspiratory end tidal CO2 and baseline will be zero. But when there is increase in the production of the CO2 and exhaustion of the soda lime, so baseline will start rising and there is an increase in the concentration of the CO2 also. In this graph, we see the two peak in the phase 3. This will occur in the post one lung transplantation and severe VQ mismatch between the two lungs. So what is volume capnogram? In volume capnogram, CO2 concentration is plotted against the expired volume during a respiratory cycle. A volume capnogram has only expiratory segment. There is no inspiratory segment. And it is more sensitive than time capnogram in detecting the dead space. And it estimates both anatomical and the alveolar dead space. So what are the uses of capnography beyond operation theatre? Capnography nowadays has important role in cardiopulmonary resuscitation. Apart from confirmation of advanced airway placement, it monitors the effectiveness of chest compression and target value should be 10 to 20 millimeter of mercury. End tidal CO2 is an indirect indicator for cardiac output. Return of spontaneous circulation is most early indicated by rise in end tidal CO2. If end tidal CO2 less than 10 mm of mercury after 20 minutes of CPR associated with poor outcome, and if it is more than 20 mm of mercury, then there will be a strong likelihood of return of spontaneous circulation. Capnography has important role for procedural sedation like ERCP, electrophysiological study, interventional radiology. Capnography has been shown to prevent or detect these complications and treat early. And the changes in capnography forewarn of the respiratory depression in most of the cases of hypoxia. Capnography is important role in ICUs nowadays. Apart from the intubation confirmation, airway complications are more common in ICU than OT because of less use of end tidal CO2, more emergency condition, and less skill in airway management. According to the 4th National Audit Project report, mentioned that 75% of death or neurological complication could have been prevented by the use of capnography in ICU. It can be used for continuous monitoring in ventilated patient to see the response to therapy in bronchospasm. It is indirect assessment of cardiac output in neuro ICU We can monitor the end tidal CO2 and to avoid hyper and hypocapnia, which is detrimental to ICP and can cause secondary brain injury. And it is used in various tests for documentation of brain death. Various advances now available like smart capno line plus oxygen. It is the system provide accurate end tidal CO2 reading for non-intubated patient on supplemental oxygen. It reduces CO2 sampling dilution. It is ideal for the patient undergoing procedural sedation and patient controlled analgesia. Thank you and all the best.
Hello. Thank you, Dr. Sangeeta.
Thank you, ma'am.
Do you use portable capnography when you shift the patient to CT from trauma centers?
I am audible?
Sangeeta ma'am?
आवाज
Yes, yes.
Yes, ma'am.
Yes, ma'am. We use portable capnography, pulse oximetry during transportation normally.
Okay, okay. So, can you please give me the name of the company person who provides the portable capnography and its approximate cost?
Ma'am, that I don't know.
Okay.
Ma'am, I'll share the details with you, ma'am.
Okay, thank you, sir.
Okay,
Thank you.
thank you.
Ma'am, please introduce our next speaker, ma'am.
Yes. Good morning, Dr. Upma. Are you here?
Yeah, good morning, ma'am.
So, it's my privilege to introduce Dr. Upma Bhatia. She is professor in Department of Anesthesia at LHMC, New Delhi. She has many publications in national and international journals. She is PG supervisor and thesis reviewer, guest faculty in various forums. Her area of interest is ultrasound guided regional anesthesia and airway management. Welcome you, madam.
Thank you, ma'am. I want to thank Dr. Nisha ma'am and Team Appec to give me the opportunity to speak about point of care ultrasound to airway and lungs. Ultrasonographic assessment of the airway parameters has been shown to be better than clinical and demographic indicators in predicting difficult airway. Moreover, the identification of airway structures such as cricothyroid membrane or trachea in cases suspected of difficult airway can improve the procedural safety of cricothyrotomy and percutaneous dilatational tracheostomy. It can also help in predicting the correct size of endotracheal tube, more so in cases of neonates and infants, and also help in confirming the correct placement of the endotracheal tube. In addition to the linear and curvilinear probes, there is a small high frequency hockey stick probe that can be used for the airway assessment. The superficial structures can be examined by the high frequency linear probe. These structures include cricothyroid membrane, vocal cords, and epiglottis, whereas tongue base and hyomental distance can be assessed better by a curvilinear probe. The hockey stick probe can be used by the intraoral route for identification of the hyoid bone. 5 comprehensive focus views have been suggested for a detailed examination of the airway, and we will be discussing them one by one. In the suprahyoid view, the probe is placed just above the hyoid bone in the transverse orientation, and the hyoid bone can be identified as a hyperechoic inverted U-shaped structure followed by a posterior acoustic shadowing. When the probe is rotated to a sagittal orientation in the same view, we can see the acoustic shadowing produced by the ramus of the mandible and the acoustic shadowing produced by the hyoid bone on the right side of the screen. The tongue lies between these two structures. The tongue thickness can be examined in this view. Superficial to the tongue, the hypoechoic structures which are seen are the mylohyoid and the geniohyoid muscles. In the same view, we can assess the hyomental distance between the lower border of the mandible ramus and the cornu of the hyoid bone. We can assess this distance in neutral, extended, as well as ram neck positions. When the probe is brought a little bit down, this is the thyrohyoid view, and it is tilted a little bit cranially or caudally so as to delineate the small face sign, in which the eyes of the face are made by the strap muscles of the neck, whereas the face is made up by a hypoechoic strip, which is the epiglottis. The distance between skin and epiglottis can be estimated in this view. Epiglottis can also be assessed in the same view, but in a parasagittal probe orientation. The hyoid bone is traced till its caudal margin, and the epiglottis, thin strip of epiglottis is seen, and the distance between skin and epiglottis can be measured. Next is the thyroid view. Take care to apply sufficient amount of gel, as the probe placement over the prominent thyroid cartilage, especially in male patients, may be difficult. The thyroid cartilage is identified as a triangular structure deep to the strap muscles of the neck. Deep to the thyroid cartilage are the vocal cords, which can be seen as the hyperechoic triangular structures which form an isosceles triangle. Their identification can be facilitated by asking the patient to phonate. Arytenoids can also be seen in the same view. Next is the cricothyroid view, in which the tracheal lumen can be seen in the transverse as well as the sagittal orientation. For identification of the cricothyroid membrane, place the probe into the in a longitudinal orientation just above the suprasternal notch and slide it cranially. The ring of pearl-like structures can be identified, which are the tracheal cartilages, and suddenly there is an appearance of a hypoechoic structure which is more prominent and more anterior. This is the cricoid cartilage. When we slide the probe further anteriorly, another structure starts appearing from the left side of the screen. This is the thyroid cartilage. Between these two structures lies the cricothyroid membrane. This membrane can be identified and marked beforehand in patients in whom difficult airway is suspected. Next is the suprasternal view, in which the probe is placed in a transverse orientation just above the suprasternal notch, and trachea can be identified with the reverberation artifacts. Other structures seen are the thyroid gland, common carotid artery, and internal jugular vein. In the same suprasternal view, esophageal intubation can be identified when two air mucosal interfaces are seen with a double comet tail artifact, in contrast to the tracheal intubation, where a single air mucosal artifact with a single comet tail sign is seen. Lin et al. Have proposed a DARES protocol, in which they have proposed that distance between skin and epiglottis, hyomental distance, and its ratio in the neutral, extended, and ram neck position, along with tongue thickness, provide a comprehensive parameters which can guide the clinician towards the detection of a difficult airway. Now, coming over to the focus for the lungs, the ultrasonographic examination of lung not only provides for the diagnosis of respiratory pathologies such as pneumothorax, pleural effusion, or pneumonia, but also guides the clinician in providing the therapeutic intervention such as the placement of intercostal tube or drainage of the pneumothorax. It also helps in guiding for the administration of fluids and diuretics, as well as identifying the correct placement of endotracheal tube and weaning from the ventilator. Since healthy lungs are filled with air and surrounded by a bony ribcage, both of which do not conduct the ultrasound waves, the lung ultrasound depends upon detection of different ultrasound artifacts with unique signatures that allow the diagnosis of different lung pathologies. Curvilinear and linear probes are used. In addition, a phased array probe may be used, which is a low frequency, small footprint probe, which can be fitted into the between the two ribs in a single interspace. The machine is put in a lung preset, and the focus is adjusted at the level of the pleural line. Depth settings are adjusted as per the body habitus of the patient. Gain may be reduced if we want to visualize the superficial structures, whereas if we want to visualize the lung parenchyma, as in cases of consolidation, the gain needs to be increased. If the probe is placed in a perpendicular position on the anterior chest wall, we can see this type of structure. This is the acoustic shadowing of the two ribs and the intervening intercostal space. Whereas if the probe is tilted in a way that the ultrasound beams insonate the pleura at a 90-degree angle, we can see pleural line and the underlying reverberation artifacts, that are the A lines. Now, where to scan? If the operator places two hands on the patient's chest, starting just below the clavicle and excluding both the thumbs, there are two points can be seen. First is the upper blue point, which is the midpoint of the upper hand, and second is the lower blue point, which is the midpoint of the lower hand. There is a third point which lies on the posterior lateral chest wall and starts from the and is marked by the joining of the horizontal line from the lower blue point and the posterior axillary line. The parietal and distal pleura, they form a hyperechoic line which can be seen when the probe is placed in the anterior chest wall. This pleural line moves along with the underlying lung in case of normal lung tissue, and this is called as the lung sliding sign, which indicates that the underlying lung tissue is normal. This is the shadow produced by the ribs, and this is commonly known as the bat wing sign. The A lines are the reverberation artifacts, which are a normal finding in the lungs. They are produced when the ultrasound beams are trapped between two highly reflective surfaces, that is the ultrasound probe and the pleural line. The ultrasound machine interprets them as transverse hyperechoic lines, which are placed equidistant at a distance which is equal to the distance between the probe and the skin pleura of the patient. These move with the respiration, and presence of A lines is a normal sign in the lungs. Another artifact is the presence of B lines, which are seen when the ultrasound waves are trapped between the two reflective structures, that is the fibrous tissue and alveoli that are filled any kind of fluid and surrounded by air, as in cases of pulmonary edema. Normally, 1 to 2 B lines are present in one intercostal spaces. They extend from the pleural line and extend vertically till the end of the lung field. But if their number increases to more than 3 in one intercostal space, they are pathognomic of many lung pathologies such as pulmonary edema, ARDS, or pneumonia. In case of M mode scanning, we can identify the lung tissue by the rapid B scans are taken along with a single vertical line through the moving lung tissue, and ultrasound identifies the morphology of skin, subcutaneous tissue, intercostal muscles, pleural lungs, and the lung tissue. The pleural line and the lung tissue are the mobile structures, and they produce the seashore sign in case of normal lung. M mode is especially useful to detect when lung sliding cannot be produced by a good quality 2D image, and also in cases of cardiac arrest when the end-tidal carbon dioxide values are not seen, and it can confirm the placement of endotracheal intubation. This is a normal picture of M mode where a beach sign can be seen, whereas in case of pneumothorax, a barcode sign is seen. In cases of pneumothorax, air is filled between two layers of pleura, and the pleura and the underlying lung does not move. The barcode sign is seen by the white and black interrupted lines. See, in this picture, we can delineate that there is a normal moving lung tissue, and this is the junction of the immobile lung. This point is known as the lung point, and the visualization of a lung point is almost pathognomic of for pneumothorax. This small simplified scheme has been provided for identification of pneumothorax. In case we do not identify lung sliding, lung pulse, or vertical artifacts, pneumothorax is likely. But if lung point is identified, pneumothorax diagnosis is almost certain. E lines are another artifact that are seen in cases of subcutaneous emphysema. Now coming over to the flap point or the normal CP angle. Normal CP angle can be seen via the ultrasonic window of liver or spleen at the point of CP angle. The diaphragm is seen, and this is the normal costophrenic angle. Normally, this is filled by a mirror artifact, whereas in cases of pleural effusion, this is filled by an anechoic shadowing of the fluid. Normally, the lung tissue moves at the level of the CP angle and is seen to cover the underlying abdominal organs. Whereas in case of pleural effusion, this curtain sign is absent. Pleural effusion is best estimated with the patient in the sitting position because the effusion tends to settle in the dependent areas of the lungs. It has a high degree of sensitivity and specificity for detection of pleural effusion. Other signs that are seen in case of pleural effusion are the spine sign, which has a sensitivity of around 93% and specificity of 88%. Normally, the shadow of thoracic spine is not seen above the level of the diaphragm because air-filled lung tissue is present here. But in case of pleural effusion, the shadow of lung tissue, the shadow spine can be seen because there is a fluid which forms a window for the spine to be seen. Other signs that are seen in case of pleural effusion are the quad sign and the sinusoid sign. Now, jellyfish sign is again seen in case of pleural effusion when the compressed lung tissue floats like a fish into the sea of pleural effusion. Plankton sign is seen, which indicates the hyperechoic small exudate-like things in the pleural effusion. We can also calculate the size of the pleural effusion by ultrasonography by a formula given by Balik et al. They said that the maximum distance between the lung base and the diaphragm can be estimated in millimeters and multiplied by 20 so as to give the estimated volume of pleural effusion. A volume of more than 1 liter has been found to be clinically significant. Now for the detection of pneumonia. As the lung tissue loses its aeration, the ultrasound can visualize the lung parenchyma. Normally, when the aeration is maintained, we can see the normal A lines, but gradually with the loss of aeration and the alveoli, as they get filled with the fluid or pus or inflammatory debris, we can see the B lines. Sometimes the B line number may increase and they become the confluent B lines and are called as the lung rockets. When the inflammatory pathology increases and the pleural line gets disintegrated by the inflammation, it is seen as the shred sign, and ultimately the lung tissue gets consolidated and this is known as the pulmonary hepatization or tissue-like sign. Ultrasound has a sensitivity of around 90% and specificity of 98% for detection of pneumonias. Distinction between bacterial and viral pneumonias can also be made, where in viral pneumonia, the consolidation areas are usually multiple, bilateral, and small and subpleural in location, and more than 3 confluent or pathological B lines are seen. Whereas in case of bacterial pneumonias, single unilateral large consolidation are seen associated with air bronchograms. Air bronchograms are seen where the air gets trapped into the alveoli distal to the airway obstruction, and they are seen as the hyperechoic circles. They may be static or dynamic and are usually present in atelectasis or in cases of consolidation as associated with pneumonia. In cases of atelectasis, if lung sliding is absent, they indicate atelectasis due to obstruction. And when lung sliding is present, they indicate compression atelectasis when the air has been absorbed completely. Note that lung pulse and B lines may be present in these cases. Air bronchograms can be present as a static and dynamic. In case of static, we can also use color Doppler, and if color flow is seen, then it is usually due to consolidation. If the color flow is absent, then it indicates atelectasis of the lung. Whereas dynamic air bronchograms are usually present in consolidation and indicate ongoing lung flow. This is the picture of dynamic air bronchograms. The distinction between atelectasis and pneumonia can be further improved if we combine the lung ultrasound with a simplified clinical pulmonary infection score, which includes parameters like temperature, total leukocyte count, tracheal secretions, PF ratio, and chest X-ray. These parameters are elevated in cases of pneumonia. The P lines are pathognomic for detection of pulmonary edema. The hallmark finding is more than 3 or confluent pathologic P lines per interspace, and then their number is directly correlated with the degree of loss of aeration. It should be noted that the lung sliding is preserved in cases of pulmonary edema, and pathological B lines are bilateral and homogeneous. This picture shows the confluent B lines. The differential diagnosis of pathological B lines includes pneumonia, ARDS, and lung contusion, which can be differentiated from pulmonary edema by uniform appearance, and homogeneous nature of the B lines. Whereas in cases of pathologies such as interstitial lung disease, idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, and acute interstitial pneumonia, the pleural line is fragmented and vertical subpleural pattern is seen on the ampoule. Ultrasound has a great role in the management and diagnosis of ARDS also. Nowadays, a new global definition of ARDS has been put up where ultrasound by a well-trained operator has been recommended as one of the imaging modalities to diagnose bilateral opacities in ARDS. Lung ultrasound is performed to know the lung ultrasound score in cases of ARDS. A score of 0 is given when the lung tissue is normally aerated, and a score of 3 is given when the lung parenchyma is completely consolidated. The scores of the various lung regions examined are then added, and the calculation of lung ultrasound score is used as a marker to detect response to the intervention such as lung recruitment and ventilation in the prone position. Now coming over to fluid resuscitation, although presence of B lines suggests fluid overload and detection of pulmonary edema, but since they are non-specific in nature, so other indicators of dynamic fluid responsiveness must be used to guide fluid therapy along with the lung ultrasound. How to distinguish between CHF and COPD exacerbation? In case of CHF, homogeneous B lines may be seen in case of lung ultrasound along with the presence of pleural effusion, whereas in cases of COPD exacerbation, the predominant finding will be multiple A lines, and sometimes the bulla or pneumothorax may also be identified. In case of weaning from the ventilator, if during a spontaneous breathing trial, pulmonary edema appears, which is diagnosed by increase in the B lines, it can point towards an failure of weaning. Multiple parameters have been suggested for a systematic examination of the lung ultrasound. These include the protocol and the false protocol. And there is another framework has been proposed, which is the IAIM framework, that is the indication for lung ultrasound, acquisition of an image, interpretation of an image, and medical intervention for the pathology detected. To conclude, focus can be learned by critical care, pulmonary, and anesthesia providers. But always ensure patient consent, privacy, and comfort throughout the procedure, and document and capture your findings. In case you are unsure of any findings, do not be shy of seeking help. And we know that variety of lung ultrasound protocols exist, which provide a structured approach to the diagnosis. Always use focus as a part of wider clinical examination. That's all. Thank you. Now,
Thank you so much, Dr. Upma. Dr. Bhavna and Dr. Madhis are here. Ma'am?
Yes, madam. I'm here. Surprisingly, there's no question in the chat box, so there's nothing to discuss as of now.
Yes, ma'am. There are no questions in the chat box from the delegate chat box also. There are no questions.
Okay.
I hope
Okay.
the
Nice
lecture was.
academic session. Thank you.
Thank you, ma'am.
Dr. Upma's talk was really very enlightening. And I think ultrasound is now to be used in routine practices in OT also. And it was a great talk, Dr. Upma.
Thank you, ma'am. Thank you. In fact, we are nowadays increasing the use of ultrasound. We are trying to use it for airway assessment as well as early detection of complications.
This is what I also wanted to ask. Are you assessing the tube size also with like ultrasound in routine practice?
Yeah, there is a study going in our department. They are doing it for, it has, I think, now completed. They were doing it for pediatric patients for assessment of tube size.
Okay. For pediatric patients,
we will be we will be doing one study for airway assessment using ultrasound.
Okay. Great talk. Thanks a lot.
Thank you, ma'am. Thank you.
Even I agree. Dr. Upma's lecture was very enlightening, ma'am.
Thank you.
Thank you to all the speakers, Dr. Upma, Dr. Anjane, Dr. Sangeeta. Thank you, Madhvi ma'am, and thank you, Bhavna ma'am. for this
Okay.
great session. These are very basic topics, but day to day we use these topic very frequently. And for the short notes also, this topic is very important.
They are backbone, and for PGs, definitely they are important.
Yes, ma'am. Definitely.
Thank you.
Thank you so much,
Thank
ma'am.
you. Thank you.
So before the next, hello, Dr. Madhvi.
Okay, बैठ जा तू, टेक्निक पे आ गया।
So before the next long case, which is total thyroidectomy, let us take a quick tea break. Before tea break, we have two MCQs. This is quiz time. First question is small face sign on USG airway. Small face sign on USG airway is diagnostic of epiglottitis in sagittal view, epiglottitis in transverse view, hyoid bone in suprahyoid view, and hyoid bone in thyrohyoid view. Next question is, what is the normal value of alpha angle in capnography? In degrees, you have to tell what is the normal value of alpha angle degree in capnography. A 90, B 100 to 110, C 120, and D 80. So we'll take a quick break for tea and we'll come back very soon with a long case. Thank you, everyone. Within 10 minutes, we'll come back. So I hope after tea break, everyone is feeling fresh. The answers for the MCQs I have asked before tea. Small face sign on USG airway. The answer is epiglottis in transverse view. The answer is epiglottis in the transverse view is small face sign on USG. Second question, the normal value of alpha angle in capnography in degrees is 100 to 110 degree. Okay. So these are the answers. Congratulations who guessed it correct. Next, we'll start with a case. It's a long case in which we'll discuss 36-year-old female with long-standing neck swelling posted for total thyroidectomy. For this case, I will invite Dr. Munisha. Dr. Munisha Agarwal, ma'am can you please show me the CV of ma'am? Thank you. Dr. Munisha is Director Professor and Head President of ISA Delhi. Ma'am is head of ma'am is head in LNG. MAMC and LNJP, an associated hospital. Her areas of interest is fibroscopy and difficult airway management, BLS and ACLS, pediatric anesthesia, anesthesia for bariatric surgery, teaching and learning, medical oxygen infrastructure, logistic and management. We welcome you, ma'am.
Thank you. Am I audible?
Yes, ma'am.
Okay. So Dr. Velesh will be presenting his case first of all. So Dr. Velesh, you can start
Okay, ma'am.
with the
Good
history
morning.
of your patient. Good morning.
Good morning, ma'am.
Can I request IT guy to please start the timer for the case?
My case
Yes,
is a
ma'am.
36-year-old female presented to ENT OPD with chief complaints of painless swelling in front of the neck since 8 years and difficulty breathing on lying down flat since 3 weeks. History of present illness. Patient noticed a swelling in front of the neck 8 years back, which was insidious in onset, gradually progressive, first time noticed by self while bathing on the left side of the neck as a pea-sized swelling and has extended to other side to cover the whole front side of the neck now. It moves with deglutition. Difficulty breathing down flat since 3 weeks, which is relieved on left lateral position or head up with pillow support and worsens while sleeping. She also developed weight loss, palpitations, and heat intolerance. No dyspnea in upright posture, no stridor, hoarseness, or change of voice, dysphagia. No pain, redness associated with swelling. No history of discharge or sinus from the swelling. No history of fever, URTI. No other swellings elsewhere. Past history, no alleged history of diabetes mellitus, hypertension, COPD, bronchial and any malignancy. No history of any previous hospitalization, operative intervention, radiation therapy, or blood transfusion. No history of any drug allergy. Treatment history, patient is on tablet neomercazole 15 mg OD and tablet propranolol 20 mg BD since 3 months. Family history, no history of neck swelling or similar complaints in the family. No of tremor, anxiety, depression, increased decreased sleep, lethargy, weight gain, diarrhea, constipation, hair loss, cold intolerance, protrusion of eyeball, double vision, swelling of lip, or dry eye. No visual abnormality, abdominal pain, joint or bone pain. Able to perform activities of daily living such as household cleaning.
Yes, it's
Personal history, my is a homemaker by occupation. a resident of Bareilly, Uttar Pradesh, India, married, dietary habit regular vegetarian, no substance abuse, bowel and bladder habits normal, sound sleep, prefers to lie in left lateral position, propped up with pillows. Socioeconomic status, modified Kupus-Stami score is lower middle class. Menstrual history, she achieved menarche at 12 years of age. Her last LMP was 4 July 2025. Cycles are normal in duration and blood loss, no menstrual abnormalities. Marital history, non-consanguineous marriage, P2L2, obstetric history. First pregnancy conceived spontaneously, antenatal and postpartum with full-term normal vaginal delivery. She delivered a female baby of 2.8 kgs, and development milestones of the baby were normal. In second pregnancy, she conceived spontaneously, antenatal and postpartum was uneventful. She delivered at full term through normal vaginal delivery a male baby of 2.6 kgs, and development milestones were normal. In general physical examination done under broad daylight in sitting position after obtaining.
Dr. Velish, we'll just, okay, you can complete your examination. Just go ahead.
And verbal constant, conscious oriented and cooperative. Average body built and nourished. Her height was 150 centimeter, weight is 60 kg, and BMI is 23.5 kg per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Skin, hair, nails, tongue are normal. Eye signs were absent. Vitals, pulse is 80 per minute, regular rhythm, no radial radiofemoral delay, normal in character and good volume. Sleeping pulse rate was 72 per minute, no apex pulse deficit, carotid.
Transmission. Hello, I cannot see your screen, Velish. Audio is also not there.
Ma'am, Dr. Shailesh is not available at this moment. He left, I think.
Velish.
Sudhir, please ask him to join again.
examination, facial dysplasm, no retrognathia, bilateral nasal passage is patent, no deviated nasal septum, mouth opening is more than 3 finger breadth, interinstitutional distance is 4.5 centimeter, tongue, no macroglossia was observed, dentition, no loose tooth dentures, Malampatti grading was, modified Malampatti grading was class 2, palate normal, neck movements, normal flexion and extension, neck circumference was 36 centimeter. Okay, slide again.
Velish, go ahead with your examination.
Yes, ma'am. Ma'am, thyromental distance and hyomental distance could not be measured due to large thyroid swelling. Sternomental distance was 13.5 centimeter. Upper lip bite test is grade 2. Submandibular space was soft. Cricothyroid membrane not appreciated. Back and spine, no abnormality detected. Centimeter with uneven surfaces over the lateral aspect of the neck between the two sternocleidomastoid muscles. Upper border visible, lower border not visible, lower border reaching beyond sternal notch. Moves with deglutition, doesn't move. Normal, no sinus. Mass of 9. Border was 3 centimeters.
The transmission is not proper. I cannot hear or see any change of slides, etc.
Monisha ma'am, we have to just wait for 2 minutes. We will just wait for 2 minutes. We are having some technical glitches. As soon as we sort it out, we'll resume again.
The swelling moves with deglutition, not fixed to skin. Trachea palpable, displaced to right. Carotid pulsations present bilaterally. No bruit. Cocker test negative. Berry sign was negative. On percussion, there is dull note over 2 centimeter on manubrium sterni. On auscultation, no bruit here over the swelling. Systemic examination, respiratory system examination on inspection, trachea palpable, displaced to right. No use of accessory muscles, chest bilaterally symmetrical. No dilated veins, scars or swelling. On palpation, chest expansion normal and symmetrical. No tenderness, no crowding or whitening of ribs. On percussion, dull note here over 2 centimeter on manubrium sterni. On auscultation, normal vesicular breath sounds bilaterally. Forced expiratory time was 4 seconds. On
Dr.
cardiovascular system,
any positive finding in any of other systemic examination?
ma'am,
Any
only in
positive,
respiratory system there. Yes, ma'am.
Any
In
respiratory system you have
trachea.
covered?
Yes, ma'am.
Respiratory
No.
system you have told us. Any
Yes.
other remarkable finding in any other systemic examination?
No, ma'am. Systemic
No.
examination
Okay.
normal.
All right. Okay. So based on your history and examination, what is your provisional diagnosis of this patient?
Ma'am, my provisional diagnosis of a patient is 36-year-old female presented with large thyroid swelling with tracheal compression and deviation with retrosternal extension and with symptoms of hyperthyroidism controlled on antithyroid medication and beta blocker with no comorbidities suggestive of large multinodular goiter and scheduled for total thyroidectomy.
So if I were you, I will give my provisional diagnosis as 36-year-old female with large thyroid swelling with hyperthyroidism. That's it. Okay. Rest of the
Okay.
things you need not say unless and until you are asked for. Okay. So why do you say this
Okay, ma'am.
midline swelling is a thyroid swelling based on your history and examination?
Ma'am, because the swelling moves with deglutition.
Okay.
Uh,
All right.
yes,
Anything
and ma'am,
else?
it is between the it is between the two sternocleidomastoid muscles. It is very typical of thyroid swelling.
Okay. Speak loudly. Speak loudly. Okay. So you have said that your patient is hyperthyroid in your diagnosis. What are the points in favor of hyperthyroidism in the history and examination of this patient? Mainly in the history.
Ma'am, in history, the patient had symptoms of unintentional weight loss, palpitations, and heat intolerance. And in science, ma'am, the thyroid was large, 9 into 6 centimeter, and ma'am, there is a tracheal deviation, compression, and on palpation, the trachea is bosselated surfaces. Bosselated surfaces suggest, ma'am, that the trachea, then the thyroid has multinodular consistency, which is a
Okay.
present in hyperthyroid.
Those are not signs of hyperthyroidism per se. All right. So, okay.
Yes, ma'am.
What are the causes of hyperthyroidism? What all can lead hyperthyroidism in the patient?
Ma'am, Graves' disease is the most common cause of hyperthyroidism. Toxic adenoma, toxic multinodular goiter, TSH secreting pituitary adenoma, struma ovary, and ma'am, choriocarcinoma can also lead to goiter. And ma'am, exogenous iodine uptake.
Okay. All right. So these are the causes of hyperthyroidism. And you elicited some eye signs for your patient. Okay.
Yes, ma'am.
So one of the signs was Dalrymple sign. What is that sign?
Ma'am, Dalrymple sign is infrequent blinking. The patient gave a wide starey look, and the upper sclera is visible due to upper lid retraction.
Okay. You also talked about Cocker's test and Pemberton's test. What are these two tests done for?
Ma'am, Cocker's test and Pemberton test are done to rule out retrosternal extension of the thyroid gland and any mass effect which is possessed on other structures like trachea, esophagus, and other vascular structures. In Cocker's test,
Yeah. What do
yes,
you do
ma'am.
in Cocker's test?
Ma'am, in Cocker's test, we slightly push the lateral, compress the lateral lobe of the thyroid gland, and the patient will have stridor in Cocker's positive. This means that the thyroid gland is compressing the trachea.
Okay. So should you actually be, is it advocated that you should be performing Cocker's and Pemberton's test?
No, ma'am. These tests
Why not?
are not performed nowadays because these tests are provocative tests, and this can lead to dyspnea, stridor, and respiratory distress in the patient. So we avoid them.
Okay. So can you, are there any simpler methods of diagnosing retrosternal? What are the points in favor of retrosternal extension of thyroid mass in your patient?
Yes, ma'am. Ma'am, there are symptoms such as dysphagia, dysphagia on lying down, and deviation of trachea, and ma'am, hoarseness of voice,
So
stridor.
patient gets dyspneic on lying down, then you cannot reach below the swelling.
Yes,
Isn't
ma'am.
it?
Yes, ma'am. Yes, ma'am.
Very important. Then there is a dull note, percussion note over the
Manubrium
manubrium.
sternum.
That's what you said. So these
Yes,
all
ma'am.
tell us that patient has retrosternal extension. How would you confirm this? Any investigation?
Ma'am, I will do imaging, CT scan, MRI scan.
Okay, so CT and MRI are better, these tests, non-invasive tests to diagnose retrosternal extension. So now
Yes,
this is
ma'am.
your patient and patient is scheduled for total thyroidectomy. So how will you investigate your patient?
Ma'am, I will order a complete blood count because my patient is, I will order complete blood count. I will order a coagulation profile.
So complete blood
Uh,
count, what is the significance of complete blood count?
Ma'am, because my patient is on anti-thyroid medication, neomercazole, it causes thrombocytopenia and agranulocytosis. And
Okay.
and ma'am, as my patient has large thyroid mass and there can be major blood loss. So to estimate the maximum allowable blood loss, I will do a baseline hemoglobin.
Okay, what else? What other investigations you will do?
Ma'am, coagulation profile,
Okay.
TF thyroid function test, serum electrolytes, random blood sugar, KFT, LFT, chest X-ray, ECG, X-ray neck, AP lateral, CT scan, MRI,
So
indirect
what
laryngoscopy.
okay, what are the changes you are expecting in ECG in this patient who is on
Ma'am, in
treatment for
ECG,
hyperthyroidism also?
ma'am, I'm expecting sinus tachycardia, any
What else can be seen in ECG? Speak loudly, your voice is
ventricular
clear.
premature. Ma'am, ventricular premature complexes, atrial fibrillation, dysrhythmias, tachyarrhythmias, ST elevation,
Okay,
QT shortening.
all right. And what are you expecting in X-ray neck? Why do we do both the views, AP and lateral?
Ma'am, the AP view is used to assess that any tracheal deviation and any calcification of thyroid mass, and lateral view is done to see any compression on trachea or esophagus.
Okay. So you mentioned about indirect laryngoscopy also. What is the importance of doing IL preoperatively?
Ma'am, it is used for preoperatively to rule out any recurrent laryngeal nerve palsy, and it is for medical legal documentation.
Okay, so you see the mobility of the vocal cords. Why particularly recurrent laryngeal nerve? What is the nerve supply of thyroid gland?
Ma'am, the nerve supply, the sympathetic nerve supply comes from superior, middle, and inferior cervical sympathetic ganglion, and parasympathetic nerve supply comes from superior laryngeal nerve and recurrent laryngeal nerve.
So why recurrent laryngeal nerve is prone to injury?
Ma'am, recurrent laryngeal nerve is prone to injury uh, because the inferior thyroid artery is in close proximity to the recurrent laryngeal nerve, and during surgery it can be injured. So along with it, the recurrent laryngeal nerve can also be injured.
Okay. So plus recurrent laryngeal nerve is one of the very peculiar nerve that it has got a very long course. It goes down
Yes.
and then curves upwards and then goes into the tracheal esophageal groove. Okay, that's why it's
Yes, ma'am.
more prone to injury, and its proximity with the thyroid artery also. So now
Yes, ma'am.
you have investigated your patient, any schedule for total thyroidectomy. What are your major anesthetic concerns in this patient?
Ma'am, major anesthetic concerns are that the patient is a difficult airway case. It is a
Okay.
shared airway surgery, and ma'am, there
So
can
one,
be
it is because of the anatomical mass effect of the thyroid swelling.
yes, ma'am.
Okay, so it's a difficult airway because it is compressing on the trachea, it is deviating the trachea, and
Yes, ma'am.
it has got a retro-sternal extension also. All right.
Yes, ma'am. Yes, ma'am.
So problems due to this difficult airway.
Difficult
Second,
airway. Second, ma'am, the surgery is shared airway surgery. We are sharing the airway with surgeons. And third is,
okay.
ma'am, there can be adverse
So
interop
if you're
events.
sharing the airway, with these surgeons, so what? What are the problems in such kind of surgeries?
Ma'am, in such kind
What are
of
the
surgeries,
anesthetic problem?
ma'am, there can be displacement or dislodgement of our endotracheal tube, which can be fatal to the patient. And
Okay, so because you and the surgeons are working at the same place, so there are high
yes, ma'am.
chances of your tube getting kinked, compressed, or disconnection. Okay, what else? Other concerns?
Other ma'am, there can be intra-op adverse events such as cardiac events and thyroid storm. And
No, third major concern is because of
Ma-
the
major
thyroid
blood loss.
dysfunction, the hyperthyroidism that the patient has. Okay.
Yes,
So
ma'am.
first anesthetic concern is because of the thyroid swelling leading to difficult airway because of tracheal deviation, compression, and intraluminal narrowing of the trachea. Second is,
Yes, ma'am.
as you said, the surgical problems, you're sharing the airway with the surgeons. Okay.
Yes, ma'am.
Third is because signs and symptoms because of the thyroid dysfunction. In your patient, she has hyperthyroidism. Okay.
Yes, ma'am.
And any other concern?
Ma'am, the thyroid is thyroid is a large swelling, so there can be major blood loss. So blood transfusion
Major
can
blood
be.
loss. And
Yes, ma'am.
another is any other comorbidities that patient has. And you
No,
must
ma'am.
understand that because of thyroid dysfunction, for example, in hyperthyroidism, patient may have systemic end organ damage or
Damage.
problems. For example,
Yes.
hyperthyroidism can lead to dilated
Cardiotoxin.
cardiomyopathy.
Yes, ma'am.
Cardiomyopathy. So if your patient gives signs and symptoms suggestive of that, you do need to investigate patient on that account also. For example, if patient was having cardiomyopathy, I would like to go in for a 2D echo
2D echo.
also.
Yes, ma'am.
Okay. So these are our anesthetic concerns. Now, what is your anesthetic management plan in this patient who's scheduled for total thyroidectomy?
Ma'am, as my patient is a difficult airway, I will go for awake fiber optic nasotracheal intubation, followed by general anesthesia and controlled mechanical ventilation.
Okay. So keeping in view all the anesthetic concerns of your patient, your plan is fiber optic guided awake nasal intubation followed by general anesthesia with controlled ventilation. Okay. So what pre-op orders would
Yes,
you be writing for this patient when you visit your patient a day prior to the swelling? In anesthetic concerns, one of the
ma'am, I will
important things that, just a minute, Vilesh. In the anesthetic concerns, one of the major thing is
okay, ma'am.
that patient will be taken up for elective surgery only when patient reaches a euthyroid state. Isn't it? So you have to preoperatively prepare your patient and work towards it. Okay. So what are the anti-thyroid drugs your patient is taking?
Ma'am, my patient is taking neomarcasol and beta blockers propranolol.
Why the patient is on propranolol?
Ma'am,
Why
because
beta blockers are
propranolol gives
prescribed to
simple.
hyperthyroid patients?
Ma'am, because propranolol will give symptomatic relief to the patient, and it also inhibits the peripheral conversion of T4 to T3.
Okay. All right. So, for how long your patient needs to take these drugs so that a euthyroid state is reached? You cannot take up the patient for elective surgery unless and until patient becomes euthyroid, isn't it?
Yes, ma'am. Yes, ma'am.
Speak loudly, speak loudly. Speak
Ma'am,
closer
at
to the
least
mic
4
and
to
loudly.
Ma'am, at least 4 to 6 weeks, he or she have to take anti-thyroid medications to become euthyroid before elective surgery.
So preoperatively, when we investigate the patient, patient should have normal TFT. So what
Yes,
is the
ma'am.
normal level of TSH?
Ma'am, a normal level of TSH is 0.5 to 5 milliunits per ml, and free T3 normal level is 10 to 26 picogram per ml, and free T4 is 10 to 26 picogram per ml, and free T3 is 2.3 to 4.2 picogram per ml.
Okay. So now tell us what pre-op orders would you be writing for this patient?
Ma'am, I will instruct him I will tell him about NPO guidelines: 2 hours for clear liquids, 6 hours for light meal, and 8 hours for fatty meals. I will take written and informed high risk consent. In high risk consent, I will explain the patient that his airway is difficult, and also there can be need for post-op mechanical ventilation, and I will also tell about that there can be
NPO consent next.
Ma'am, I will instruct him to continue anti-thyroid medications and beta blockers.
Okay, next.
And instruct surgeon to arrange for blood and blood products. And I will
Anything else?
also console my patient about awake fiber optic intubation
Okay.
preoperatively.
That is very important. You should explain the entire preparation procedure and the procedure, and ensure him that it will be a painless procedure. Okay, and that full cooperation is required from the patient's side. All right.
Yes, ma'am.
Anything
Yes.
else that you have forgotten? This is a patient of difficult airway, isn't it?
Yes, ma'am.
Would you like to give aspiration prophylaxis to your patient?
Yes, ma'am. Anti-aspiration prophylaxis with tablet Pentop 40 mg HS and 2 hours before surgery.
Okay. All right. So these are the preoperative orders for. So next day the patient has come to the OT. What about any anxiolytic drug? Would you like to give?
Ma'am, I will avoid any anxiolytic drugs because I don't want to lose airway, and I want to keep the airway patent. And sedatives can cause decrease in patency of airway due to fallback of thyroid due to decreased pharyngeal tone.
Okay. So you may avoid sedative anxiolytics in your patients if airway obstruction is a concern. Otherwise, if your patient is anxious, you can give mild sedation with drugs like
Yes, ma'am.
alprazolam 0.25 milligram HS. All right.
Yes, ma'am.
So next day,
Yes,
your
ma'am.
patient is now in the OT. So your plan is awake fiber optic guided intubation. How will you prepare your patient for this?
Ma'am, on the morning of surgery also, I will console my patient what he will expect from this management. And in the pre-op holding area, I will put an IV access and I will give injection injection glycopyrrolate 0.2 mg IM. It will act as an anti-CL-GOG.
Okay, next.
Ma'am, then I will topicalize the airway. In topicalization, I
How
will
will you
nebulize.
topicalize the airway?
Ma'am, I will nebulize the patient with 4% of 4 ml lignocaine. And ma'am, I will also do the nasal lignocaine spray 10%, in which point each spray is
Suppose
0.1.
you listen just a minute. If you have in the pre-op holding area, you have nebulized your patient and you have given intramuscular glycopyrrolate to your patient. Is it?
Yes, ma'am.
Then you will transfer your patient inside the operation theater. All rest of the procedures should ideally be done inside the OT. So now
yes,
your
ma'am.
patient is come inside the OT. So I presume that you have prepared your OT, you have prepared your difficult airway card, machine is checked, everything is done. All right?
Yes, ma'am.
So now tell me, what else would you do for the patient? Patient is lying down on the OT table.
Ma'am, first of all, I will put all the 5 ASA monitors.
What are those monitors you'll put?
Ma'am, ECG, SpO2, ETCO2, temperature, and NIBP.
So in the beginning, you can only put ECG, SpO2, and NIBP. Rest of the monitors will be can be put post induction, isn't
Yes,
it?
ma'am. Yes, ma'am.
Yes. What else will you do? You will secure an IVP.
Yes, ma'am.
You will
Ma'am, in
start
pre-op.
fluid.
And ma'am, then I will topicalize the airway with 10% lignocaine. I will spray 15 to 20 times, and each
Where will you spray?
each spray
Where will you
contains.
spray? What are you anesthetizing?
Ma'am, I'm
Which area?
anesthetizing the posterior pharyngeal wall. Posterior pharyngeal wall, ma'am.
Yes. Okay. So 10 to 15 sprays. All right. So what is the safe dose of topical lignocaine?
Ma'am, 9 mg per kg.
Okay. So your patient is 60 kilograms. So the safe dose
Yes,
will
ma'am.
be 540
540 mg.
milligrams. Okay. So you have to keep on adding all these aliquots of drugs that you are using for each topicalization. So you have
Yes,
done
ma'am.
posterior pharyngeal wall. What about how will you prepare your nasal cavity?
Ma'am, before nasotracheal intubation, nasal cavity should be anesthetized and vasoconstricted. So to anesthetize the nasal mucosa, I will put 2% lignocaine jelly, and for vasoconstriction, I will put xylometazoline in drops.
Okay. Anything else you want to do?
Ma'am, viscous gargle. I will instruct the mouth and then gargle and then spit it in the kidney tray. Don't swallow it.
What are you anesthetizing by doing the gargles?
Ma'am, I'm anesthetizing a posterior pharyngeal valve and epiglottis.
You have already used oropharyngeal sprays, haven't you?
Yes, ma'am.
Then, so if I were doing oral fiber optic or oral awake intubation, I would like to anesthetize the posterior 1/3 of the tongue along with the posterior pharyngeal wall, isn't it?
Yes,
The
ma'am.
territory supplied by the glossopharyngeal nerve.
Yes, ma'am.
So then I may use gargles also. Okay. So
Okay,
all
ma'am.
right. So proceed. What kind of tube will you use for intubation?
Ma'am, I will use flexometallic armored tube uh, in this case.
What number? What diameter?
Ma'am, 7.0 millimeter internal diameter. And I will railroad
Okay.
it on fiber optic bronchoscope.
Okay. Any other kind of anesthetic will you be using during fibroscopy?
Yes, ma'am. I can use the Sego technique, spray as you go technique.
Okay, we will not go into the details. So I presume that you have intubated the trachea of the patient with this reinforced tube, and you have checked the placement of your tube. How will you check the placement of the tube?
Ma'am, I will check the placement of my tube by bilateral air entry should be equal, and ETCO2 should be confirmed on the monitor.
Okay. So what else? Now your patient is intubated. How will you proceed further?
Ma'am, now I will give induction dose fentanyl, and then I will give induction agent in the form of IV thiopentol, and then I will give muscle relaxant vecuronium, and I will maintain the anesthesia with the inhalation agent sevoflurane along
So
with
for induction, you have used, just a minute. Don't be in a hurry. Okay. So for
Yes, ma'am.
induction, you have used thiopentone. Why can't I use propofol?
Ma'am, because
Why
thiopentol,
particularly you have used thiopentone?
ma'am, because thiopentol has added benefit that it prevents the conversion of T4 to T3, peripheral conversion. So in
Okay.
hyperthyroidism,
Can
it is
we use
beneficial.
propofol? Can we use propofol?
Yes, ma'am, we can use propofol.
Okay. So then you have given fentanyl and a muscle relaxant. Okay.
Yes, ma'am.
Right. Any additional now monitoring would you ensue now the patient is induced? General anesthesia is induced?
Yes, ma'am. I will do neuromuscular monitoring. And for recurrent laryngeal nerve monitoring, I will do electrophysiological.
Just a minute, Velesh. Tell
Yes,
us the basic things, what you do, everything in the OT. Okay. So
yes, ma'am.
I will put ETCO2 monitor, temperature monitor. Okay.
Yes, ma'am.
These are the basic things that you do to monitor your patient for any surgery, isn't it?
Yes, ma'am.
Neuromuscular junction monitor. Why in particular you want to put NMJ monitoring? In this
Ma'am,
case, you do that for every case.
no, ma'am.
So why
Ma'am,
in this case you are asking for neuromuscular junction monitoring?
ma'am, because this is a large thyroid mass and there is high possibility of injuring recurrent laryngeal nerve. So to monitor the activity of recurrent laryngeal nerve, uh, there is need for intact neuromuscular junction, and that is why to guide the muscle relaxant dose, we will
How
use a
neuromuscular
neuromuscular
junction
monitoring.
monitor? Just a minute. How neuromuscular junction monitoring will tell you injury to the recurrent laryngeal nerve?
Ma'am, it will not tell the injury to the recurrent laryngeal nerve, but the recurrent laryngeal nerve investigation of the injury require an intact neuromuscular junction. So during when the surgeon will stimulate the recurrent laryngeal nerve, there should not be any muscle relaxant.
Wait.
Okay.
You are confusing two issues. Another method of monitoring recurrent laryngeal nerve by the surgeon is use of electrophysiological monitoring. Okay? Isn't it?
Yes, ma'am. Yes, ma'am.
For that, you
Yes,
must
ma'am.
use a specialized kind of endotracheal tube, which has electrodes embedded in its wall. All right? Electrophysiological
Yes,
monitoring
ma'am.
can be done only with that kind of tube. You have not used that tube in your patient, isn't it?
Yes, ma'am. Yes, ma'am.
Yes or no? So
No,
you
ma'am. I haven't.
should answer listen to the question carefully and then answer whatever is being asked. Okay? Don't volunteer
ma'am.
information unnecessarily. All right?
Okay, ma'am.
So when we are doing electrophysiological monitoring, then you need to, do away with the effect of muscle relaxant that you have used. All
Yes,
right.
ma'am. Yes,
So
ma'am.
that when the surgeon touches the nerve accidentally, so the signals, the electromyographic signals are transmitted and it gives an audible alarm that he is touching the recurrent laryngeal nerve. That's how the nerve is monitored electrophysiologically. Okay?
Yes,
All
ma'am.
right. So how will
Yes,
you
ma'am.
maintain anesthesia in this patient?
Ma'am, I will maintain anesthesia by inhalation agent sevoflurane 2% and with oxygen and
Oxygen,
night.
nitrous,
Yes, ma'am.
sevoflurane. Okay.
And ma'am, top
What
up of
else?
muscle relaxant
Okay.
and
Analgesia, how will you provide analgesia intraoperative?
ma'am, intraoperatively, I will give injection paracetamol 1 gram IV, injection diclofenac 75 mg IV, and I will also ask a surgeon for suture infiltration of 0.25% 10 ml of bupivacaine.
We are still doing the surgery, no? We have not come to the end.
Yes, ma'am.
You are in tearing hurry to finish off the case, perhaps. So now the case was going on and you notice that your patient is becoming tachycardic and EtCO2 is rising. It has gone up to 50 and patient's temperature monitoring also shows that temperature is around 38.5. So what has happened to your patient and how will you manage this situation?
Ma'am, in the background of a large thyroid mass and hyperthyroidism, probably my patient has landed up in thyroid storm. So, ma'am, first of all, I will ask the surgeon to stop the surgery. I will check my tube. I will check the plane of anesthesia whether my patient is light or not, and I will also check the exhaustion of soda lime. Then I will keep FiO to 100%. I will call for help, and then I will administer. After ruling out all these, I will administer injection propranolol 0.5 to 1 mg after every 15 minutes till 10 mg we can maximum dose we can given, and injection esmolol 0.5 mg per kg over 10 minutes, and infusion dose 0.03 to 0.3 mg per kg, and I will also do cooling of my patient, active cooling of my patient. In active cooling, I will from Rile's tube of the patient. I will put ice pack in axilla of the patient. I will ask surgeon to lavage the surgical field with cold saline, and I will also saline through Foley's catheter also, and then antithyroid
Okay,
drug.
so yes. What antithyroid drug?
Antithyroid drug PTU 100 to 500 mg can be given through Rile's tube or per rectal.
Okay, any role of steroids?
Yes, ma'am. I will give steroids, injection hydrocortisone 300 mg IV followed by 100 mg every 8 hourly. And
Okay.
ma'am, I will take. I will.
So when can this thyroid storm occur? Does it occur only intraoperatively?
No, ma'am. Most thyroid storm episodes occur post-operatively, 6 to 48 hours post-operatively. Maximum incidences
So
occur.
it can occur anytime intraoperatively or from 6 to 48 hours post-operative also. So patient should be adequately monitored. Okay.
Yes,
So, all right. So, the surgery is over. The surgeon has taken out the thyroid mass. The bleeding has been adequately controlled. And now he's suturing his incision line. So how do you plan to extubate your patient? What is your extubation strategy?
Ma'am, I will ask the surgeon to palpate the trachea to get the feel of soft or floppy. And ma'am, then I will
What kind
do
of extubation? Just a minute, Velish. What kind of extubation is this will be labeled as? Do you know
ma'am, the guarded.
about TAS extubation guidelines?
Yes, ma'am.
So according to that, what category of extubation will be done in this patient?
Ma'am, as my patient has difficult airway and it's a difficult intubation, my extubation is also difficult. So I will do guarded extubation on airway
So
exchange
this
catheter.
is known as at-risk extubation. Okay. All
Yes,
right. Tell me
yes.
why this is at-risk extubation.
Ma'am, this is at-risk extubation because after extubation, there can, due to tracheomalacia, there can be complete airway obstruction, and we can't intubate.
No, we are not talking
with
about tracheomalacia. No. That is wrong. At risk, you know what is at risk? Have you read the extubation guidelines or no? I don't think so.
Yes, ma'am.
So first, because this is a difficult airway, large
Difficult
thyroid mass,
yes, ma'am.
patient tracheal compression and deviation is there with retrosternal extension. Okay? So one is
yes, ma'am.
this. Your patient has, what are the, does your patient has any feature suggestive of tracheomalacia in the history?
Yes, ma'am. Yes, ma'am. The thyroid is long
What are
standing.
those?
The thyroid swelling is long
Okay.
standing since 8 years, and it is a firm swelling. So it can compress trachea.
Okay, so how will you extubate this patient now? Tell us, how will you extubate this patient?
Ma'am, I will
Fast.
ask. Ma'am, I will ask surgeon to palpate the trachea and to get the feel of the trachea, whether it is floppy or soft, and then I will do a leak test. In leak test, I will change my ventilator mode to volume control and then I will note down the baseline inspiratory and expiratory volume. Inspiratory and expiratory volume, I will deflate the cuff of the tube, and for 6 cycles, I will note down the difference between expiratory and inspiratory, and the lowest 3 values I will deduce the average, and from this average I will deduce.
Okay, if a leak is positive, if the
more
leak
than-
test is positive, what does that mean?
Ma'am,
If the
if
leak
the
is
leak test is
present,
positive,
what
that
does
means
that
that there
mean?
is, ma'am, it means that there is no leak.
There is no tracheomalacia. Okay.
Okay, ma'am.
Hello. Yes, if the leak
Hello.
test is
Yes, ma'am.
positive, more than 110 ml, then the leak test is positive and there is no tracheomalacia. So now how will you extubate your patient? What technique are you going to follow?
Ma'am, I will extubate my patient on airway exchange catheter. I will reload the airway exchange catheter,
Okay.
and through airway exchange catheter.
Okay, so now you have
And
extubated your patient on airway exchange catheter. All right. Okay. So patient is successfully, patient has been extubated. Now you will shift the patient to post-op recovery area. So what is the
Yes, ma'am.
post-operative management in this patient?
Ma'am, I will keep my patient propped up. I will give supplemental oxygen by face mask, and I will look for any respiratory distress in this patient. I will do constant SpO2 monitoring in these patients.
How will you give post-op analgesia to this patient?
Ma'am, in post-op, I can ask surgeon for suture infiltration of local anesthetic. And
So, just a minute, three major concerns in the post-operative management of this patient will be post-operative analgesia, post-operative nausea, vomiting, because thyroid surgery have great propensity towards this side effect, nausea, vomiting. And third is any respiratory obstruction the patient can develop. So you have to tackle all these problems. For post-op analgesia, you can get the suture line, multimodal analgesia can be given. Suture line is infiltrated with local anesthetic. We've already given Falgan, paracetamol, diclofenac. Non-sedative analgesics can be used. For post-operative nausea vomiting, even before you extubate the trachea of the patient, antiemetics like ondansetron should be used. Then what are the causes of patient going into respiratory obstruction in this case?
Ma'am, there can be wound hematoma, recurrent laryngeal
Hematoma
nerve,
next.
recurrent laryngeal nerve
Palsy.
palsy, tracheomalacia,
Next.
laryngeal edema, and hypocalcemia induced laryngospasm.
Okay, so these are the features. Tracheomalacia we have already ruled out. Laryngeal edema also. While extubation, you also see the check the integrity of the recurrent laryngeal nerve. I mean the mobility of the vocal cords. So how do you see that? You didn't tell us about that. Any special technique you will adopt to see the mobility of the vocal cords during extubation?
Ma'am, during extubation with airway exchange catheter, through airway exchange catheter also we can see the mobility of vocal cord.
How will you see that? AEC से vocal cords थोड़ी ना नजर आ जाएंगी. आपको कुछ laryngoscope तो डालना पड़ेगा ना, कुछ तो scope डालना पड़ेगा.
Ma'am, video laryngoscope.
How do you do actually in the theaters? You must be doing it for all the cases. How do you do that?
Ma'am, we can
Yes,
do
you can
that by
use video
direct laryngoscope.
laryngoscope. You can use a direct laryngoscope. You can use a video laryngoscope. You can do a nasal fibroscopy. But you have to ensure prior to that, your full neuromuscular blockage should be reversed so that the movement of the vocal cords can be seen. But at the same time, patient should be sedated or deep enough to allow laryngoscopy or fibroscopy. All right. So you can deepen the plane with your inhalational agent, or you can use short-acting IV agents like a bolus of propofol.
Yes, ma'am.
All right.
Yes, ma'am.
And then you will see the mobility of the vocal cord, and you will extubate the trachea of the patient. Okay. In the post-op patient, now suppose suddenly your patient develops respiratory distress and his SpO2 goes down to 90%. He's tachypnic, restless, agitated. So what will you do and what will you suspect?
Ma'am, I will remove the. I will call the surgeon and I will remove the suture of the patient. I am suspecting a wound hematoma in this because of respiratory distress.
Okay, right. So immediately the bandage should be removed, surgeon should be called, and then after the surgeon sees the patient, you will wheel in the patient inside the OT again for urgent evacuation of the hematoma. Okay. So just one thing that when you were talking about checking the integrity of the recurrent laryngeal nerve intraoperatively, any other technique can be used to do that?
Yes, ma'am. We can use a specialized tube such as electromyographic tube. It is
that we have already talked about. What is the role of TIVA? What is the role of TIVA?
Yes, ma'am. In the RNN nerve monitoring, TIVA will not interfere in RNL monitoring because it will not block the neuromuscular junction. So TIVA can be given.
What are the drugs what are the drugs you will use for TIVA?
Ma'am, I will use propofol injection 75 to 150 microgram per kg.
Just name the drugs. Just name the drugs.
Ma'am, injection propofol, injection dexmedetomidine.
Okay, all right. Okay. So you can use that. What is the role of loco-regional anesthesia for thyroid swelling? What all regional anesthetics
Ma'am,
can be used for thyroid surgery?
ma'am, we can use bilateral super cervical. Uh, it will give a post-op
Your
analgesia.
audio is not clear. Your audio is not clear. Which block did you say?
Ma'am, bilateral superficial cervical plexus block.
Okay. Will this provide complete analgesia for thyroid surgery?
No, ma'am. It is only it is only provide a post-op analgesia. It is only for small thyroid swelling, not deep thyroid swelling.
But
And
still, even if the thyroid swelling is small, a bilateral superficial cervical plexus block needs to be supplemented, isn't it?
yes, ma'am.
Can you use deep cervical plexus block?
Ma'am, we can use deep cervical plexus block, but bilaterally we will avoid this block because there is a risk of recurrent laryngeal nerve injury and phrenic nerve palsy in bilateral block.
Okay. What about cervical epidural? Can we use cervical epidural?
Yes, ma'am. We can use cervical epidural
So at what
in some
level will you
selected
insert
cases.
cervical epidural?
Ma'am, at C7 to T1, we will insert the cervical epidural.
So we generally don't use these techniques. Why? What are the complications associated with these techniques?
Ma'am, cervical epidural use highly skilled personnel to give cervical epidural, and also it causes excessive respiratory distress, bradycardia and hypotension, and it requires extremely cooperative patient and surgeon.
Okay. Another thing that was left was if this patient of large thyroid swelling, if I do the flow volume loops, so
Yes,
what
ma'am.
kind of shape will my flow volume loops show? What kind of obstruction will be depicted on flow volume loop?
Ma'am,
Yes.
in my case, there will be extrathoracic obstruction, and in extrathoracic obstruction, there will be airflow limitation in inspiratory limb. So inspiratory limb, if there will be ma'am, depressed. And ma'am,
Okay,
if
so this is a variable extrathoracic obstruction. So the expiratory limb will be normal, while the inspiratory limb will be compressed. You must know the shapes of all your flow volume loops in various situations. Suppose your
Yes, ma'am.
patient had tracheomalacia, then what kind of obstruction will it be?
Ma'am, in tracheomalacia, it is a fixed obstruction. So
It will be
there
a
will
variable intrathoracic
variable
obstruction.
intrathoracic.
Okay.
Yes, ma'am. Yes.
So in that case, your expiratory limb will be compressed.
Compressed.
All right.
Yes, ma'am. Yes, ma'am.
Oh, yes. Okay. I think that's it. Dr. Twinkle can
Thank you, ma'am.
now summarize the.
Good morning, ma'am.
Good morning. Yeah.
Good morning, ma'am. Thank you, ma'am, for this wonderful discussion. Since Dr. Vilas has already covered everything, so I'll just take a quick revision. Thyroid gland and anesthetic management of large thyroid mass. So we'll start with anatomy. So this is an endocrine gland which consists of two lobes anterior to trachea extending from C5 to T1 and located just below the cricoid cartilage. It covers the second to fourth tracheal rings. So the thyroid gland weighs approximately 20 grams. Blood supply via superior and inferior thyroid arteries, nerve supply via superior, middle, and inferior cervical ganglia of autonomic nervous system, and parasympathetic innervation is provided by the vagus nerve. So the physiology, it produces three hormones: thyroxine, triiodothyronine, and calcitonin. Thyroid gland is essential for regulation of gene expression, regulation of growth and development, regulation of general metabolism, and regulation of tissue differentiation. So these are the thyroid hormone actions in cardiovascular system. This has chronotropic effect, inotropic effect. It increases cardiac output, increases peripheral vasodilation. In respiratory system, this is important for surfactant production. It increases rate and depth of respiration. In gastrointestinal system, it increases appetite, increases secretion of digestive juices, increases gastric motility. In metabolic, it affects oxidative metabolism, increases O2 consumption, increases heat production. It affects synthesis and breakdown of carbohydrates, protein, and fat. In central nervous system, this is essential for normal brain development and emotional stability in adults. In skin, necessary for growth and maturation of epidermis and hair. And in skeletal system, it increases growth by acting on pituitary gland and helps in skeletal and tooth development. So this synthesis of thyroid hormones, we'll just skip this part. Thyroid hormones, the normal values, thyroid stimulating hormone 0.5 to 5 milli international units per liter. Thyroxine 0.7 to 1 nanogram per deciliter, and triiodothyronine is 0.2 to 0.5 nanogram per deciliter. Hypothyroidism. So this is a clinical syndrome which is resulting from exposure of the body tissues to elevated levels of free circulating thyroid hormones. This is more common in females. Diagnosis is made by free and total T4 is raised, free and total 3 is raised, and serum TSH is low. So what are the causes of hyperthyroidism? So the causes includes Graves' disease, toxic multinodular goiter, thyroid stimulating hormone secreting pituitary tumors, toxic thyroid adenoma, overdose of thyroid replacement hormone. So what are the clinical features? It includes, the picture suggests intolerance to heat, fine straight hair, bulging eyes, facial flushing, enlarged thyroid, tachycardia, breast enlargement, weight loss, muscle wasting, tremors, finger clubbing, increases diarrhea, and menstrual changes in females. Eye signs in hyperthyroidism includes Rosenbach's sign. This is tremors of the closed eyelid, Stelweig's sign, staring appearance with infrequent blinking. Dalrymple's sign is sclera visible between the cornea and the upper lid. Von Graeff's sign is a lid lag on downward gazing. And Zoffroy's sign, absence of forehead wrinkling when looking upward. And Mobius sign includes impaired convergence. So what is the treatment of hyperthyroidism? So it takes 6 to 8 weeks to render the patient euthyroid, and we start antithyroid drugs, propylthiouracil 100 to 200 mg every 6 to 8 hours, methimazole or carbimazole 10 to 20 mg every 8 to 12 hours. Beta blockers, we usually prefer non-selectives over selectives. So it blocks the peripheral conversion of T4 to T3. It helps in controlling tachycardia. So the propranolol, the dose is 40 to 80 mg every 6 to 8 hours. Also, we can give radioiodine therapy. It destroys thyroid cell function. It is used as initial treatment or in case of relapse after anti-thyroid drug therapy. Anti-thyroid drugs should be stopped at least 3 days prior to radioiodine therapy to optimize iodine uptake. It may cause hypothyroidism and is not recommended in pregnancy. And the final treatment is surgery, which is subtotal thyroidectomy or total thyroidectomy. What is hypothyroidism? So this is an impaired secretion of thyroid hormones or underactivity of the thyroid glands leading to hypometabolic state. And the diagnosis is made by free and total T4 is low, free and total T3 is low, and serum TSH is raised. What are the causes? It includes primary hypothyroidism, autoimmune, which is Hashimoto's thyroiditis, post-thyroidectomy, post-radioactive iodine, overdose of antithyroid medications, iodine deficiency, or secondary hypothyroidism. So clinical features, the picture suggests intolerance to cold, receding hairline, facial and eyelid edema, dull blank expressions, thick tongue, slow speech, anorexia, brittle nails, dry skin, hair loss, muscle aches, and the late clinical manifestations, the subnormal temperature, bradycardia, weight gain, thickened skin, and cardiac complications. Treatment includes, it also takes 6 to 8 weeks to achieve a euthyroid state. Replacement therapy with thyroxine is started. We start with thyroxine 50 microgram per day for 3 weeks, which is followed by 100 microgram per day for the next 3 weeks, and then finally 150 microgram per day single daily dose. So in elderly patients with coronary artery disease, initiate treatment with a lower dose. So what are the problems with the thyroid? So the mass effect due to goiter, it may impact on structures in the neck. It may airway, esophagus, and the nerves around the neck, structures in the thorax. Airway issues are major concern in addition to hyperthyroid or hypothyroid status. So what are the pre-op investigations you will be suggesting to the patient? We will start complete blood count, liver function test, kidney function test. Serum electrolytes are important because in hyperthyroid patients, hypokalemia, hyponatremia are very common, and hypercalcemia may occur due to bone resorption. And in hypothyroid patients, hyponatremia is very common. Thyroid function test to be done, blood grouping and cross matching to be done. Random blood sugar charting, ECG to rule out any arrhythmias, and indirect laryngoscopy to assess for neurological involvement of vocal cords and for pre-op documentation for the medico-legal purpose. X-ray neck AP lateral view to rule out trachea, deviation or compression. 2D echo to be done in hypothyroid. It may show pericardial effusion, and in hyperthyroid patients, it may reveal left ventricular hypertrophy, regional wall motion abnormalities, or left ventricular failure. CT neck is to be done for retrosternal goiter extension. This is to be done to assess the extent of the swelling, to plan the surgical approach, to document the tracheal narrowing, to calculate the tracheal diameter. So we have 3 grades of severity. Grade 1, this is an extension up to aortic arch. Grade 2 is extension below the aortic arch, and grade 3 is extension below the right atrium. So these grades, they suggest they changes the approach towards the patient. Flow volume loops, they are not routinely done nowadays, but fixed upper airway obstruction, this is seen in large goiter and tracheal stenosis. Both inspiratory and the expiratory limbs are flattened, which is seen as a box-like loop. And variable extrathoracic upper airway obstruction, this is seen in thyroid masses which are compressing trachea above thoracic inlet. And variable intrathoracic upper airway obstruction, this is seen in goiter extending retrosternally. So what pre-op orders you'll be writing? We'll start with informed consent, fasting, 2 hours for clear fluids and 6 hours for solids. We'll explain awake fiber optic intubation if a difficult airway is anticipated. Pre-medication, anxiolytics in apprehensive patients without any airway compromise, anti-aspiration prophylaxis, arrange adequate blood and blood products, and avoid sedation in patients with airway compromise. In hyperthyroid patients, we'll administer iodide for 7 to 10 days prior to surgery to decrease the gland vascularity. And we'll continue antithyroid drugs and beta blockers until the morning of surgery. In hypothyroid patients, we'll continue the drugs, medications until the morning of surgery. We'll administer aspiration prophylaxis, especially in these patients due to delayed gastric emptying. And we'll use sedatives cautiously. Patients are prone to drug-induced respiratory depression. So what is going to be our anesthetic plan? So this includes general anesthesia with endotracheal tube or awake fiber optic intubation with controlled mechanical ventilation. Bilateral, superficial, and deep cervical plexus block or cervical epidural anesthesia. So which endotracheal tube to be decided? So conventional endotracheal tubes, they can get kinked. Reinforced or flexometallic endotracheal tube is less likely to kink. So we prefer these ones. Also ring Adair Elvin North Pole endotracheal tubes, they helps keep breathing tubes away from the surgical field. Use a smaller size tube if tracheal compression is present. What is the management of anesthesia in hyperthyroid patients? So pre-op medications will start with benzodiazepines. Anticholinergics are not recommended as they interfere with the body's thermoregulation and contribute to an increased heart rate. Induction will start with IV propofol or thiopental. We'll avoid ketamine as it stimulates the sympathetic nervous system and can cause tachycardia. Succinylcholine or non-depolarizing neuromuscular blockers that do not significantly affect the cardiovascular system, so they may be used for intubation. Maintenance will use volatile anesthetics such as isoflurane, desflurane, sevoflurane. They are effective as they blunt adverse sympathetic nervous system responses to surgical stimulation without sensitizing the heart to catecholamines. So what is the goal? We have to avoid administration of drugs that stimulate the sympathetic nervous system and provide sufficient anesthetic depth to induce sympathetic nervous system depression and prevent exaggerated response to surgical stimulation. So management of anesthesia in hypothyroid patients, ketamine or etomidate may be used as induction agents of choice. Hypothyroid patients, they may be more sensitive to the hypotensive effects of the anesthetic drugs due to decreased cardiac output, blunted baroreceptor reflexes, decreased intravascular volume. So we have to give titrated doses of anesthetic drugs. Also, pharmacological support may be required. Positioning is also very important in this patient. The patient is positioned with a sandbag placed between the shoulder blades and the head resting on a padded horseshoe. We have to avoid excessive neck hyperextension. Arm should be secured by the side with proper padding and protection of the ulnar nerves. Apply eye padding, especially in patients with exophthalmos to prevent corneal injury. So what monitoring you will be doing? So we will start with standard ASA monitors, ECG, non-invasive blood pressure, temperature, pulse oximetry, and ETCO2 monitoring. Neuromuscular monitoring can also be done. This is optional. Urine output monitoring, temperature monitoring is very important. Invasive arterial monitoring and CVP line, they are based on individual patients if they have any comorbidities. And electrophysiological monitoring of recurrent laryngeal nerve is also optional. Intraop concerns in hypothyroid patients. So increased activity to central nervous system, depressant drugs, hypodynamic cardiovascular system response, which leads to decreased heart rate and reduced cardiac output, slowed metabolism of anesthetic drugs, hypovolemia, delayed gastric emptying, hyponatremia, hypothermia, hypoglycemia, adrenal insufficiency. And anesthetic concerns in hyperthyroid patients, hyperdynamic circulation, thyrotoxic cardiomyopathy, and high output cardiac failure, exaggerated sympathetic nervous system response, tachyarrhythmias, including atrial fibrillation, hyperpyrexia, hypercarbia, increased oxygen consumption, elevated metabolic rate, risk of thyroid storm, and postoperative complications. So what are intra-op concerns in hyperthyroid patients? So bradyarrhythmias. So we do not have to give atropine in case of bradyarrhythmia. We have to stop the surgery temporarily and infiltrate lignocaine around the carotid body. Excessive bleeding could be there due to hyperextension of the head and hypercarbia. Acute hypertension can be there. So we have to use direct sympathomimetics like phenylephrine in hyperthyroid patients and indirect sympathomimetics in hypothyroid patients. Air embolism and thyroid storm can be there. So pain management. So pain management includes multimodal approach. We can give opioids. We have to use judiciously. Analgesia, NSAIDs or paracetamol. Cervical plexus block, USG guided can be given. Local infiltration and cervical epidural. Reversal and extubation. So we have to ensure complete reversal of neuromuscular blockade. Surgeons may request a Valsalva maneuver after confirming hemostasis. We have to perform cuff leak test to rule out tracheomalacia. How will you assess vocal cord movement? So we can do direct laryngoscopy, video laryngoscopy, nasal fiber optic bronchoscopy, or Bailey's maneuver. We have to minimize sympathetic response to extubation. So you can use dexmedetomidine and consider deep extubation if appropriate. So post-op complications, early complications can include hematoma, laryngeal edema, nerve injury, tracheomalacia, thyroid storm, or pneumothorax if retrosternal goiter. Late complications can include hypoparathyroidism and hypocalcemia and hypothyroidism. So hematoma, the incidence is very rare, 0.3 to 1%, but it can be fatal. Timing most occur within first 6 hours post-operatively. It obstructs venous and lymphatic drainage. The symptoms include neck swelling, dyspnea, stridor, and this is an acute emergency. It can cause acute airway obstruction, cannot intubate, cannot ventilate scenario may be there. So the management includes bedside suture removal, emergent re-exploration, return to the operative room for evacuation and definitive hemostasis. Laryngeal edema, the causes can be due to repeated intubation attempts in a difficult airway, hematoma causing impaired venous and lymphatic drainage leading to edema. Prevention is minimize airway manipulation and intra-op dexamethasone 4 to 8 mg. Or management is re-intubation if airway obstruction is significant. Nerve injury, recurrent laryngeal nerve injury, it may occur due to traction, transaction, entrapment, or ischemia. So it can be transient or permanent, it can be unilateral or bilateral, and it can be partial or complete. Tracheomalacia, so this occurs in large, long-standing goiter leading to prolonged tracheal compression. So we do cuff leak test intraoperatively to rule out it. What is cuff leak test? Cuff value for leak volume less than 110 ml or less than 10 to 15% of delivered tidal volume. Lower leak volume indicates a higher risk of post-extubation stridor. So we perform fiber optic bronchoscopy before extubation to assess tracheal collapse during inspiration and consider extubation over an airway exchanger. Thyroid storm. So this is rare nowadays due to widespread use of anti-thyroid drugs and beta blockers. This is most likely 6 to 48 hours post-operatively. Mortality rate is approximately 20%. This is a life-threatening complication. Factors which are precipitating thyroid storm: radioiodine therapy, iodinated contrast agents, withdrawal of anti-thyroid drugs, infection, trauma, pain. So what are the causes inside the OT? Inadequate depth of anesthesia, hypoxia, hypovolemia, pulmonary embolism, and surgical manipulation. So what is the clinical presentation under anesthesia and when the patient is awake? Under anesthesia, increased bleeding will be there, increased EtCO2, soda lime exhaustion, excessive sweating, tachycardia, hypertension, arrhythmias, cardiac heart failure, and shock. When the patient is awake, restlessness, extreme irritability, delirium, seizures, coma, tachypnea, vomiting, abdominal colic, excessive sweating, and dehydration will be there. So what is the management? Management includes increase oxygen support, increase depth of anesthesia, replace soda lime, use beta blockers, esmolol infusion or propranolol, decrease body temperature by using cooling mattresses, ice packs, cold irrigation, cold IV fluids, and acetaminophen. Fluid of choice will be cool and dextrose containing solutions. We have to correct fluids, electrolytes, and acid-base imbalances, and furosemide, digoxin, or inotropes if needed. Steroids will be using dexamethasone 2 mg IV every 6 hours and hydrocortisone 100 to 200 mg IV every 8 hours. It inhibits conversion of T4 to T3. In hypoparathyroidism, mostly due to devascularization of parathyroid gland or direct trauma, signs and symptoms of hypocalcemia usually occur 24 to 48 hours post-operatively. So initial neurological presentation is paresthesia of perioral region, hands and feet, muscle cramps and spasm, hyperreflexia, positive short sign and Tournier sign will be there, and treatment includes IV calcium gluconate followed by oral calcium and vitamin D supplementation. So the take-home message is ensure the patient is in a euthyroid state prior to elective thyroid surgery. AFib management may be challenging in these patients. Post-operatively, close monitoring is essential, and uncontrolled hyperthyroid or hypothyroid patients may present as emergencies, so must be managed with vigilance. Thank you, ma'am.
Thank you, Dr. Twinkle. That was a very comprehensive and good presentation. Thank you, Velesh, and thank you, Dr. Twinkle.
Thank you,
I
ma'am.
hope everybody has gained from the deliberations. Thank you so much.
Thank you, Monisha, ma'am. I just want to say, ma'am is the woman of considerable merit and distinction, and it is my pleasure, and I think all the residents' pleasure to listen to this case. It was an enlightening session. Thank you so much, ma'am. For the next session, I would like to invite Dr. Jayashree Sood. Ma'am is advisor in Institution of Anesthesiology, Pain and Perioperative Medicine, Vice Chairperson, Board of Management, and she is affiliated to Sir Gangaram Hospital, New Delhi. Ma'am portfolio of achievement speaks volume. Ma'am is the member of Specialist Board in Anesthesia of NBE, DNB Examiner, MDDA Examiner, and member editorial board of many national and international journals. Welcome you, ma'am.
Thank you so much. Thank you so much.
Can you please introduce Dr. M.D. Kaur, ma'am?
Thank you very much. It's my pleasure to introduce Dr. Mohandeep Kaur, Professor and ex-HOD of the RML Hospital and the ABVIMS. She has several achievements. She has pioneered this Appec program. She's received the Pratibha Samman Award, ex-ISA Delhi President. In 2022 to 2024, she has publications in several national and international journals. Area of interest is critical care, quality improvement, laparoscopic anesthesia. And to add it all, she's a very good friend of ours. So welcome, Mohandeep, and you will be, of course, speaking on a very important topic of the non-technical skills.
Non-technical skills in anesthesia. Good morning, chairpersons, delegates, and the organizers. I thank Dr. Neerja and rest of the organizers for giving me a chance to take this lecture in important program Appec 2025. So will be speaking on non-technical skills in anesthesia, which is a very important topic these days. Next. Skills required by anesthesiologists in OT and ICU include both technical and non-technical skills. Technical skills are related to the knowledge of science of anesthesia and performing these skills in various case scenarios and situations in OTs and ICUs. And these comprise an airway management like incubating and the trachea, then regional and neuraxial blocks, record keeping, and knowledge of computers. Whole focus of the curriculum is on learning these technical skills, and examination process also determines this aspect. However, non-technical skills, these include cognitive, social, and personal resource skills that complement technical skills and contribute to safe and efficient task performance. First used in aviation industry for maintaining safety and extrapolated to an emergency situation management. However, applied first time to anesthesia specialty in medicine, and before learning ends, good technical skills have to be there at the base of it. Known as ANTS, anesthesia non-technical skills, these have a lot to do with behavior and personality of the person, that is the anesthetist. However, studies of behavioral sciences show that these can be taught, learned, and assessed objectively both in simulated and real environment. So these ANTs determine safety and efficiency during performance of technical skills, encompass human behavioral components of safe medical practice, and thereby maximize human performance for anesthetists. Aim here is on crisis management in best possible manner in the available scenario. Types of skill categories include cognitive and mental skills like situation awareness, decision making, and social and interpersonal skills like coordinated teamwork, leadership, and communication. Now, skill set for ANTS was evolved by a team of anesthetists and psychologists based on data of anesthetist behavior from literature review of human errors in medicine, observations, interviews, surveys, and incident analysis. The AND system comprises three-level hierarchy. At the highest level are 4 skill categories, and beneath these 15 skill elements. Each skill element has a definition which can be explained by examples of good and poor behaviors that could be associated with it to form the main framework of the system. Now, the 4 skill categories are task management, teamwork, situation awareness, decision making, with various component elements and examples of good and poor behavior. So, task management and teamwork, these are the backbone of performing non-technical skills. Since, the main thing is about any situation which has to be handled. The non-technical skills are very important. Cognitive skills are important in the third and fourth skill category, that is situation awareness and decision making. So this is a framework in which we have task management, teamwork, situation awareness, and decision making as skill categories, and these are the skill elements, 15 in total under these 4 skill categories, and these will be described one by one in the next slides. Task management is organizing available resources and requisite activities to achieve a set goal for the task, and 4 skill elements included in this are planning and preparing ahead, prioritizing, developing primary plan and plan B, identifying and prioritizing key points, maintaining SOPs that are very important. And we have to have 2 plans, plan A and plan B. We will not make plan B when the plan A has failed. So, after doing this, we have to delegate the task to the team, then deal with the interruptions. Time management has to be justified. Resource management has to be justified, both human resource as well as non-human resource. So the teamwork next skill category, which has got 5 skill elements, these comprise coordination, communication, role adoption as leader, as follower, then capability assessment of the team members, then provision of support wherever it is needed. So coordination and information sharing amongst anesthetists, surgeons and nurses as a team who is managing the situation results in better outcomes and handling unforeseen problems and complications. Like a good example here would be to describe surgical checklist for fixing responsibility. Coordination is necessary for carrying out technical and cognitive skills. And one main role of communication is very important. Like it's both an art and skill, and closed loop communication skill has to be learned, and it is the basis of effective communication. This may be learned through or improved through observing seniors, peers, and practicing oneself. And clarity of speech and tone of language must be emphasized while making communication. So next is knowledge competencies under teamwork. You know, this element is important for understanding team members' strengths and weaknesses, knowledge of team mission and objectives of task in question. So leadership as a skill element requires 4 competencies, that is knowledge, skill, attitude and vision. Leaders' good knowledge and technical skills form the basis of error-free task management. And capacity of the leader is to translate vision into reality. Somebody is, as a leader, is visualizing the results, outcome, and then performing the teamwork to bring it to reality. So leadership comprises the skill competencies are ability to recognize obstacles, and it has a dynamic role as per situation. Leader can adapt to changes needed in teammates, like changing roles, changing strategies to accomplish the task. Attitude competencies or emotional intelligence. This is very important these days. In addition to your IQ, you should have emotional intelligence and emerging novel psychosocial construct in scholastic, academic, educational, and organizational settings, and it forms the foundation of non-technical skills. So a leader manages conflicts when confronted by difficult situations with authority, with accountability, and with support. This comes with confidence, and when you are performing that same task a number of times, repetitive. Emotional intelligence as 4 integral components: self-awareness, self-regulation, social awareness, and relationship management. First, to define one's own abilities, and social awareness and relationship management define one's role with respect to others. So self-awareness and self-regulation important for your own self and may be increased and learned. Social awareness involves interpersonal relationships, including verbal, non-verbal interactions in crisis management situations. Like non-verbal would be not making faces at anybody. Valid in OR and ICU setup where multidisciplinary workforce is required for positive outcomes. And relationship management defines role of individual in team, ability to understand views of others. One thing very important, hierarchical dominance may be detrimental to coordination and communication and should be seen with a pinch of salt. Like the most senior most person is not the best leader. You know, we have to identify the best leader and work under the best leader amongst the team. A junior member may be a good leader in the team. Situation awareness is the ability to maintain adequate internal representation of the status of changing environment in a complex and dynamic situation. This concept was introduced by GABA and applied at individual level and team level. So various studies have been quoted for determining success or failure of situation awareness. And this situation awareness errors have been identified in critical incident reporting systems in approximately more than 80% cases, and errors were reported at the level of perception and comprehension. So under the skill category situation awareness, we have these 3 skill elements: gathering information, recognizing and understanding the situation, anticipating in advance. Gathering information and data from the team, entire sources of information available in the environment and their assessment are required to make a complete sense of the situation. Recognizing, understanding and interpreting information by various team members and team leaders. Team leader should have focused and inclusive team briefing session. And then the skill category of decision making, in which we have the skill elements comprising identifying options, balancing risk and selecting options, and re-evaluating the scenario time to time. So it's a cognitive process which helps identifying options to take proper decisions, recognizing pros and cons of various options, balancing risk and selecting best option, making well-informed decision, proper implementation and evaluation of cases and situation. Decision making involves skills for making judgment to select a course of action in normal as well as time-pressured crisis situations. So judicious use of resources and adoption of all components of ads help in successful task completion. Now the second part of it, ads rating. Measuring the performance of non-technical skills is essential to ensure safe and quality perioperative care. It's an ideal tool for this purpose and which should be highly reliable and validated. ANTS rating system is most promising with acceptable validity and reliability in both simulated and clinical settings. And evaluation of these skills should be linked to programs designed to evaluate performance, competency, and allow remediation. In addition to ANTS framework, a behavior rating scale was designed where each element was rated on a set of 4-point rating scale for rating observed behaviors in relation to the skill elements and skill categories, and space also to write brief comments and an option for indicating the non-observed skill for that particular scenario if it was not performed. Now, this is the evaluation of ANTS rating score-wise: good, acceptable, marginal, poor, and not observed. Then this is how it is written. Like the skill elements on one side, then the rating, and then comments on the observed behavior. The ANTS ratings are made at any place where anesthesia is being delivered, like operation theatre or mid areas of anesthesia delivery, or in simulator facilities, and even in ICUs and for neonatal resuscitation. The tool is designed to be used by experienced anesthetist to rate the non-technical skills of another anesthetist who has achieved basic technical competence and provides feedback on the behavioral aspects of performance. Managing stress and coping with fatigue are not explicit categories, as they can be difficult to detect unless when extreme. So the impact of simulation-based training in non-technical skills for anesthetists during residency has been found to be positive. Simulation helps in recognizing error, enriching self-confidence, and crucial role of behavioral skills. So video replay and debriefing act as powerful way of allowing scenario participants to reflect on their action and facilitate further exploration of the cognitive processes. The advantages of such skills is that by identifying specific behavioral examples during performance with illustration of positive and negative impacts of their action, force participants rapidly build their understanding and develop confidence. And also it is used to test the efficiency of similar-based training program on anesthesia crisis management. To conclude, non-technical skills is important to mitigate the effects of errors in the areas where safety is a paramount concern. It's important to remember that non-technical skills should not be considered in isolation to other aspects of anesthesia competence. Successful task performance depends on the effective integration of both technical and non-technical skills for any given situation. Thank you.
Thank you so much, Dr. Kaur. And that was, of course, an excellent overview. You need to start the video so that the students can see. Can you start my video? Nirja?
At the back end, Jyoti, just ask
Okay.
them to, hi, ma'am. At the back end, yes, ma'am. Yeah.
Yeah, it's done. Thank you so much, Dr. Kaur, for that very important lecture that you have just delivered. It's such an important topic, as you have highlighted, and surely the students will appreciate that this improves the patient care as well as the patient outcome. And as you've seen, even in your practicals of the DNB, you have communication skills as the table. And I think even the MD exams have started this in the practical examination. simulation, of course, is a very important example. So thanks a lot, Dr. Kaur. And Betty, are there any questions in the chat box that we need to discuss?
No, ma'am, not as of now. There is no question on the chat box.
Right. So just to conclude, Nija, would you like to add anything?
No, ma'am, I would like to thank you in the end. So please complete.
So thank you, Dr. Kaur. That was excellent. And I think you have highlighted everything so clearly. And each and every step and point was very, very relevant. And for the students, it's very important. And I'm so glad this was included as one of the topics in Appec today. So I'd like to thank Dr. Nirja and her team for this excellent program that has been started a couple of years back and is running so successfully. Thanks a lot.
Thank you so much, ma'am. Personal thanks to you. Such a senior faculty joining our teaching program, and you have been associated with us since 21 when we started, and it's like really encouraging for PGs to learn from you. And especially you are associated with teaching programs all over especially the online teaching programs for ICA programs, you're always there. So thank you so much for being part of our program.
Thank you, Nirja. It's an honor for me.
Your
Thanks
inputs
a lot.
mean a
Thank
lot
you.
to us, ma'am.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you.
So I appreciate and I thank Dr. MD Kaur to bring light to this topic. This is a very upcoming topic nowadays. Thank you so much, MD ma'am. Thank you so much, Jayashree ma'am. And obviously, I gained something from this topic. Thank you, ma'am.
Sure you did. Thank you.
Thank you so much.
Thanks, ma'am.
Thank you. Thank
So for our next long case, I would like to invite Dr. Nirja Banerjee. Our next case is 58-year-old male diagnosed with CA larynx, planned for total laryngectomy. It will be moderated by Dr. Nirja Banerjee. Ma'am is head of department in RML hospital. Ma'am, area of interest is trauma and resuscitation, difficult airway, teaching and training. Her professional trajectory is started with noteworthy milestone. Ma'am is a mentor to me. Welcome you, ma'am.
Thank you, Doctor. Thank you, Dr. Jyoti.
Thank you, ma'am.
I would like Dr. Srinivas to take over now. Dr. Srinivas will be presenting the case, and our senior resident, Dr. Spriha, is also there with us. She'll be joining us in a short while. So, Dr. Srinivas, please. You may start your case.
Good morning, ma'am. I'll be presenting a case on patient posted for total laryngectomy.
We need to make it full screen, Dr. Srinivas.
Now you can.
Yes. Ma'am, is it visible, ma'am?
Yes.
Yes, please.
My patient is Mr. Shafiq, 58-year-old male, Muslim by religion, not formally educated, rickshaw puller by occupation, residing in Daroga Street, Delhi, presented with chief complaints of change in voice for 2 years, difficulty in swallowing.
Yeah, your PPT, the slides were not moving. It was stuck on first slide. Now, please go ahead. Go. Now you started. Yeah.
Yes, my patient is Mr. Shafiq, 58-year-old male, Muslim by religion, not formally educated, rickshaw puller by occupation, residing in Daroga Street, Delhi, presented with chief complaints of change in voice for 2 years, difficulty in swallowing for 3 months, and difficulty in breathing for 3 months. The patient was apparently developed change in voice, which insidious in onset, gradual progressive, hoarse in nature, and no biting or relieving factors. Patient also complains of difficulty in swallowing for 3 months, insidious in onset, gradually progressive, initially for solids but now for semi-solids, no aggravating or relieving factors, not associated with pain or cough during swallowing, but associated with foreign body sensation in the throat.
There's a lot of background
Patient
noise.
also
Can we
presents
check it,
with
please?
difficulty.
IT team. Dr. Srinivas, can you just wait for a moment? Let them check.
So,
Yes.
so what you have told is that this patient has, our main complaints are change in voice, breathlessness, and difficulty in swallowing. And the change in voice
ma'am.
was 2 years back, and difficulty in swallowing and your dysphagia and
Difficulty in breathing.
breathlessness is for last 3 months only. Okay. So breathing difficulty is only for last 3 months. There is some
Yes, ma'am.
ambient noise. Can we check it? Give me a moment, please, Srinivas. Srinivas, you'll
Yes,
have to
ma'am.
give me a moment before we continue again.
Yes, ma'am.
कितना सुंदर गाना है। ये बड़ा वो ये हमारा पंजाबी टाइप मैम, ये अंजलि है ना हमारी जो कंसल्टेंट है यादव में, हाँ उसकी मम्मी ने मुझे दिया।
कहाँ से उधर इस ओर से आ रहा है। ज्योति ज्योति क्या स्पीकर है कौन? Okay, Srinivas, we may start. So the presenting history
Yes,
is,
ma'am.
yes, you may go ahead.
Ma'am, patient was apparently asymptomatic 2 years ago, after which he developed change in voice, which was insidious in onset, gradually progressive, coarse in nature, with no aggravating or relieving factors.
Right.
Patient also complained of difficulty in swallowing for 3 months, which is insidious in onset, gradually progressive, initially for solids, but now for semi-solids, with no aggravating or relieving factors. It is not associated with any pain or cough during swallowing, but the patient feels a foreign body sensation in his throat. Coming to difficulty in 3 months, it was insidious non gradually progressive. Initially having difficulty while doing strenuous exercise, now having difficulty in walking on the level ground. He has to stop for each breath frequently. It is also associated with noisy breathing during strenuous exercise. It is not increased on lying down or upright position or lateral position. There is no seasonal or diurnal variation. No history of awakening in the night feeling breathless, and there are no relieving factors.
Okay. Can you tell me why did you take all this negative history of any positional changes in breathlessness or any other associated history that you have found out, and what are you trying to rule out?
Ma'am, noisy breathing suggests the degree of obstruction in the airway.
Right.
And the obstruction can be relieved or can aggravate during lying down position or any other position. Based upon the degree of obstruction, the patient might feel better when he turns to a particular position. So I want to rule out any obstruction in the upper airways.
Right. And it is also very important because these are the patients who are going to come to us for anesthesia. If there is a particular position in which a patient is comfortable, so one is we will, whenever anesthesia is given or whenever a patient is being examined in lying down position, we have to ensure that that position is maintained. Otherwise, it is pointing towards the fact that some kind of obstruction, whatever is there, is increasing in that position. So we have to avoid it. So that's why finding the ideal position in which a patient is comfortable is important. Please go ahead.
There is no history of loss of appetite, but patient complains of weight loss for the past 2 months. He lost almost 5 kgs, which was noticed by loosening of his clothes from the past 2 months. There is no history of trauma to neck or vocal abuse. There is no history of ear pain, excessive salivation, or foul-smelling discharge from mouth. There is no history of any neck swelling or difficulty in the neck movements. There is no history of cough with expectoration, blood in sputum, or evening rise of temperature or night sweats. There is no history of foreign body ingestion or ingestion of acidic or alkaline substances. No history of yellowish discoloration of skin or bony pain. No history of palpitations, excessive sweating, chest pain, or lower limb swelling. And there is no history of headache, altered sensorium, loss of consciousness, or abnormal body movements.
Right. So basically, all these negative histories you have taken to rule out other comorbidities.
Cardiac related history you have
Yes,
found
ma'am.
out, then any associated history of chest infection also you're trying to rule out, right? Go ahead, please.
Want to rule out any other associated lung disease also.
Lung disease, right? That also you're trying to rule out, right?
Yes. Coming to past history, there is no significant past history in the patient. There is no significant family history also. Coming to personal history, he is married and has 2 daughters and 1 son. He's a known BD smoker for the past 10 years. He smokes 1 bundle per day and he has stopped smoking for the past 2 months. And he is also a known alcohol consumer. He takes alcohol for the past 15 years. He takes 90 to 120 ml per consumption, and he also stopped it for the past 2 months. He has no history of tobacco chewing or hookah smoking. He takes mixed diet. His appetite is normal, but because of dysphagia, he has reduced intake for the past 3 months. He has disturbed sleep due to this noise breathing and no food or drug allergies. Bowel and bladder habits regular and normal. Meds couldn't be assessed in this patient, and he belongs to lower middle class according to modified Kuppuswamy scale.
Okay, so I see that there are some points that you have highlighted. So what does it mean to you, this patient being a BD smoker? What is the implication of this? And how does it contribute to this disease per se also?
Ma'am, smoking can be associated with lung disease. So I wanted to be careful in asking the history of smoking to make sure that I will suggest him to cessation to be abstinent from smoking before the surgery, because it would increase the postoperative pulmonary complications in this patient.
Right, very good. So these patients, those who are BD or cigarette smokers, they are a very high likelihood of developing COPD. And once we are suspecting upper airway disease along with any kind of lung pathology, COPD, your lower airway pathology, they further complicate our problem. And another thing that's been found, that upper airway disease, which we are suspecting this to be in a case of maybe malignancy. So this is also a contributing factor to that. A very high percentage of these patients, they have a history of cigarette smoking, and our life becomes very difficult if they have underlying COPD, right? And another very big problem, if they have an underlying COPD, what do you think about PFT and all? Is it easy to do in these patients, or does it at all give you any kind of information?
Ma'am, patients with upper airway obstruction, especially malignancy in the larynx, the PFT won't give us proper cardiopulmonary reserve of the patient. So it's better to not go for PFT. Sometimes it can prompt the upper airway obstruction and cause problems to the patient.
Right, we will get falsely low values. So because of that, we'll interpret as very high COPD. We will not be it will not be of any help at all. We'll not be able, it will be an improper interpretation of the COPD. So we should, what I'm trying to highlight here is, whenever you see any reports, always see the patient as a whole. If you would just see this PFT, this patient, it can be highly deranged. So you just make sure, one is we will not be doing in these subset of patients. 2 is, in case if it has been done, you will have to take it with a pinch of salt, in the sense that it will definitely be deranged because it is associated with upper airway obstruction. So you have to assess your patient otherwise. You have written that he has stopped smoking 2 months back. What does it mean to you? Yes, Srinivas, the duration of stopping, 2 months stopping. This is for the PGs who are all listening to us. The duration, whenever you take history of smoking, please always take when was the cigarette smoking stopped. That is because each duration has got different implication and that you should be able to answer. Where in your exam, whenever you give history of cigarette smoking, more so for a patient of upper airway or COPD or any kind of lung disease, you should know what is the implication of stopping cigarette smoking at what duration. So can you tell me, Srinivas?
Yes, ma'am. Ma'am, smoking
Yes,
as such involves all the systems in the body. Its implications in cardiovascular system is it increases the atherosclerosis, and it can be the cause for coronary artery disease. It also is a cause for angina and vasospasm as such. And in respiratory system, it causes COPD, chronic bronchitis, emphysema.
So different time durations. What if you stop it at 24 hours or 48 hours? If you stop at 72 hours, this patient who has stopped for 2 months, is your life very good, or are you, would you still, or is your life going to be even more difficult? Can you tell me further duration? If you stop 24 to 48 hours before,
Yeah.
how does it help you?
Ma'am, stop smoking 12 to 24 hours before surgery will significantly reduce the oxyhemoglobin level, and the shift to the right and OD curve can be seen. And it also, after 24 to 48 hours, it also reduces the secretary. And the PFT will become normal in 1 to 2 weeks. And smoking till 4 to 6 weeks would pre-operate. The risk of post-operative complications would be as normal as any other patient.
Right. So if someone has stopped for 6 to 8 weeks, that means you can be like really happy as far as the effect of smoking on lung functions is concerned. Other factors, they
Yes,
will or they might stay the same, but as far as the effect of smoking on lung functions, that definitely will get improved within these 8 weeks. So your patient is fine as far as smoking is concerned. Very good. Alcohol consumption also is he has decreased. That's also fine. Meds is not accessible in the sense, basically, here you can do meds, but if you look at his history, he is saying that he becomes breathless while walking, doing normal activity. Here, meds is going to be really, really low. But is it because of any change in cardiorespiratory reserve, or is it because of upper airway obstruction? Very difficult to say. So in case if you are suspecting some kind of a cardiac compromise, you can go a further detailed examination. Otherwise, we are not able to comment on the basis of meds as to what is your cardiorespiratory reserve. Okay, please let's go ahead. Srinivas.
Yes, ma'am.
Right. After personal history.
Patient presented to ENT OPD 10 days back and got admitted in the hospital 5 days back. Some mentioned
You need to change the
after
slide,
undergoing
please.
blood.
Yeah.
Yes, ma'am. Patient presented to ENT OPD 10 days back and got admitted in the hospital 5 days back. Above mentioned complaints after undergoing blood chest X-ray and 70-degree endoscopy, which revealed a glottic growth. And contrast enhanced CT neck was advised, following which the patient underwent a direct laryngoscopy and biopsy 4 days back in our hospital. Upon review of anesthesia operative notes, a microlaryngeal tube of 5 millimeters internal diameter was secured under general anesthesia. After biopsy and debulking of the growth with hemostasis achieved, patient was reversed and extubation was done uneventfully. All the perioperative period was uneventful. The surgeons didn't suggest for any radiotherapy or chemotherapy. Patient was put on nebulization post-surgery with budesonide thrice daily perioperatively.
Okay, Srinivas, you have given me this history that this patient was anesthetized. Did you have access to anesthesia notes or any problems this patient faced during anesthesia? Can you tell me some details about this?
Yes, ma'am. Since the surgery was done in our hospital, I could access the anesthesia operative notes, and it was seen that the patient was induced uneventfully, and microlaryngeal surgery tube of 5 millimeters internal diameter was secured under general anesthesia. And after that, the
So you mean muscle relaxant was given? You mean a muscle relaxant was given? Did they give muscle relaxant, and which one did they give?
Yes, ma'am. They have given muscle
And why is it
relaxant.
important? Why am I asking you?
Ma'am, this set of patients can be difficult airway to manage. Managing the airway with skeletal muscle relaxant would be an issue. It would be a problem for us in managing the airway.
So in this patient, did they give a muscle relaxant or did they do a wake intubation?
Ma'am, in this patient, they have given succinylcholine, ma'am.
Okay. Okay, so that means there was no problem of they did not anticipate difficulty in ventilation or intubation, so they gave succinylcholine and they were able to intubate with a normal laryngoscope, Macintosh laryngoscope or video laryngoscope.
Ma'am, they have used video laryngoscope only.
Okay, and you have told me that it is MLS tube 5. Why have you? Why do you think they would have used 5 size tube, and what is MLS tube?
Ma'am, to ease the surgical access to the surgeon, MLS tube was used so that they could do the biopsy and manage the case.
How is MLS 5 size tube different from the normal tube?
Ma'am, MLS tube is a lighter tube which would be used for upper airway surgeries, especially the glottic surgeries. It is lengthier than the normal endotracheal tube, and it comes in a size of 4, 5, and 6 millimeters internal diameter, ma'am.
Right. So the idea is that we are using smaller size tube because the surgeon is working in that area. At the glottis, so they need a smaller size tube. But if we use this smaller size tube, the length of these small size tubes is small. So in order to circumvent that, MLS tubes are available, which are longer. So you put the same size, but the length gives you an added advantage of fixation, and inadvertent extubation is much lesser. Okay, so this was done for the patient,
Yes,
and then next what happened? This was after getting the biopsy. Did they get the biopsy report?
Yes, ma'am.
Yeah.
This was a scientific endoscope that they did, ma'am. It showed proliferative growth over left false vocal cord involving left arytenoid,
Can you show me
anterior
the next
commissure,
slide?
and
Dr. Srinivas, can you show me the
Yes,
next
ma'am.
slide?
Yes, ma'am.
Okay. So you can go back, go back, go back, go back. Go back further.
Yes, ma'am.
Yeah. You go to where you had stopped after that DL biopsy, follow subsequently after that. So these patients, when we get a biopsy report, then the surgeon decides whether this patient needs to be taken up for surgery or not. So since we are presenting this patient, I'm sure the result must have come positive for it to be a resectable tumor, and they would have decided to take this patient up for surgery. So is there a problem in slide sharing, Dr. Srinivas?
Yes, my little issue is there. Now
Doesn't
it will be
matter.
correct.
Okay, doesn't matter. You remember this case without sharing the slide? Can you tell me the case?
Yes, ma'am. Ma'am, coming to general physical examination, my patient was conscious, cooperative, well oriented to time, place, and person. He was examined in sitting position, comfortably on bed, with arms resting on his thighs. He was averagely built and nourished. His gait was normal. His height is 172 centimeters and weight is 52 kgs. His BMI was
is very
calculated
less.
to be 76.
Fine.
Yes, ma'am. Has no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Cervical lymphadenopathy was positive.
Okay.
Coming to vitals, his temperature was febrile on touch. His pulse rate was 88 beats per minute, regular in rhythm, normal in volume and character, no radio-radial delay or radiofemoral delay. All the peripheral pulses were palpable. Blood pressure was 134 by 82 millimeters of mercury, measured in right arm and sitting position. His respiratory rate was 20 breaths per minute, and it was abdominothoracic type. His saturation 95% room air, significantly.
Very good. You have taken
Here.
SpO2?
And his jugular.
Very nice.
Yes, ma'am.
Right.
His
Go ahead.
the jugular venous pressure was visibly raised.
Right.
Coming to the examination, there was no difficulty and opening admits more than 3.
So these patients, in general physical finding, what we have seen is his BMI is less than 18. Then rest of the parameters as far as his vitals are concerned, they are fine. There isn't much. He has mentioned that respiration is fine. He's not hearing any kind of noisy breathing or at rest. So that's a very good sign. And saturation in air is also 95%, which is not too bad. So these are some of the findings that we have on a general physical examination. Any findings, Dr. Srinivas, this was in general physical examination. Any findings that you could find on your any systemic examination or something that any positive findings on respiratory system?
Yes, ma'am. On neck examination, trachea is in the midline. Cervical lymphadenopathy was present. Level 2 and level 3 were involved. And laryngeal crepitus was not felt. There is no laryngeal tenderness, but there was playing of thyroid cartilage, which was laryngeal widening. And cricothyroid membrane was identified. And
very good, very good. So you have tried, and you could feel tracheal rings also?
Yes, ma'am.
Okay, very good. So this is very important. In any case where airway is involved, and otherwise also, whenever you are talking about airway examination, this is this is something that you have to look for. Looking for your cricothyroid membrane, and of course, in this case, tracheal rings felt or not felt, extremely important. In obese patients, it further adds to our woes as far as tracheostomy is concerned, which we might have to do. Right. Next slide, please, Dr. Srinivas.
Ma'am, respiratory system examination was normal, ma'am. Upper respiratory tract, no deviated nasal flip or sinus tenderness, normal. There was poor oral hygiene with dental caries. Apart from that, tonsils were normal with no post-nasal drip or pharyngeal congestion. On inspection, trachea appears to be central with normal both of chest moving equally present. There was no drooping of shoulders.
Okay, so as far as your airway examination is concerned, the distances are concerned, anything suggesting that there is an associated airway difficulty? So he has done general physical examination. He has the chest and respiratory findings, which do not give us much information. As far as the neck examination is concerned, that also seems fine. So in this patient, we would also like to find out. I am interested in knowing what are his respiratory findings, because it's very important. He was a BD cigarette smoker. He does not give any history of cough with expectoration or any seasonal variation. Yet we do not know. Sometimes we cannot rely on their history. So any findings on chest, any rhonchi, crepitations, decreased air entry, anything of that sort?
No, ma'am. On
So
palpation,
respiratory findings are fine. And as far as CVS is also concerned, nothing significant. Abdominal findings are also fine. So you may summarize your findings, Srinivas.
Yes, ma'am. My patient, 58-year-old male, smoker and alcoholic, occasional alcoholic, currently abstinent for the past 2 months, with progressive change in voice, which is hoarseness for 2 years, and progressive difficulty in swallowing for 3 months, with normal appetite but reduced food intake, progressive difficulty in breathing and noisy breathing for the past 3 months, which was associated with history of weight loss for 2 months without loss of appetite, and cervical lymphadenopathy involving level 2 and 3 lymph nodes, and with absent laryngeal crepitus and splaying of thyroid cartilage on examination, currently on budesonide nebulization, with a history of direct laryngoscopy and biopsy done 4 days back.
Very good. So in summary, whenever you have summarized everything, which includes not only the history, but any positive findings and the procedure which has been done. Right. Very good. Wonderful. Next slide, please. So what is the provisional diagnosis?
The provisional diagnosis. Yes, patient is an ASA2 male patient diagnosed to have laryngeal growth in direct laryngoscopy and biopsy, with risk factors of smoking and alcohol intake, with weight loss and cervical lymphadenopathy, which is suggestive of laryngeal carcinoma with cervical lymph node metastasis.
Okay. And anyhow, by this time, this is the diagnosis that we have made. By this time, we have the result of biopsy would have also come, because then only they are posted for surgery. So this patient needs to be posted for surgery. What are the investigations that you are looking for? The routine ones and the specific ones.
Yes, ma'am. The routine investigations, I would like to go for complete blood count, ma'am, which involves hemoglobin concentration and total leukocyte count and platelet count.
Right. And anything else? So these are the, so yeah, besides this, what else is important for you? What all will you like to find out?
I would like to go for a kidney function test, which involves
Right.
blood nitrogen and serum creatinine. I would
Right,
like
which is
to
a
go
baseline thing you want to know only. Otherwise, in this case specific, there is nothing much. Not a case, not a suspected case, but you would like to have a baseline value, right? Very good. Then what else?
I would like to go for liver function test also, ma'am. Since these patients usually, since my patient is an alcohol intaker and my patient can also have liver metastasis, I would like to go for liver function test.
Good. And liver function test, besides the liver enzymes and all, one value which is very important for you, because his nutritional intake was also very poor.
Yes, ma'am. Total proteins and albumin, I would like to go for.
Right. So that's also extremely important. Right. Go ahead. So
Along
liver
with
function test.
Since this
you
is
are
an, since this is an
So you would
intermediate
like to
risk
do-
surgery, I would like to go for coagulation.
So besides this, blood sugar that you will do, baseline blood sugar you will do, right? You will do LFT,
ma'am.
KFT that you have already done, coagulation profile, right? Blood grouping cross matching definitely.
Ma'am, I
Other
would like to
than
go
that,
for,
a baseline X-ray test you would to have.
Yes, ma'am. I would like to go for thyroid function test also in my patient since
Very nice. Now you will have to tell me why do you want to get a thyroid function test done?
Ma'am, since total laryngectomy always involves the side where the laryngectomy is done, that side thyroid gland also will be removed. So I would like to check.
Hemithyroidectomy.
Yes, ma'am. They would do hemithyroidectomy. So I would like to check the thyroid status along with calcium levels.
Yes. So baseline I would like to have, because post-operatively we'll have to monitor these patients and they may need thyroxine supplementation, right? And since this is an adherent area, when they remove thyroid, we really do not know whether parathyroid is also removed. Although on the other side, they are doing only hemithyroidectomy, but baseline we should have, and these are the things we should keep in mind post-operatively. Very good. X-ray chest, what is it that you're looking for?
Ma'am, I am looking for any COPD changes in this patient
Very
since my
good.
patient is a
So,
smoker.
see X-ray chest, ECG. Again, what all do you want to see?
Ma'am, in ECG, I want to go for any cardiac issues in the patient. I would like to.
Because as far as history is concerned, he doesn't give any histories. He doesn't have any history of hypertension, failure, anything. So those related changes are not there, but you never know. Patient is, sometimes the history is not reliable. So in case if there are any findings associated with it, right? So in this patient, we did not get any findings pertaining to COPD or ECG changes. And in case if you have the findings, you can flash the findings also if you have the lab values of this patient.
Yes, ma'am.
Dr. Srinivas?
Yes, ma'am.
Right. So the only thing which I'm worried about is albumin is 3.1, hemoglobin is fine, 10. Otherwise, rest everything else is fine for him. Okay. So, right. So these are the findings that I have, and X-ray ECG also I have. So with this background information in mind, this patient comes to you. How will you? Okay. Coagulation profile. With all this was there. Now, these are the, tell me, this is extremely important. Very good. So this finding you have to know before you take this patient up again for surgery. And so tell me about this finding.
Ma'am, this is a 70-degree endoscopy, which the surgeons prefer to do before taking the patient in. My patient, on undergoing 70-degree endoscopy, the findings were ulceroproliferative growth over left false vocal cord involving left arytenoid and anterior commissure, and left true vocal cord was partly visible, and left hemilarynx was fixed. The right true vocal cord, only the posterior part was not visible, 1/3, and it was mobile. And the chink was adequate.
And chink seems adequate. Chink seems adequate because of this only they would have used the muscle relaxant for anesthetizing for direct laryngoscopy and taking the biopsy and debulking, right? So with these findings, these findings you have to have before you do DL biopsy. whenever ENT surgeon brings you, please look for any, this is for the postgraduates. Whenever you get a DL biopsy done, DL biopsy and look for these findings. Sometimes the growth is so big and the chink is so narrow, you might not be able to do the normal, which he talked about, yeah, after inducing with say propofol and giving a muscle relaxant. So you will, in that situation, you will have to change your plan of anesthesia. So in this patient, we are fairly comfortable, but when we go to discussion, what are the other plans that you can think of, that we will do once we proceed with type of anesthesia and how will you do it. So how will you prepare this patient, pre-op preparation, pre-op advice? Please tell me, Srinivas.
Yes, ma'am. Ma'am, I would like to, since my patient is already abstinent from smoking and alcohol, I would like to ask him to continue abstinence from smoking and alcohol. And I would like to take a written informed high-risk consent. I would like to ask I would tell the patient to be NPO for 8 hours for fatty foods and 6 hours for light diet and 2 hours for clear liquids. And I would also give the patient anti-aspiration prophylaxis. I would like to give tablet pantoprazole 40 mg in the before the night of the surgery and on the morning of the surgery, 1 hour prior to the surgery with sip of water. And
right. So these patients, other than that, Srinivas, these patients, because their physical activity is limited and poor socioeconomic status, they start becoming, basically they start leading a very sedentary lifestyle. So do you think that's some kind of a risk factor for that pre-operatively, few days prior to surgery or 12 hours before surgery, we can give something?
Yes, ma'am. Ma'am, since the patient is sedentary, patient be a risk for venous thrombosis. So I would like to go. Yeah. Yes, ma'am. So I would
Very
like to
good.
add
So we
DVT
can give 12 hours before surgery, we can give low molecular weight heparin also, right? So you have it, nilparole orally you have advised this, then you have advised, okay, pantoprazole may be given in a, not a very high risk case, but right, if this is your hospital policy, you can give it, fair enough. Then what else will you do specific, something very specific for this patient in these subset of patients?
Ma'am, my patient is was put on nebulization, so I would like to continue the nebulization preoperatively.
Okay.
And
Okay.
I would like to ask for an arrange for an ICU bed with ventilator, since these patients airway is can be difficult managing post tracheostomy after the surgery. So I would like to electively ventilate.
Otherwise, also these are the patients who would undergo tracheostomy. So you need to explain all that to the patient, right?
Ma'am, I would, since my patient's total proteins are low, I would like to nutritionally supplement the patient also.
You do not have much time. There are only 4 days. So as far as that is concerned, we do not give albumin preoperatively, right? But if you have enough time, then that time nutrition supplementation definitely brings better results. Okay. So basically, you NPO you have talked about. Then you have told that you will be giving pantoprazole. Then you will be giving thromboprophylaxis, high risk consent, blood and blood products to be arranged. What type of surgery is this? What risk is?
This is an intermediate risk surgery, ma'am. It is intermediate risk surgery because there is no body cavity being opened.
Right. But
blood
loss still can be there.
Yes, ma'am. Since the surgeon is working around major blood vessels, I would like to go for blood grouping and cross matching along with arranging of blood and blood products.
Very good. So that needs to be done. So all that, and then these patients are tracheostomized. They should be informed beforehand, and then they definitely need to be put in ICU for minimum 24 to 48 hours. And another thing that is extremely important is they lose their voice, or regarding counseling regarding that has to be done. And there is a whole in ENT department, there's a whole setup where they are counseled about it, right? So as far as anesthetist, all this we have to, and patient is very, very anxious. So would you like to give anxiolytic to him?
Ma'am, since my patient, the chink is adequate and the anesthetic technique which was used before didn't have any issues. So I can give sedation to
We
this
would
patient
still
under
avoid it.
monitoring now.
We would still avoid it. At night, we would not like to give it. So what I'm trying to say is this patient pharmacological management for anxiolysis is probably something which may not work. Let's play safe, because they will be in ward and we really do not know how they fare once they are sedated, because we do not know how their airway would behave. After all, it's an upper airway involvement. So that is something we will avoid. But there is a very, very big role of good counseling of the patient. So that you need to do. Okay. So they bring this patient in, and so once this patient comes to OT, what are your concerns for this patient?
Ma'am, my concern in this patient would be airway especially. So I would be.
So, Srinivas, can we divide our concerns either preoperative, intraoperative, postoperative, or anesthesia-related concerns and surgery-related? Because this is an easier way to remember things. So, just tell me in these headings.
Yes, ma'am. Preoperative, intraoperative, and postoperative concerns. Ma'am, my preoperative concerns would be patient's air. Since 70-degree endoscopy was done and contrast enhanced CT also was done, I would like to select the tube which I could place in the patient. Selection of the tube is a concern for me.
So it is
marking the
it is a airway related concern you have. So securing the airway, this is an anticipated difficult intubation for you. So that concern is there for you, right? Preoperative concern, maintain airway related concern is there in the preoperative period. Then in preoperative period, what else is the concern for you?
Ma'am, anti-aspiration
this is the
and
all that you have given, and hemoglobin is 10, that is okay. So primarily airway related concern is there in the preoperative period, and these are the, for that you will make, so what are the preparations that you will make in the OT keeping this airway related concern in mind?
Ma'am, I would like to prepare my difficult airway cart with all the sizes of blades and laryngoscopes. I would like to keep a video laryngoscope also. I would like to tell the technician in my OT to prepare the fiber optic bronchoscope as a standby.
Right, but that is not the first one. Very good. We'll talk about it further. So all the difficult airway cart preparations you will make, and then you will prepare your OT with all the monitoring, warm IV fluids, and then
ambient temperature.
Exactly.
IV
You will
fluids,
also have, yes,
apparatus.
very good. So
the
warming
IV drug, IV fluid.
Right. And what all monitoring you would like to keep? All non-invasive monitoring, any invasive monitoring you would like to keep?
Yes, ma'am. The surgery can be prolonged. I would like to go for invasive arterial line, ma'am. So I would
you'll make
prepare
the
for
preparations
invasive
for all
arterial
that.
line.
So these are your preoperative concerns. Blood loss may be there. So blood grouping and cross matching preparation, then positioning of the patient. These are some of the things you will prepare for. So, and interoperatively, what are your concerns?
Ma'am, intraoperatively positioning of the patient is my concern, ma'am, and airway, because it is a shared airway with the surgeon. The surgical steps that involves the airway manipulation are my concerns.
Yes,
and
yes. That is the actually, this is for all the PGs. Those who have not seen laryngectomy, intraoperative concerns are very big concerns for us. Once we have intubated the patient, after that, the time when they take out the specimen and make a tracheostomy incision on the lower part of the trachea, which is remaining, that is a very difficult step. We'll be discussing in detail later. And post-operatively, these patients they will be tracheostomized. So your concern would be managing the concern would be the tracheostomy care. Okay, let's go ahead. So this patient comes to you in your OT. How are you going to anesthetize the patient?
Ma'am, I would like to attach all the ASA standard monitors and then take initial vitals, and then record the initial vitals, and then take a wide bore cannula and attach the IV fluids. and then I would like to pre-oxygenate the patient. Since
So
my
tell me the steps of
hospital,
Dr. Srinivas, tell me the steps of pre-oxygenation and with what would you like to pre-oxygenate them?
Since my hospital has a facility of high frequency nasal cannula, ma'am, I would like to go for high frequency nasal oxygenation with 60 liters per minute oxygen.
Right. However, this is for the PGs who are listening. You do not necessarily need to give high flow nasal oxygenation, but if you have, please go ahead with it because it gives you a very wide margin of safety especially when you're doing apneic ventilation. And continued this not only for pre-oxygenation, but also as a tool for oxygenation or no DSAT, whatever you may call it. And it also gives you CPAP, some amount of CPAP, about 5 centimeters of water. 3 to 8 is given by this. So that's the biggest thing that you can do. Keep the head end up. Keep the mouth open in case if a patient is paralyzed or conscious patient, there isn't much that needs to be done. And what else monitoring that you will need to do when you are pre-oxygenating?
Ma'am, I like to monitor the saturation, continuous
and ETO2
and tidal CO.
ETO2
Yes.
and tidal oxygen, right?
Yes, ma'am.
So that is another monitoring that you will need to do. So you will pre-oxygenate this patient. In the meantime, what is your plan A of airway management?
Ma'am, my plan A would be induction and with muscle relaxant, and then intubation, endotracheal intubation with controlled
So
mechanical
how did
ventilation.
you come to this plan? What are the questions that you would have asked yourself as to what are the various steps that you would have followed to reach this conclusion?
Yes, ma'am. Ma'am, basically with any anticipated difficult airway, we would like to ask 5 questions according to ASA airway management algorithm, difficult airway management algorithm. First, I would like to ask whether it is a difficult laryngoscopy. If it is a difficult laryngoscopy, then I would like to ask whether there is any difficulty in face mask ventilation or supraglottic airway ventilation. If there is no difficulty, then I would like to ask whether there is a risk of aspiration or not in this patient. And if the question is no, if the answer for the question is no, then I would like to ask whether the patient is prone for rapid desaturation.
Right.
If the patient is this question answer is no, then I would like to go and ask for a question whether it is a difficulty front of neck axis.
So in this patient,
Based upon this, I will plan
front of neck axis. Front of neck axis, I'm sure you said you palpated it, but you can also do with the help of ultrasound before you finally anesthetize this patient. So this patient, there is difficulty in intubation. There is from previous history, we know there was no difficulty in bag mask. And however, if the chink is not adequate, it is a very small chink, there can be difficulty in mask ventilation, then you will change your plan of action. So having all this background information in mind, you know that only difficulty is difficulty in intubation. So you have chosen, which laryngoscope are you choosing?
I'm choosing video laryngoscopy as before only.
Right. So as per the guidelines by DAS guidelines and ASA guidelines, for difficult intubations, video laryngoscope should be your chosen device. Why not? You said just as standby your fiber optic. Why don't you want to use fiber optic?
Ma'am, if the chink is really minimal, I go with fiber optic bronchoscope, it would become a cork in the bottom phenomenon where I could not even oxygenate the patient. So I would like to first check with video laryngoscopy and proceed.
So this is cork and bottle appearances, basically more so when a patient is breathing spontaneously. There's no space around the bronchoscope, the bronchoscope that you have introduced. So patient, there is no breathing around that. So it's completely okay because it's a small chink. So that's really not the first thing. So you will use a video laryngoscope. Which muscle relaxant would you like to use?
Yes. Ma'am, I would like to use the intermediate acting muscle relaxant, rocuronium.
So that you can use because you know that previously there was no issue about this, and rocuronium, if Sugammadex is available, you can reverse that. However, even Scoline is not contraindication. Saxamethonium is not contraindicated in these patients. If you are not sure in difficult airway, one can use it. Okay. So this is when you are using muscle relaxant. What if you're not using muscle relaxant and the chink was narrow? What is the second plan that, what is the other plan which could have been used?
Ma'am, I would like to prefer going for awake video laryngoscopy
In that
intubation.
scenario. Okay. For paucity of time,
Yes,
I'll
ma'am.
quickly, Srinivas, I'll quickly summarize it for the students. Awake fiber optic, all of you are well aware about doing awake fiber optic intubation, but please remember that you can also do awake video laryngoscopic intubation. You will have to make all the preparations of preparing the airway as you do for awake fiber optic. Only thing that you don't need to do is you don't need to make any preparations of the nasal cavity. Lignocaine, your nebulization, and when you do the video laryngoscopy, spraying around the cords, all that will need to be done also in these patients, and believe me, it's quite easy. And the dual technique of using, in some situations, dual technique, when you have difficulty in introducing the tube through a video laryngoscope, you can use video laryngoscope and fiber optic in these patients also. So these are some of the techniques that you can use. Okay, fine, we have intubated, where you have paralyzed this patient, and you will put an intra-arterial IV line, warm fluids, catheterize the patient, and you have put a temperature monitoring, and you will have to put a NG tube definitely in these patients, because later on when their feeding needs to be done, and it will be very difficult to introduce, the whole anatomy gets distorted because the surgery is done in neck area. Some of the patients, some of the places, they do preoperative gastrostomy also for feeding, because feeding is very important. Preoperatively also they are generally malnourished because of poor intake. So that you have done, head up position of 15 to 20 degrees done. You have handed over the patient. So what are the precautions that you will take?
Yes,
That you will be sharing the airway with the patient, with the surgeon. So you have to ensure that tube is not kinking, tube doesn't come out. Continuous E2CO2 monitoring is there, and intermittently you will also be doing your ABG monitoring. Are you fine with it, Srinivas?
Yes,
I'm sure all this you have planned. So
Yes,
what happens? Suddenly there are arrhythmias. So what could be the cause for arrhythmias, intraoperative arrhythmias?
Ma'am, since the surgeon is working around the area where the carotid bodies are present, there can be intraoperative arrhythmias,
Right.
ma'am.
So the first thing that you will, what is the first thing that you do?
I will ask the surgeon to remove the pressure over the
Perfect. Very
carotid
good,
body.
very good. So remember, the moment you see arrhythmias in these situations where you should know where a surgeon is operating. So at what site a surgeon is. So you don't need to give the drugs. Just removing the stimulus itself helps in relieving it. Sometimes if that doesn't, just local infiltration with lignocaine also helps in that area, right? The second, suddenly if there is sudden drop in ETCO2, what could be the cause?
Ma'am, it could be venous air embolism because
Yes.
the IGV is in the proximity.
Very good, very good. Right. So they are, and sometimes they are doing extensive neck dissection. Depending upon what type of surgery, a lot of blood loss can be there. Great vessels may get injured. So all that you have to keep in mind. Please, to the postgraduates, don't sit in one corner. Don't see only the monitor. You have to see what is happening at the surgical site, what step a surgeon is operating on. Otherwise, you will really be caught unawares when you suddenly face a complication. So these are some of the things that you keep in mind. Now your surgeon tells you that I am taking out the specimen. Be prepared to take, this is what a surgeon is going to tell you. He will tell you, sir, be prepared. You have to take the tube, the oral endotracheal tube out, and I will need to put a tracheostomy incision on the trachea, and there you will have to put a flexometallic tube. So now, Dr. Srinivas, can you share the pictures? I'll explain it to the students as to what are those steps, because nowadays it's not very common to see total laryngectomy. So these steps are very, very important. You should see what happens is, so if you look at this, this is the time when they are taking out the specimen. And now you can see before completely removing the specimen, the surgeon is making a nick at the trachea. This is trachea. Surgeon is making a nick at the trachea. At this time, our tube is still in situ, right? So now after making a nick in trachea, the surgeon, we ask the surgeon only to do it, because this has to be, this is a sterile area and our tubes are also sterile. We choose either the flexometallic tube, or which is the other tube that we can use.
And there is a specialized laryngectomy J tube, which is also called Montando tube,
Right,
which
we'll
we
be
can
sharing
use.
the picture soon. Right, so the surgeon would be holding this sterile tube here, and while he is putting the tube in, we are supposed to pull the tube from mouth out. The next picture, please, Srinivas.
Yes, ma'am.
Yes. So if you look at this, you see he has inserted this, and can you see the cut section here? What happens is the trachea is cut from here. The specimen, larynx specimen is cut. 1 or 2 rings of trachea may be gone, sometimes up to 3/4, depending upon what here we can see it has been cut. You can see the lower end of tracheal tube. So tracheal tube has been removed. The surgeon has introduced the flexometallic tube here. And side by side, alongside, surgeon is also making an incision on the skin, because this incision is on the this incision is on the trachea. This tube needs to be taken out on the skin, so this tube will eventually come out on the skin. Next pictures, please. So what we will do is, while he's sharing these pictures, this tube we will take out of this hole. Okay, and then please ensure that this is properly fixed on the skin. Look, can you see this? It has been taken out of this hole. It has been stitched here, because what is happening is, if we do not stitch it properly, if we just put a leucoplast or a dynaplast, this can still come out, because there is a lot of movement in this area, and then it will be very, very difficult for us to maintain the airway. So this step is extremely important. Please take care of this step. So Srinivas, this step was undertaken. Before doing this step, we have to ensure that we give 100% oxygen, and while we are giving, very good. And what else will you do to prevent awareness? While giving 100% oxygen, your inhalation will not help, because everything is getting lost.
Increase the depth of anesthesia.
Very good. By using
I would
TY.
like to increase the depth of anesthesia and TY, yes, ma'am.
Perfect. Very good. So this is the most important step in the intraoperative period, for which we have to make preparation accordingly. And you should also wear sterile gloves and all. Make this preparation, monitor your patient well, give 100% oxygen before doing this procedure, maintain adequate depth of anesthesia, put this tube in, suture this tube in. So this has been done. Here you can see the surgeons have sutured it. So now and before doing that, you have to ensure that you have, before you remove the tube in, you have to ensure that you do proper suctioning and all also. So Srinivas, this has been done. The surgeon says it's complete. Now you need to reverse this patient. Would you like to electively ventilate, or can we reverse this patient?
Ma'am, I would like to reverse the patient if the patient is completely awake and following all my commands. So before extubation, I would like to put the patient on 100% oxygen, and then give the reverse. Before reversing, I would like to suction the tube, my flexometallic tube, and then introduce an air exchanger, and then under vision, I remove the flexometallic tube and introduce a tracheostomy tube of the same size.
Very good. So what we are trying to emphasize is, this is one tube which eventually will have to be replaced with a tracheostomy tube. So we are doing it under controlled condition in the OT. These sutures that we had put, because we wanted that our tube should be safe. It should move at the time of manipulation when the surgical procedure is going on. So now however, this tube needs to be changed, but this tracheostome which has been made is very fresh. So we need to put an airway exchange catheter in through this flexometallic tube or a Montando tube. However, in our hospital, we do not have. Those who have will definitely be using this. And then through that, take this tube out, and over that we put a tracheostomy tube, and then fix the tracheostomy tube accordingly. And after that, we will give the reversal. Srinivas, and what else will you do? Give the reversal. What all will you do besides that? reverse the patient, and for analgesia and all, you will do something?
Yeah, I would like to ask the surgeon to locally infiltrate the area with 0.1 to 5% bupivacaine.
Right.
Surgeon will also place a drain.
Can be done, and then of course paracetamol, multimodal analgesia is a dictum for any kind of surgeries. So you can give paracetamol. Even diclofenac is not contraindicated in this patient. You can give tramadol, you can give fentanyl, whatever is your hospital practice that you can give following this. Post-operatively, these patients, sometimes when you find that it is the effects are not adequate or some other problem is there, see, they may need to be kept on PSP or whatever, some mode, but most of the times we are able to reverse them if the pre-op condition was good, if associated comorbidities like chest condition was fine, no cardiac conditions were there, there is no other contraindication, we are able to reverse and we put them on TPs and shift them in the post-operative period. Humidification needs to be done, patient needs to be kept under close observation, monitoring needs to be done, intraoperatively urine output, post-operative urine output, and yes, intraoperative ABGs were done. Post-operatively also you will monitor once at least these ABG values. Right? Anything else that you would like to add, Srinivas, besides what we have done?
Ma'am, post-operative care of tracheostomy is important, and post-operative oxygenation of the patient with post-operative anesthesia is important. And after that, early nutrition according to protocols, early drain removal, and early ambulation of the patient is important in this case. And I would like to rehabilitate the patient with speech therapy and all the options of processes that the patient have.
Very good. So basically, as far as whenever in today's date and age, whenever you talk of any surgery, one is thromboprophylaxis, two is ERAS. These are two things that you are expected to be aware of. However, for laryngectomy surgeries, there's really not a very, very well-defined ERAS protocol. But like any other surgery, you start mobilization early, you hydrate the patient well, you start the nutrition early, and of course, thromboprophylaxis, we had given give good post-op analgesia, remove the drains early, and in this patient, since half of the thyroid was removed, so you will keep a close watch on your calcium levels. And later on, also keep in mind that these patients could be requiring thyroxine. So that also you'll have to keep in mind. Is that clear? Very good, Dr. Srinivas.
Yes,
you have managed this patient very well, comprehensively, starting from pre-op, starting from taking a detailed history. You took a very good history at the time when the first surgery was done. This needs to be emphasized time and again that whenever you take these patients up for definitive surgery, you should always look for previous records. Sometimes they send these patients home, the previous records are lost. Some kind of information you can get from his patient also, where they can tell you whether ICU care was needed, whether ventilation was required, or sometimes even at that time tracheostomy may be required. These patients who have, this patient was giving you a history of stridor, which is an upper airway obstruction. Stridor is mainly inspiratory, sometimes expiratory. So sometimes they can present to you in emergency with stridor. So emergency tracheostomy may be done. There also the role of anesthetist comes into play. So Srinivas, I would like to see your picture before we end this discussion and then hand over to Spriya to finally summarize it. Srinivas, can you please come over?
Yes, ma'am.
Thank you, Srinivas. Very well presented. Excellent presentation, Srinivas.
Thank you, ma'am. Thank you, ma'am.
Very good. Now I'll hand over to Dr. Spriya to summarize the case. Dr. Spriya, please summarize the case.
It was a very good presentation by Dr. Srinivas and a very well discussion. between you and Dr. Srinivas. So I'll be dealing with the anesthetic consideration for total laryngectomy and a brief summary about the tracheostomy care. So first we'll be going with the anatomy of larynx. Larynx allows phonation and breathing, and also an important part of human airway. It also assists with coughing and uses airway during swallowing. So aspiration is limited. The position of larynx is between the third and sixth cervical vertebra, and it extends from the epiglottis to inferior border of cricoid cartilage. It consists of 9 cartilage, out of which 3 are paired and 3 are unpaired. Besides that, there is a true and false vocal cord, intrinsic and extrinsic musculature, and intrinsic and extrinsic ligaments. Superior and inferior laryngeal arteries and veins drain the larynx, and lymphatics drain deep cervical lymph nodes. And superior and recurrent laryngeal nerves, which are branches of vagus nerve, they supply the larynx. So this is an indirect laryngoscopic view and an endoscopic view of a normal larynx. So I will briefly discuss about the incidence and prognosis of CA larynx. So laryngeal carcinoma is the most frequent head and neck cancer. It is the 7th most common malignancy in males in India and 9th most common in worldwide. It is mostly seen in males, and the male to female ratio is 4:1, and it accounts for 3 to 6% of all the cancers in males in India. Mostly the patient will present in their 6th and 8th decade of life, and it can be divided into supraglottic, glottic, or subglottic tumors, out of which glottic tumors form the 60% of all the laryngeal carcinomas. If the treatment is provided at right time, the 5-year survival rate after treatment is approximately 28%. As the laryngeal carcinomas are locally spreading cancers, the involvement of thyroid can be 1 to 30%. So in most of the total laryngectomy cases, thyroid, either partial thyroidectomy or full thyroidectomy can be done. The risk factors for the laryngeal carcinomas are tobacco use, alcohol, viral infections, occupational exposure of asbestos, nickel fumes, and if there is any family history of head and neck cancers, beside this, some genetic syndromes and laryngeal dysplasias. The combined effect of smoking and alcohol consumption account for 89% of the laryngeal cancers. Total laryngectomy is actually the en bloc removal of laryngeal structures, which includes the hyoid, epiglottis, and a variable amount of upper trachea, and a partial or total thyroid glands can also be removed. There is a creation of permanent tracheostome and the repair of pharynx. The pharyngeal reconstruction is done with either pedicle flaps or free tissue transfers. Along with that, modified radical neck dissection or selective neck dissection can also be taken place if the cancer is in the advanced stage. So the most common indication is advanced laryngeal carcinomas. And besides that, some less common indications are trauma to the larynx, some chemical burns, or the laryngeal fistula. Mostly it is done as an elective procedure, but if the patient presents in stridor, it can also be done as an emergency procedure. As per surgery, it is an intermediate risk surgery as it does not involve the opening of the major body cavities. Some laryngeal conservation procedure surgery also hemi or partial laryngectomy. In transoral laser microsurgery, voice is preserved, and along with that, supraglottis laryngectomy also voice is preserved. Now, the challenges to the anesthesia, it is a difficult airway. Both mask ventilation and fecal intubation can be difficult. Airway is not only shared, but it is operated upon. There can be therapy or chemotherapy process, and they can reduce mobility of the surrounding structures. As most of the patient present in 6 to 8 decades, it is a GERD population, and the patient can have multiple comorbidities. Although rare, but the complications surgeries can occur, which can be bleeding, air embolism, or nerve palsies, or thoracic duct bleeding. Some other problems like local tissue infection, high level of anxiety, malnutrition also there. Patient most commonly presents with persistent coldness. In glottic carcinomas, coldness is an early symptom, and Besides that, there can be cervical lymphadenopathy, anorexia, and weight loss. Some patients might present with sleep disturbances and frequent wakening up night with breathing difficulties, which suggests of critical obstruction is present. It is an advanced disease. If there is a positional exacerbation of airway symptoms, it can be often due to supraglottic or pedunculated glottic tumors. So these are the symptoms of laryngeal cancers, which I have already discussed. Now, the preoperative management. So pre-anesthetic evaluation, optimization, and prehabilitation is very important in such patients. Relevant history and thorough airway examination, along with systemic and site and local examination, should be done. Investigations, imaging, endoscopy has to be done preoperatively. If there is any comorbid state, it has to be optimized. Care of nutrition and hydration has to be taken care of. There should be cessation of smoking and alcohol. And in post-operatively, tracheostomy care is very important. Besides that, patient needs to be counseled for post-operative speech and rehabilitation. History, I'm not going into the details, but it has been already been discussed. But a detailed history has to be taken. And a history of opioid and narcotic abuse is very important, as we have to plan this patient for pain. There can be associated respiratory diseases, and most of these patients are heavy smoker, and COPD are very common in these patients. Particularly high-risk surgical candidates are those who present with pulmonary hypertension and right heart disease. And dyspnea from upper airway obstruction must be differentiated from dyspnea due to chronic airway diseases. PFT and flow volume loops can be helpful, but further investigation needs to be done, as these are not very well suggestive of the upper airway obstruction. Appropriate ABG analysis can be done to know the patient's ventilatory status and to plan the post-operative ventilatory management. Steroids, bronchodilators, smoking cessation, and chest physiotherapy may also be beneficial in such patients. Then these patients can have associated cardiovascular diseases, out of which congestive cardiac failure appears to have a very important prognostic significance. So a cardiologist's opinion has to be taken, and all the cardiovascular diseases need to be pre-optimized. Such patients can be chronic alcoholic, and they can have a deranged coagulation profile and liver functions test. Besides that, other problems of chronic alcoholism can also be present. Radiotherapy and chemotherapy are sometimes given to these patients in the preoperative state, and which can lead to airway-related changes, which can make our mask ventilation, laryngoscopy, and intubation even more difficult. Besides that, chemotherapeutic drugs such as cisplatin and all can cause myelosuppression, cardiotoxicity, electrolyte abnormalities, and lung-related complications. So the routine investigations which we would like to send in such patients would be hemogram, KFT, LFTs, coagulation profile. A baseline thyroid function test is an important thing. Besides that, chest X-ray, X-ray KP lateral view, and ECG are routinely asked in such patients. Exercise tolerance testing can be done either using METs or CPET for risk stratification, but it is contraindicated if there is a critical airway stenosis, as it can lead to airway obstruction. Indirect laryngoscopy, CT scan, and MRI tells us about the growth and the function of the cord and how our intubation and other plan will be successful or not. So optimization in the elective surgery, it has to be started 4 to 6 weeks prior to the elective laryngectomy. Nutrition assessment and correction of anemia has to be done. There should be smoking cessation, controlled alcohol withdrawal. If the patient has diabetes, the blood glucose optimization should be done. There should be psychological interventions also, like meditation and deep breathing exercises. And some scoring system can predict the morbidity and mortality in such patients, like POSUM, SORT, APOCHE 2. Airway assessment according to line of AMF, line of sight for airway assessment, it has to be done and documented very well. And according to that, plan A, B, C, D should be well known and written. There are other airway concerns like pre-op tracheostomy in such patients is mostly avoided. This is associated with poor wound healing, and there are high chances of reoccurrence in tracheostomy stoma, especially after radiotherapy. And there can be preoperative signs of airway obstruction like dysphagia, voice change, breathlessness, and orthopnea. Frozen larynx is fixed immobile larynx with cord paresis and dysphagia needing tracheostomy and gastrostomy. The size of endotracheal tube is predicted based on the indirect laryngoscopy visualization and nasal endoscopy. Normal PVC single lumen tubes or MLS tubes can be used, but special tubes like laryngectomy J tube, Montando tubes, or reinforced flexometallic tubes can also be used. Now, what device is selected for laryngoscopy? Video laryngoscopes are most useful device as they give you the optimal glottic view. The fiber optic bronchoscopy, though it has a role in supraglottic growth, if there is a narrowed laryngeal aperture in which the aperture diameter is equal to the diameter of fiber optic bronchoscope, it can lead to laryngeal aperture completely blocked and we can lose the airway. Such phenomena is known as cork in bottle phenomena. And before that, planning and predicting for the difficult front of neck access is also very important. So site and approach to fauna for emergency tracheostomy or cricothyroidotomy should be marked and communicated to the surgeon. Nasendoscopy is an important investigation, and it gives us about the assessment of the airway, nature and mobility of the tumor, if there is any vocal cord movement or present or not, and there is any risk of potential airway obstruction or not. Then the preoperative preparation, a well-informed consent should be taken. ICU bed should be reserved. Patient should be kept nil per oral according to recent ASA guidelines. If he is taking any current medication for any comorbidity, it needs to be continued or stopped in accordance with the need and after discussion with the specialist. Blood and blood products should be arranged. Anti-aspiration prophylaxis should be given. We should avoid sedatives, and anti-anxiety medications, if given, it should be given cautiously, although it is mostly avoided. Difficult airway cart needs to be prepared, and an ENT specialist should be scrubbed and be ready for the emergency tracheostomy if it is required. So this is a surgical technique for total laryngectomy. And the most common incision we give is a U-shaped Gluck-Sorensen incision. And when the trachea is resected from the larynx, a tracheum is formed. And at this point, ETT is withdrawn and a laryngectomy tube is used for the remainder of the procedure. And it is secured at the chest. At the end of the surgery, a cuff tracheostomy tube is inserted for first 24 hours. And it helps with suctioning and aspiration, although if the patient can be extubated, well-awake controlled extubation should be done. It's an ideal shared airway, and for an ideal shared airway, there should not be any risk of aspiration. Adequate oxygenation and ventilation should be maintained. A clear motionless surgical field should be given. There should be smooth emergence, and the patient should remain pain-free, comfortable, and alert at the end of the surgery. Now, the surgical consideration and team planning. Formulating airway management strategy. This has been already discussed, like whether we are able to pre-oxygenate the patient or not. Is bag and mask ventilation possible, or is it difficult? Is it possible to get a good view of glottic during laryngoscopy? Is intubation easy or difficult, or is fauna possible or not? So pre-oxygenation should be done in a comfortable position. There are various methods to do the pre-oxygenation, HFNO, Thrive. CPAP can also be provided, and no DSAT approach can be done. Jet ventilation and tracheostomy, if required, it can also be done in emergency situations. Now, the face mask condition, it can be difficult in a very laryngeal inlet. And depending upon the location of the obstructed face can be easy or difficult. If there is difficulty in face mask ventilation, we can move on to the next step of the airway plan immediately. And that's why plan A, B, C, D should be well written and documented. Video laryngoscopes have a greatly ease the visualization of larynx. Muscle relaxant, if used, it can provide a good optimal intubating conditions in case if there is a non-obstructing lesion and mask ventilation is possible. Succinylcholine usually avoided because of its short duration, and the surgery is a very long duration surgery, but it can be used if airway has to be secured. And rocuronium is reliable when repeated attempts are anticipated, and Sugama-Dex is also available. And fauna is likely to be required if ventilation is not possible in any of these ways. Preoperative imaging can help predict if passing a small diameter tube is possible or not. And awake tracheostomy always has a fallback strategy. The placement of local anesthetic in anterior neck prior to any intubation can make awake tracheostomy more comfortable, because when there is a high degree of obstruction, the patient might so the
Tech team. Now tech team on it, and we can't.
Tech team, can you please check? We cannot.
Spreha has to talk about tracheostomy care also. So please show her slides.
Yes, ma'am. This is the video
to directly trade.
You can skip this. Priya, we have already shown it. You may go ahead. This video we have shown as pictures. If you are not able to play, you can show your slides.
So the anesthetic consideration, if the patient is already tracheostomy, there should be close communication with surgeon, and backup plan for difficult airway has to be there. It is a shared airway. There can be potential catastrophic complication like loss of airway, false drag, or hemorrhage or pneumothorax. And for emergency surgical tracheostomy, consider it as a full stomach, and difficult airway cart should be kept ready with backup plans. For elective tracheostomy, optimize underlying coagulopathy if present. Now, prerequisite in tracheostomized patient in OT. These are the prerequisite. Suction should be checked. Similar sized tracheostomy tube and one downside should be kept as backup. Determine if trachea can be intubated orally or not. And difficult airway cart along with airway exchange catheter should be prepared. If tube is too short, it can cause reduced pulmonary compliance and persistent cuff leaks and tracheal damage can be there. If it is too long, risk of endobronchial tube placement can increases. For confirmation of appropriate tracheostomy tube position in larynx, a combination of below is done. None of the above method is fully reliable when used alone. Tracheostomy weaning protocol. When the patient has a good cough, he or she can manage own secretions adequately, and suctioning requirement is minimal or is reducing, we can go to the following step. There can be cuff deflation, progressive cuff deflation, and progressive use of one-way valve to achieve 24-hour cuff deflation. Then capping of tracheostomy tube, and for an agreed length of time, the cap is to be tolerated. Then we decannulate and do a firm airtight dressing at the stoma site. Early short-term and long-term complications of tracheostomy can occur. Early can be hemorrhage, aspiration, or there is a failure of procedure. Short-term can be, there can be blockage of the tracheostomy tube, tube displacement, any infection, surgical emphysema, tracheal necrosis. And in long-term, it can be tracheomalacia, tracheal stenosis, tracheocutaneous fistula, decannulation problems. So this is a chart for emergency tracheostomy management. Tracheostomy care. Daily tracheostomy care is very important. All the equipments and the monitors should be checked. The procedure should be explained to the patient. Regular suctioning of the tracheostomy tube has to be done. The inner cannula should be cleaned, and the stoma site should also be kept clean and uninfected. The changing of tracheostomy tube ties should be done, and the first tie change should be done by the ENT specialist. Then after cleaning the inner cannula, it has to be replaced, and the reassessment of the patient should be done. Look for any bleeding, displacement, or blocking of the tube. And if there is any secretions, good suctioning should be done. The frequency of suctioning depends upon the amount of secretion. If a vigorous suctioning is done, it can lead to injury to tracheal mucosa. Each suction should not be longer than 5 to 10 seconds, and routine use of 0.9% sodium chloride into tracheal tube is not recommended. For prevention of crusting and tracheitis, humidifiers like bubble humidifiers or HME filters can be used. Besides that, ultrasonic nebulization can also be done. Whenever the inner cannula is removed, it should be cleaned, and it should be daily removed and cleaned for first 3 days. Once it has been cleaned, it should always be placed back. And outer tube, unless blocked or displayed, should not be removed for 3 to 4 days. This will allow the tract to be matured. For the stoma care, it immediately start in the post-operative period and inspect the stoma site regularly. It has to be kept clean and dry, and the integrity of the skin should be maintained. Daily cleaning of stoma is recommended with 0.9% sterile saline solution. After daily cleaning, ensure dressing is inserted at the stoma site. Other than the tracheostomy tube care, the other care in the post-operative period consists of feeding and nutrition, the oral care, and the communication and post-operative voice rehabilitation should also be taken into consideration. And finally, the patient is moved back into the community. These are the things by which post-operative voice rehabilitation can be done. There can be voice prosthesis or tracheoesophageal puncture can be done, or a laryngeal speaker can be used. Now, what if the patient of a post-total laryngectomy presents for any other surgical procedure? Such patients can have complications like tracheal stenosis, tracheomalacia, and they can have an increased risk of aspiration, and difficulty in ventilation. Pharyngocutaneous fistula are very common in the post-operative period in such patients. They cannot be oxygenated or ventilated, and sometimes they cannot be intubated via oral or nasal route. So for such patients, we always consider them to be a difficult intubation and bag and mask ventilation. If intubating and securing airway in patient with partially removed larynx has to be done, then tracheal intubation with a possible smaller size tube can be done with use of video laryngoscope. And if there is a total laryngectomy, we can always use a pediatric face mask over the stoma, or an inflated LMA, or via catheter mount over the stoma. The cuff tracheostomy tube or J tube or tracheal tube can also be placed via the stoma if securing airway is necessary. And for low-lying stoma, low volume, high pressure cuff ETT to be used, as they sport a smaller cuff length. So in conclusion, patients who present for total laryngectomy are usually elderly and they present with significant comorbidity. There is sharing of airway and also the airways shared upon. So primary and backup airway plans need to be discussed. Video laryngoscopes, HFNO have made the managing such cases very easier. A good communication between the anesthetist and surgeons should be done. And it is a multidisciplinary approach. So whenever required, help can be taken from the different specialities. And this is the references. Thank you.
Thank you, Dr. Spriya. It was a very, very extensive and and absolutely complete presentation. This is for the postgraduates. She has included a detailed slide of how to manage tracheostomy. In your exam, you may get a separate short case only as a case of tracheostomy. So besides this, the questions which are asked in a case of tracheostomy is the types of tracheostomy, and yes, is still the choice. So these are some you have in mind. Every that we done in case, specifically she talked about
Good afternoon, everyone. Sorry, there must be some technical glitch. So thank you so much, Nija ma'am, for this enlightening session. Total laryngectomy, obviously, it's not a very common case nowadays, and so many residents have not seen. So by this lecture, they have gained so much of knowledge. Thank you, ma'am. Thank you, Spriya, for this summarizing it, and thank you, Srinivas, for this case presentation. Thank you, ma'am. Thank you so much.
Thank you, Dr. Jyoti. Okay, thank you, Spriya.
For the next session of ABG and inhalational agent, I would like to invite Dr. M.D. Kaur. Ma'am will moderate this session. Ma'am is pioneer of Appec programs, which we are learning. Ma'am is pioneered Appec programs. She received Pratibha Samman Award. She is an ex-ISA Delhi president from 2022 to 24, and ma'am has several publications in national and international journal. I want to add one more thing. Ma'am is my guide during when I was a postgraduate student. I welcome you, ma'am. Thank you, ma'am.
Thank you, Jyoti, for the nice introduction. You may continue to invite the speakers. So, our next speaker is Dr. Sandeep Kumar. His designation is Professor of Anesthesia and he is affiliated with Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. And to his credit, he is a BLS and ACLS instructor. He has received Certificate of Merit for scoring highest marks in good clinical practice, current regulatory trials research in India held on 23-24-2019, organized by CDCA, Department of Biotechnology, Government of India, and has been awarded appreciation certificates for anesthesia services from the Lifeline Express and World's First Hospital on a Train from Impact India Foundation. He has participated as faculty in various conferences and workshops. Over to you, Dr. Sandeep, for your topic.
Hello everyone, I am Dr. Sandeep Kumar. I am working as Professor Anesthesia at Dr. RML Hospital, Delhi, associated with Atal Bihari Vajpayee Institute of Medical Sciences, and I will be presenting my class on arterial blood gas analysis. Yeah. If you see about the introduction part, yes, ABG tells us about the pH of the blood, PaO2, which gives us an idea about the oxygenation of the blood. PaCO2 value gives us information about the ventilation part of the patient. Bicarbonate, yes, bicarbonates tells us about the bicarbonate content of the blood, which further guide us towards the metabolic acidosis or alkalosis in the blood, and the saturation value. Fine. So these are the values which we obtain from ABG. And see, ABG is just a piece of paper unless and until you correlate the ABG with history, examination, treatment history, previous ABG report, and other blood and radiological investigation of the patient. Fine. If you try to interpret the ABG and try to correct it without knowing the history and examination and what the treatment the patient is getting at present, you may not be able to decide the treatment properly. Fine. About the normal values, yes, the pH has got normal value in between 7.35 to 7.45. PaCO2 should be between 35 to 45 millimeter of mercury. PO2 values should be between 80 to 100 millimeter of mercury, and bicarb should be between 22 to 26 milliequivalent per liter. Saturation value should be more than 95%. The saturation value and the PaO2 value depend upon the patient. It may vary from patient to patient. And to be honest, practically PaO2 should be more than 60 millimeter of mercury, and the saturation value should be more than 95% of fine. And this is how ABG sampling is done. And if you notice how he has positioned the hand of the patient, there is a towel in just below the wrist, and he's holding the ABG syringe in a pencil-like position, fine, and keeping it at 35 to 30 degree, and palpating it with the left hand and withdrawing the sample. See, if you are aiming to insert an ABG indwelling catheter, it is recommended that one should do a proper surgical hand wash and put a sterile gown and drape also, and then do the insert the ABG indwelling catheter. And about arterial sampling, yes, direct percutaneous puncture of the artery can be done as I showed you before, or arterial catheter can be inserted with all the sterile technique, fine, if there is an indication. And what are requirements for artery sampling? Yes, consent is required if you are aiming to insert an indwelling arterial catheter. Allen test should be done. It is of two types, non-modified and a modified approach that I will tell you later. And yes, use of ultrasound, if it is available, it is helpful in case of pediatric obese patient or difficult cases of the patient which are on inotropes. ABG sampling technique. It can be collected from radial artery, brachial artery, or femoral artery. One should use heparinized syringe always, and perform Allen test before the ABG sampling. Ensure hemostasis. Suppose one has taken the ABG sample, one has to achieve it is required to achieve hemostasis with the help of pressure and keep it there for 4 to 5 minutes. may be required for a longer time if the patient is on antiplatelet drugs or having DNH coagulation profile. And it is important to label the sample properly. The name of the patient, the CR number should be there. Fine. One should put at what FiO2 the sample is taken. Fine. And yes, one should use ice if you are transferring sample for further analyzing the sample. Analyze within the 15 minutes. There should not be any delay in analyzing the sample. Otherwise, the result will not be good. This is the picture which I have taken from ABG book on and written by Shapiro, and the image is showing how to perform a modified Allen test. See, the modified Allen test needs patient cooperation. Fine, you have to tell your patient to make a fist, make a fist and repeat it 2 to 3 times, and while you occlude both the radial and ulnar arteries with your fingers. And by keeping the radial artery occluded, you release pressure from the ulnar artery. You will see, you will notice a gush of blood on the palm of the patient. Fine, it confirms the patency of the ulnar artery. So what you have observed that the modified Allen test need patient cooperation. It cannot be done in case if the patient is not cooperative or patient is under anesthesia. Fine, whereas the a conventional test, that is non-modified Allen test, fine, patient cooperation is not required. You can do it. Fine. So this is the difference. Sampling technique, aseptic precautions should be taken. ABG kit, yes, if it is available, should be used. Heparinized syringe, one can use. Nowadays, we use plastic syringes, and before the glass syringes were used, and they usually don't interfere with the ABG results. That's why, and they minimize the diffusion of the gas. So the results achieved with glass syringes were good as compared to our syringes which we use, but they are difficult to maintain. That's why nowadays we use plastic syringes. 20 to 25 gauge needle can be used. Sterile gauze, bandage, proper positioning should be used. And for transporting the sample from one place to another for analyzing purpose, one should use ice bag. About sample transport, send it to the lab as soon as possible. That is, within 15 minutes, it should reach the ABG analyzer. Avoiding delay. See, it helps in it reduces oxygen consumption and gas diffusion through plastic syringe. So one should avoid delay. There should not be air bubble inside the ABG syringe. Fine. One has to remove it by gently tapping it. Fine. Once you get the ABG sample of your patient, just mix it between, gently roll it between your palm. Just avoid vigorous shaking of the sample. Fine. And other sources of error are sample left prolonged period at the room temperature. So one has to process the sample within 15 minutes. Gas diffusion through the plastic syringe can happen. Consumption of oxygen by the leukocytes can happen. If you are using more of the heparin, it will interfere with the result. It can dilute the PaCO2 value and affect pH. It is recommended that one should use at least 2 ml of blood. Nowadays, we have got sophisticated machine. One can do ABG with 0.5 ml of blood also. And the sample should be air bubble free. And otherwise, what will happen? There will be more of PaO2 values and less of there will be more of PaO2 values and low PaCO2 values. So one has to remove air bubble through the ABG syringe. Improper mixing. See, one has to mix the sample in the ABG syringe by rolling between the two palms around 8 to 10 times. Avoid vigorous shaking of the sample, which can result in spillage of the sample, and it can also increase the air bubble size, which can again interfere with the result. About acid-base balances basics. As we know that the pH, if the pH is less than 7.35, we call it acidosis. If pH is more than 7.45, we call it alkalosis. Respiratory component, see, we have to look for the PaCO2 values if we want to assess the respiratory component, and by cough, we want to assess the know about the metabolic component. Steps for ABG interpretation, it is recommended that one should interpret the ABG in a stepwise approach. Fine. First of all, you should check for the pH. If it is less than 7.35, we call it acidosis. If it is more than 7.45, we call it alkalosis. check the PaCO2 values. Fine. If the PaCO2 values are higher than 45, then the component is respiratory. It is respiratory acidosis. If the PaCO2 values are less than 35, we call it respiratory alkalosis. Check for the bicarbonate in the third step. Fine. If the pH is higher side and the bicarbonate is also more, then it is metabolic alkalosis. And if the bicarbonate is low and the pH is also low, that is they are moving in the same direction towards the lower side, then it is metabolic acidosis. Determine the compensation part. That this will be discussed later with the help of compensation equations which we apply to the sample. Fine. Assess oxygenation. PaO2 and the saturation SaO2 values tells us about the oxygenation status of the patient. And types of acid-base disorders. These are the main types of respiratory disorder. Say respiratory acidosis, we observe less pH and more of PaCO2 values. Respiratory alkalosis, we observe more pH, that is pH will be higher and less PaCO2. In metabolic acidosis, pH will be less, that is less than 7.35, and bicarb will be less in case of metabolic acidosis. Whereas metabolic alkalosis, pH will be higher and the bicarbonate will also be on the higher side. About the compensation mechanism, see, lungs and kidney play major role in as compensation of acid-base balance in our body. If we talk about the respiratory compensation, fine, it takes minutes to hours. If we talk about renal compensation, it takes around hours to days. We can understand this with the help of an example. Fine. As you know, as I told you that the renal compensation take more time. It takes about hours to days. You must have read about head injury patient, how you prefer ventilation for head injury patient just to decrease the ICV. You prefer hyperventilating these kind of patients. Fine. So if you want to achieve a low PaCO2 value, do hyperventilate the patient to keep the ICP lower side. But see, it is recommended to hyperventilate such patient for 4 to 6 hours only. Fine. After 4 to 6 hours, the renal compensation take place. Fine. As I told you that it occurs at the renal compensation complete within hours to days. Fine. After some time, then this hyperventilation which you were doing it for the sake of the brain injury patient becomes ineffective, because the renal compensation, what it does, it again increases the bicarb, and this your if you are attempting to lower the ICP by decreasing PaCO2 will become ineffective. Fine. About full compensation, you call it fully compensated ABG if your pH lies between 7.35 to 7.45. See, if your pH lies in between this range, you call it fully compensated ABG. For example, if your pH is say 7.34, fine, you call it uncompensated or partially compensated. It depends upon the type of compensation which you will find out with the help of equation. Fine. Or even if the pH is 7.46, fine, again you will call it partially compensated or not compensated ABG as per the given scenario. Partial, if the pH is still abnormal, you call it uncompensated or partially compensated ABG. We will learn it with the help of examples. For example, these are the compensation formulas which we use in case of metabolic acidosis. As we know, in case of metabolic acidosis, there will be less of bicarb and the body will try to compensate by hyperventilating. So there will be change in the PaCO2 values in case of metabolic acidosis. This compensation of PaCO2 can be calculated. It will be equal to 1.5 into the provided bicarb plus 8 plus minus 2. Fine. So whatever value you will get, fine, will give you idea about the PaCO2 change which will happen in metabolic acidosis. Fine. In case of metabolic alkalosis, as we know, in metabolic alkalosis, what will happen? The pH will be more than 7.45 and the bicarb will be more, and the body will try to compensate with the help of increasing the PaCO2 values. Fine. So for the change in PaCO2 value in case of metabolic acidosis will be calculated by 0.7 into bicarb minus 24 plus 40 plus minus 2. This will give you a value which will tell you whether the PaCO2 change is in compensation range or not. Fine. Similarly, in respiratory acidosis, it has been seen that in acute respiratory acidosis, increase in bicarb by 1 for each 10 10 increase in PaCO2. So if it is acute respiratory acidosis, the bicarb will increase by 1 milliequivalent per liter for each 10 millimeter rise in PaCO2 values. Fine. In case of chronic respiratory acidosis, you again expect change in bicarb by around 3.5 milliequivalent for each 10 millimeter rise of PaCO2 values. Fine. In case of respiratory alkalosis, in case of acute respiratory alkalosis, you can observe that there will be decrease in bicarb by 2 milliequivalent per liter for each 10 mm fall in PaCO2 values. In case of chronic respiratory acidosis, again, there will be decrease in bicarb by 4 to 5 milliequivalent for each 10 mm mercury fall in PaCO2 values. These equations are important in predicting, in finding out, if you want to find out whether the compensation is the ABG is fully compensated or partially compensated, we need to apply these equations to find out. Fine. About ABG interpretation, I have just given you an example. Suppose the patient has got a pH of 7.32, PaCO2 of 55 millimeter mercury, and bicarb of 28 milliequivalent per liter. See, pH is less than 7.35, it is around 7.32. It is clear that the patient is having acidosis. If you see the step 2, that is PaCO2 is for 55. It is more than 45. That means that it's an respiratory component. The patient has got respiratory acidosis. And if you see the bicarb is around 28 milliequivalent per liter. Fine. If you see that the bicarb, the normal range of bicarb is around 20 to 26 milliequivalent per liter. So the pH is at higher side, pH is at lower side in this case, and the PaCO2 is on higher side. Clearly, it is showing a respiratory acidosis. Fine. So it is chronic respiratory acidosis with metabolic compensation. What I have written in this example. But just I want to ask you whether is this much information sufficient for patient management? The answer is no, because we have not provided any history. We haven't provided any history, treatment, and other information about the patient. So it has to be there if we want to assess the ABG in a proper way, and if we want to decide a treatment regime for this patient. Fine. About common clinical scenarios in case of respiratory acidosis, what all condition we see respiratory acidosis, COPD, chronic obstructive pulmonary disease. If there is a CNS depression, you get to see a picture of respiratory acidosis. Patient is likely to retain CO2 values. CO2 or partial pressure of CO2 will be more in these cases. In case of respiratory acidosis, yes, you get to see, and these kind of patients, the patient is anxious or the patient is in high altitude. You get to see the patient is hyperventilating because of high altitude area, or the patient is anxious. Then there will be CO2 washout, and there can be a picture of respiratory alkalosis. Similarly, metabolic acidosis, yes. For example, in diabetic ketoacidosis, uncontrolled diabetes patient, renal failure patient, you get to see these kind of picture of metabolic acidosis. Metabolic alkalosis, for example, in case of repeated vomiting, diuretics. So what we have seen that these conditions associated with various metabolic acid based disorders. So the history is very important, treatment part is very important. So to get an idea about the patient condition and to treat them accordingly. About ABG analysis, yes, nowadays electronic automatic blood gas analyzers are used, and they have got electrochemical sensors which assess pH, PO2 values, and PCO2 values. And these two values, the saturation and the bicarb, are actually derived. Bicarb is derived using Henderson-Hasselbalch equation using above these three parameters. Fine. And yes, as I told you, the sample is affected by temperature. Results are affected by the temperature. If the pH increases, for example, pH increases and both PO2 and PaCO2 values decrease as the temperature falls. So it has to maintain that proper temperature, and there should not be any delay in processing the sample. The sample is analyzed at 37 degrees Celsius, even if the patient temperature is different. So it is recommended that the temperature should be analyzed at the body temperature. Analyzing oxygenation, see how we analyze oxygenation of the patient. The PaO2 value, that is the PaO2, the partial pressure of oxygen, and the saturation of oxygen saturation tells us about the oxygenation of the patient. Alveolar arterial gradient, yes, this difference should be in between 5 to 15 millimeter of mercury. It is the difference between the alveolar PO2 level and the arterial PO2 level. Fine. In these scenarios, yes, alveolar gas equation helps in analyzing the alveolar PO2 values. Fine. And we talk about the PF ratio. This PO2 is the ratio between the arterial PO2 and the FiO2. It helps in differentiation between the ARDS patient, acute gas lung injury patients. This oxygenation helps in oxygen delivery, assessing the oxygen delivery. So the whatever the parameters which we get by ABG, it helps in finding out the oxygen delivery in the patient blood. And hyperoxemia, hypoxemia can be assessed accordingly. See, PaO2 values are affected by the age of the patient also. So this is the formula by which, yes, the age is, you can just calculate with the help of 104 minus 0.2 into the age of the patient, and it will you will get the correct values of PO2 as per the age concern of the patient. As we analyze the oxygenation, now how we analyze the ventilation part by pH, PaCO2, and base axis. Acute and chronic respiratory acidosis or alkalosis, we can find out. Respiratory acidosis, in case of respiratory acidosis, you will observe alveolar hypoventilation. There will be increase in PaCO2 values. I told you before, there will be more PCO2 values more than 45 millimeter mercury. The pH will be less than 7.35. In case of respiratory acidosis, alveolar hyperventilation will be there. There will be decrease in PaCO2, more in pH. That pH will be more than 7.45 in case of respiratory alkalosis. In acute cases of respiratory alkalosis, you will observe low PaCO2 values and increase in pH. But in chronic case, suppose in chronic case there is a respiratory alkalosis, you will observe low PaCO2 values, and because of the compensation mechanism, you may get to see a normal pH in case of chronic respiratory alkalosis patients. Further analyzing ventilation, if in case of acute hypocapnia, fine, there can be cerebral vasoconstriction which may result in patient syncope, and there can be electrolyte imbalance also, because which can be associated with the acid-base imbalance. There can be hypokalemia, or hypokalemia accordingly. Metabolic acid-base disorder, pH, PaCO2, and base axis are important. Metabolic alkalosis, there will be rise in pH values, fine, and there will be rise in bicarbonate. In metabolic acidosis, there will be low pH, that is less than 7.35, and low bicarb, fine. Few words about the anion gap. As the law of electric neutrality says that the number of cations in the blood should be equal to number of anions. Fine. The anion gap, what is it? It helps assess the acid-base balance and electrolyte level in the body, particularly in diagnosing metabolic acidosis. So anion gap is helpful in diagnosing metabolic type of metabolic acidosis. How we calculate anion gap? Suppose say we have got sodium, potassium. Main cation in our plasma is sodium and potassium, and the main anion are this bicarb and chloride ions, and the minimal the quantity which is present in minimal amount, the anions which are of minimal importance are the proteins, they say albumin and other proteins. So how we will calculate it? Suppose there is an acidosis, there will be rise in the hydrogen ion which will be neutralized by the presence of anion in the blood. Fine. So anion gap is calculated by sodium, total sodium in the blood, or you can add sodium plus potassium. Difference in between the sodium and the chloride and bicarbonate present in the blood. This will give you anion gap. How much anion gap is there? Fine. And the normal anion gap is around 4 to 12 milliequivalent per liter. The cause of increased anion gap acidosis, it can be remembered with the help of mnemonic mud piles. That is, it is found the increase in anion gap acidosis found in methanol, uremia, diabetic ketoacidosis, paracetamol poisoning, isoniazide, lactic acidosis, ethylene glycol, or salicylate poisoning. There are some conditions which are associated with normal anion gap also. Diarrhea, renal tuberous acidosis. In diarrhea, there will be loss of bicarbonate. In renal tuberous acidosis, there will be less of absorption of bicarbonate. So we will get to see normal anion gap in these conditions. Let's do some ABG exercises. These exercises is very important. And say the patient, for example, there is a patient, adult male with deep rapid breathing and abdominal pain, and with a history of diabetes mellitus type 2. His respiratory rate is around 28 per minute. And the ABG, what the ABG showed us, the pH of 7.18. PaCO2 of around 22 millimeter of mercury. If you see that pH is 7.18, it is less than 7.35, it is indicating acidosis. Step 1. Step 2, observe the PaCO2 value. It is lower, towards the lower side. Fine. So primarily it is not a respiratory component. Fine. If you see bicarb, it is less. It is less than 22 milliequivalent per liter. It is around 10 milliequivalent per liter. It is clearly showing that it is primarily a metabolic acidosis. Fine. If you get to see a PO2 value of 96 millimeter of mercury, which is more than 60, there is no hypoxemia component as such. And if you see the anion gap in this patient, see the anion gap is 24. The normal was, it is quite higher in this patient. Fine. So in metabolic acidosis, this is with a higher anion gap. Lactate is within normal range. Say glucose is around 440 milligram %, which is showing uncontrolled type 2 diabetes or an improper treatment of the patient. The patient is in metabolic acidosis with raised anion gap. So diagnosis here is diabetic ketoacidosis. Is this compensation appropriate? See the body. If you see this, the pH is on lower side. The body and the bicarb is 10. It is primarily a metabolic component, and the body is trying to compensate by hyperventilating, by decreasing the PaCO2 levels. Fine. So this is a respiratory compensation which body is providing. So if we want to calculate whether this compensation is adequate or not, we have to use the formula which we have just discussed. Fine. Here bicarbonate is around 10 milliequivalent per liter. So expected PaCO2 value, how much the patient has expelled out. Fine. The expected PaCO2 values will be 1.5 into bicarbonate plus 8 plus minus 2. Fine. So expected PaCO2 will for this patient will be around, it will be around 23 plus minus 2. That will be in range of 21 to 25. Fine. 21 to 25. Actual and in this case actual PaCO2 values are 22, which fall within this normal range. So we can say that what we can say in this case, conclusion is the compensation is appropriate because the PaCO2 values are forming in within this range. As per this equation, compensation is appropriate but not complete because our pH is still less than 7.35. That's why. Fine. Now we can say that it is partially compensated metabolic acidosis. Fine. I think I have made it myself clear because the pH is 7.18 and the body is trying to compensate by increasing hyperventilation by removing PaCO2 body. In spite of that, the pH is in acidotic range, that is less than 7.35. Fine. And after this, we have applied the equation. We try to find out whether the compensation, how the body is responding. Fine. And we found that the PaCO2 value are 23 plus minus 2. Fine. And compensation, which we found that the compensation is adequate, that is appropriate, but it is not complete. Fine. So we can say the partially compensated metabolic acidosis. About this is another example of acute respiratory acidosis. There is a patient with chief complaint of there is a 68-year-old patient presented to the emergency with drowsiness, headache, and shortness of breath for 6 hours. This is very important. For 6 hours, he is presented to us, and non-COPD patient presented with 6 hours. That is, it's an acute event showing the ABG of 7.22, PaCO2 of 60, bicarb of 25, PO2 55, and saturation of 86%. If we observe that the pH is less than 7.35, first step, it is acidosis. PaCO2 is on higher side. Fine. The PaCO2 is around 60, which is showing it is a respiratory acidosis. Fine. The bicarb is 25. Fine. Bicarb is 25 and PO2 values of 55, which are less than 60, which is showing hypoxemia component. Fine. And saturation is also lower side. So hypoxemia is confirmed. See, expected rise in bicarbonate per 10 millimeter rise in PaCO2 is around 1 milliequivalent, as I told you before. Fine. It is around 1 milliequivalent per, but see, the bicarb in this case, it isn't within normal range. That is within 20 to 26 milliequivalent per liter. So here the diagnosis, the primary diagnosis is acute respiratory acidosis because the pH is less than 7.35 and PaCO2 is more than 45. And here the bicarbonate is normal. Fine. So we can say that the pH is low, but the body is not able to compensate. So it is with no renal compensation, because if it would have been a complete renal compensation, the bicarb should be more than 26 in this case. But here we have seen that the pH is 7.22. It is acidosis. Fine. It is respiratory acidosis, but body is not able to compensate with his kidneys. So there is no compensation. It is acute respiratory acidosis without any compensation. About chronic respiratory acidosis, this is another example. Another COPD patient, 40-year-old, and on examination we found 18 per minute respiratory rate, heart rate 84, and saturation 92%. The patient complaining of fatigue, headache, ABG showed 7.35 pH, PaCO2 of 60, and bicarb of 32, PO2 of 70, and saturation of 93. So if we see that the pH is 7.35, fine, and PaCO2 of 60, fine, and there is more of PaCO2 and less of pH. It is towards acidotic side, fine. So it is primarily a respiratory acidosis with a increased bicarb. If you see there is increase in bicarb, the body is trying to compensate, fine, with the help of kidneys. PO2 values is more than 60. There is no hypoxemia component as such, although saturation is slightly on the lower side. It's fine. And as we know that for every 10 millimeter rise of PaCO2, there is 3 milliequivalent per liter rise in bicarb in case of chronic respiratory acidosis. Fine. So if we use that formula equations in this scenario, expected bicarbonate rise, fine, is in this case is around 6 milliequivalent per liter. Measured is 32 in this case, fine. The bicarb was 32 in this case. If you see that the pH has touched the normal range, it is in between the 7.35 to 7.45. So can we say that that is a compensated chronic respiratory acidosis? Respiratory acidosis, why? Because the pH is towards the acidotic side. PaCO2 is 60. That's why it is respiratory. The component is respiratory. Fine. We have what we have said that it is compensated. We have said compensated because the pH has now pH is lying in within the normal range. So the body has compensated with the help of kidneys by retaining more bicarb. Fine. So the diagnosis is compensated chronic respiratory acidosis in this case. Take home message from this lecture. Yes, ABG interpretation is incomplete without knowing patient history, clinical examination, and other supporting investigation. Please find out the complete history and what the patient is receiving as a part of treatment. And yes, other investigation, if they are available, they will all give you and guide you towards a proper treatment regime. Fine. It is important to know the history and examination and what the patient is getting actually. Fine. Use stepwise interpretation. Always go step by step to avoid mistakes. Fine. First see the pH, then see the CO2 values, bicarb, and then go to other values. Then analyze the ABG. Do compare the ABG reports with previous ABG reports. There are chances that there can be fallacies because of the ABG machines, or there can be sampling error also. So it is advisable to see a look towards the previous ABG reports also. It will guide you towards a trend of acid-base imbalance in your patient and helps in properly analyzing a sample and get a good treatment for your patient. So previous ABG reports are also important. Do practice the ABG exercises for better practice and understanding. Yes. And don't just aim to correct ABG. Always try to treat the cause of acid-base imbalance. So we are not here to treat ABGs. We are here to treat our patients. So each patient is different. Examine them, take a good history, and accordingly then treat the acid-base imbalance. Fine. If you are in doubt, always repeat the ABG. Fine. The knowledge from the workshop and conferences are incomplete without reading the book. Fine. So for better understanding, for better grasping of the topic, you should refer to your textbook. Fine. And these are the reference book which I have used for my lecture. And thank you all for your time and for patient listening, and all the best for your exam. And this picture I have intentionally kept for just to generate a thought process. And yes, all the feedback is very important from all of you. Do provide feedback for the lecture at drsandeeparmal@gmail.com. Thank you all for being there and for giving me this opportunity. Thank you so much.
Thank you so much, sir. It was a well-enlightened lecture. Dr. M.
Please start my video. Host, please start my video. Thank you, Dr. Sandeep, for this elaborative,
Yes, ma'am.
very nice and comprehensive talk on the topic arterial blood gases. And this is the essence that, we in OT and ICU, whenever we are treating the patient, we have to know what is the ABG report, and then we have to see the steps that you have told the students how to go about it. That is the way they should learn, and then with the examples. So I think it was a very complete and comprehensive talk. Thank you so much. Dr. Jyoti, do we have any questions in the chat box? Do we have any questions, Jyoti, in the chat box?
No, ma'am.
No, ma'am, there is no question in the chat box.
Can you read if we have some questions? No,
ma'am.
there are no questions. So, there are no questions. So it's okay. We can shift to the next topic then. We have a next talk. Host may please project the detailed slide of the CV slide of the next speaker, Dr. Jyoti Gupta. Thank you, Dr. Sandeep. So the next speaker is Dr. Jyoti Gupta, and she is Assistant Professor Anesthesia, affiliated to ABVIMS and Dr. RML Hospital, New Delhi. Her achievements are more than 10 publications in Index Journal. She is a faculty in various national and state conferences and has won COPS Award in National ISA 2014. She's won quiz competition in ISACON Delhi 2015 as a PG. So she is my postgraduate student, so that is why I can vouch for her that she is a very hardworking faculty, and the RML is blessed to have her. So let us present in this Appec program. Yes, Dr. Jyoti.
Good afternoon, everyone. Hi, I'm Dr. Jyoti Gupta, and today I'm going to talk about inhalational aging. So when I was doing my post-graduation, this was like one of the most difficult drugs or any topic to understand. And Dr. Neerja gave me this topic. Initially, I was very hesitant, but thank you so much, ma'am. And I hope I do justice to the topic. So let us begin. If we start with the history, nitrous was the first inhalational agent that came into the clinical practice in 1844, and last are the recent one are halogenated ethers, and sevoflurane was last came into clinical practice in 1994. Diethyl ether was the first inhalational agent that was used by William T.G. Morton in 1846. After 1 year, James Simpson used chloroform in giving obstetric anesthesia while delivery, labor analgesia, but it was discontinued because it causes serious depression, sudden death, and dose-dependent hepatotoxicity. Cyclopropane was accidentally discovered in 1929. It was used for almost 30 years. It was a very good anesthetic agent. But as the surgery advances and the surgeons started using the cautery, it has very inflammable property, and it was eventually discontinued. Inhalational anesthetic agents are divided into two parts, gaseous forms and the volatile liquids. Gaseous, we know nitrous oxide, cyclopropane, ethylene, xenon, argon. It's not like these gaseous form, it's always in the gaseous form. If we decrease the temperature or compress, then it can also occur in the liquid form. But at room temperature, they are in the gaseous form. And the volatile liquids are ether, halothane, isoflurane, desflurane, sevoflurane. Methoxyflurane and enflurane are discontinued. Methoxyflurane high nephrotoxic and enflurane has epileptogenic property. So these two volatile liquids are discontinued now. So what do you mean by volatile liquids? Any liquid which have tendency to convert into vapor form at room temperature are volatile liquids. And if it is in a closed container, then the vapors exert a pressure on the container walls. And at equilibrium temperature, that pressure is known as vapor pressure. These are the basic structure of the inhalational anesthetic agent we commonly use. We see nitrous oxide and ether here. And then when halogenations occur, so fluorination increase the potency and decrease the flammability of the anesthetic agent. So we did the fluorination and it becomes the halothane now. And after adding the ether in this halothane, they became isoflurane, desflurane, and sevoflurane. Isoflurane and desfluranes have structural similars, except this fluoride ion extra in the desflurane in compared to chloride in isoflurane. And enflurane and isoflurane are structural enantiomers. They are the bilkul similar. Despite widespread use of the inhalational agent, and it is one of the most common drug we use as an anesthetist, current understanding of the molecular basis of these agents is poorly understood. The effect of inhaled anesthetics cannot be explained by one single molecular mechanism. Rather, multiple targets contribute to the effects of each agent. So there are two theories. One is lipid solubility theory and the other is protein function theory. So we'll discuss one by one. First is Mayer-Overton theory, that is lipid solubility theory. In 1899, Hans Horst Mayer published the first experimental evidence of the fact that anesthetic potency is related to the lipid solubility. 2 years later, a similar theory was published independently by Charles Ernst Overton. So that's why it is called Mayer-Overton theory. And it describes the correlation between the lipid solubility of the inhaled anesthetic and MAC. And it suggests that anesthesia occurs when sufficient number of inhalational anesthetic molecules dissolve in the lipid cell membrane. And where the lipid cell membrane is the brain, and that is our target desired organ. But it also have some exceptions like enflurane and isoflurane. They are structural isomers. I told you they are structural isomers and they have similar solubility, lipid solubility, or we can call it as oil gas partition coefficient. So it is similar, although the MAC is different in all these two agents. And that's why I said I cannot explain the mechanism of action of inhalational agent by one theory. So other theory is protein function luciferase inhibition. Protein function luciferase inhibition says that it acts on two types of receptor. Inhibitory receptors and excitatory receptors. So inhibitory receptors are GABA receptors. So what will do is it activates the inhibitory receptors. Okay, it will act on alpha channel of the GABA and it will activate the GABA receptor. And NMDA is an excitatory receptor, so it will inhibit the excitatory receptors. So these are the protein function luciferase inhibition theory. Mechanism of action. So this inhalational agents acts on 3 levels: macroscopic, microscopic, and molecular. Okay, so macroscopic, it acts on both spinal cord and brain. In spinal cord, it decreases the supraspinal arousal from the spinothalamic tract. So spinothalamic tract carry the pain receptors, thermal receptors, and touch receptors. So it decreases the tract, and it also inhibit the spinal afferent neuronal activity. On brain, it globally depresses the cerebral blood flow and the glucose metabolism, especially in the reticular and thalamic region. And that's why it helps in unconsciousness of the patient. At microscopic level, I already told you, inhibit the excitatory presynaptic channel and augment the inhibitory postsynaptic channel. Okay. And at the molecular level, it acts on GABA receptor, chloride receptors, and enhance the activity of 2-pore domain of the potassium channel, leading to hyperpolarization of the plasma membrane. Now come to the physical and chemical properties of inhalational agent. MAC is like one of the most common terminology we use. MAC is the expired gas concentration or alveolar gas concentration at steady state of inhaled anesthetic at 1 atmospheric pressure that prevents the movement in response to a standard surgical midline incision in 50% of the population. So anesthesia consists of 3 things: unconsciousness, immobility, and autonomic functions. Whenever any noxious stimulus is applied, we need unconsciousness, immobility, and the autonomic dysfunction. Autonomic response, basically. So in MAC, it talk about movement, not anything else. And 1.2 to 1.3 MAC prevent the movement in 95% of the person. If 2 different anesthetic agents are used together, the MAC values of different anesthetic agents are roughly additive. Okay. So I told you 3 things: unconsciousness, immobility, and autonomic dysfunction. Okay. Autonomic reaction, autonomic response. Sorry. So MAC awake is anesthetic concentration needed to suppress the voluntary verbal command in 50% of the patient, and it is 0.3 MAC. MAC amnesia is 2 types: antograde amnesia and unconsciousness. Antograde amnesia occurs at 0.25 MAC and unconsciousness occurs at 0.5 MAC. MAC for endotracheal intubation is defined endotracheal any response because of the endotracheal intubation, and it differs. In children, it's 1.3, and in children it's 1.3, and in adults it's 3. MAC bar means it blocks the autonomic response to the surgical incision in 50% of the patient, like pupillary dilatation, increase in heart rate, increase in BP, and that is 1.5 MAC. Okay, so MAC bar differs from the normal MAC. There are several factors which affects MAC. Some factor increases the MAC value, like if there is high metabolism in the brain, like CNS metabolism is high, CNS neurotransmission is high, hyperthermia is there, the patient is have chronic alcohol abuse, and some drugs like MAO, amphetamines, cocaine, ephedrine, they increase the MAC value. And similarly, if there is decreased CNS metabolism, decreased CNS neurotransmission, increase in the age, hypothermia, acute alcohol ingestion, and drugs like narcotics, ketamine, benzodiazepine, barbiturates, whatever decreases the metabolism in the brain and activity of the brain, that decreases the requirement of the inhalational agent, so decreases the MAC value. Hypotension, when the MAP is less than 50, and hypoxemia, when the PaO2 is less than 40, then only they decrease the MAC, otherwise they do not decrease the MAC. So if your patient's blood pressure is 60, please do not decrease the MAP and try to increase the BP. Use other measures to increase the BP. There are several factors which do not have any effect of MAC, like gender, duration of anesthesia, hypertension, anemia, thyroid status of the patient, PaCO2. If the PaCO2 is more than 95, then only it will affect MAC. Otherwise, it does not have any effect on MAC. Metabolic alkalosis, hyperkalemia, or magnesium levels. Potency. How will we say okay, how potent is this inhalational agent? So if we talk about MAC value, potency depends on the MAC. Higher the MAC value, lower will be the potent. So highest MAC value is of nitrous oxide, and it is the least potent agent. And lowest MAC is of methoxyfluorine, and is the most potent agent. So what is our goal in inhalational agent? What is our goal? We want to achieve some pressure. The inhaled concentration of anesthetic inhalation agent we are providing should be equal to the partial pressure of the inhalational agent at alveoli, should be equal to the partial pressure at arterial level, and should be equal to the brain partial pressure. And that is our final achievement. When we maintain the anesthesia, we want to maintain at this level. then only the MAC will achieve. Okay. So how will we achieve that? We'll learn some terminology and then we'll talk about it. Like solubility. Solubility means how soluble that gas is in the blood or is in the tissue or any other like fat. So blood gas partition coefficient means how efficient it is in solubility in blood, and tissue blood partition coefficient same, and muscle, fat, different partition coefficient are there. There are three types of tissue in our body: vessel rich group, muscle and fat. Vessel rich group include CNS, CVS, GIT, liver, kidney. Although they contain only 10% of our body mass, but they receive the 75% of the cardiac output. Okay. And our desired organ is CNS. And undesired organ is CVS, GIT, liver, kidney. These are undesired organ. We do not want any action of our inhalational agent on that. Similarly, muscle and fat, they receive very low cardiac output, although the body mass is high. So these are the organ of accumulation. If we give prolonged duration of anesthesia using inhalational agent, our inhalational agent have tendency to get deposited in these two tissues. So in this graph, we can see, okay, first the drug will be accumulated in alveoli. Then the vessel rich group. Obviously, it will take time from alveolar to vessel rich group, but very fast it will achieve the same partial pressure. But because of low cardiac output, muscle and fat accumulation is later. And if anesthesia continued for the prolonged duration, then the accumulation will be more. Blood gas partition coefficient, so means how much the gas have solubility. It's highest of halothane and lowest of desflurane. So we have to understand one concept. The more the gas is soluble in the blood, more time it will take to reach the brain. Okay. It is highly soluble. So it has tendency to get attracted to the blood only. But our goal was to achieve the same partial pressure at CNS, our desired organ. So it will take time. And that's why desflurane has the highest induction rate, because it has low blood gas partition coefficient. Whereas halothane is the slowest in induction. Desflurane, although it's fastest with the lowest blood gas partition coefficient, but it is very irritant. So we do not use desflurane, we use sevoflurane next in line. And sevoflurane is a sweet smelling type. So sevoflurane is the most commonly used induction agent. Muscle blood solubility and fat blood solubility. So in both these, we can see the muscle blood solubility is also highest in halothane and lowest in desflurane. And similarly, fat blood solubility is highest in halothane and lowest in desflurane. So we can say if we have to give prolonged duration of anesthesia, halothane have more tendency to get accumulated in fat and muscles. So that also give one reason for halothane to move out of the body very slowly as compared to desflurane and other inhalational agents. So this is our goal. I already told you we want this fraction of inhalational we are providing that should be equal to fraction or partial pressure at the alveolar level, partial pressure at the arterial level, and partial pressure at the brain. So the fraction of inspired gas of inhalational agent that will be determined by our fresh gas flow rate, breathing circuit volume, and circuit system absorption. Okay. Sorry. At alveolar gas concentration, the partial pressure at the level of alveoli will depend on the uptake, solubility. Okay. Second is ventilation. And third is the concentration and second gas effect. Okay, we'll talk about concentration and second gas effect. It is very important topic and it comes as short note also. And for conceptual also, you should know why this concentration effect is there, why we give higher concentration. And third is arterial gas, and it affects by the ventilation, perfusion, mismatching. Oh, so perfusion is not proper, so it will not achieve the partial pressure. First is concentration effect. So concentration effect states that if we give higher fraction of inhalational agent, then the fraction at the alveoli rises very quickly. Okay, let us learn it by example. It is not very easy thing to understand. So in first scenario, we gave 10% of the inhalational agent, right? And 90% of the carrier gas. So this is 90% of the carrier gas, only 10% of the inhalational agent. And we'll assume in all the example that 50% uptake will be there. Okay. So 50%, after 50% of the uptake of the inhalational agent, what remains is 5% of the inhalational agent and the 90% of the carrier gas. So what we have given is, we have given 10%. Now it's 5.3%. How? 5 upon 95, right? It will divide, simple calculation. It will be 5.3%. We started with 10%. So after one breath and 50% uptake, it's 5.3%. But if we increase it to 5 times, right? We gave the concentration of 50%. So 50% will be the inhalational agent and 50% will be the carrier gas. Carrier gas will not get absorbed. Only inhalational agent, 50% uptake, same. So what remains is 25 ml get absorbed and 25% inhalational agent, 50% carrier gas. So it will become 33%. So we have given 5 times and we have achieved 6.2 times. See, so increase in the fraction of inhalational agent at inspiration achieve the alveolar fraction quickly, right? It is augmented by augmented gas flow, right? This 5 ml, what was absorbed, will be replaced by the second breath. Then this second breath will also have 10%. This 10% will have 4.5 ml of carrier gas and 0.5 ml of inhalational agent. What becomes is 5.5 inhalational agent and 94.5 carrier gas. So it becomes 5.5%. Whereas if we augment the flow with the concentration effect, now we are giving 12.5 ml and 12.5 ml carrier gas and the inhalational agent. So what becomes is 37.5, 25 plus 12.5, 37.5 ml of inhalational agent and 62.5% of carrier gas. So we started with 5 times 10% of the inhalational agent and 50%, and we came to 6.8 times. By increasing the concentration, we are achieving the alveolar partial pressure much quickly. Okay. So now it's 6.8 times. So this is concentration effect and augmented gas flow. Second is second gas effect. So most of us use nitrous very frequently, and we all know that nitrous is highly soluble in the blood and it has absorption of 50%. So by giving nitrous, we increases the concentration of other inhalational agent we are giving, potent inhalational agent we are giving. Why this is occurring? For example, we are giving 80 ml of 80% of the nitrous oxide, okay, and 19% oxygen, and 1% is that potent inhalational agent. So similarly, we'll assume nitrous has 50% absorption. So 40 ml of the nitrous will get absorbed. There will be no absorption of oxygen, or the oxygen, if it will get absorbed, it will be replaced by the CO2. That is normal, but proper absorption will not be there. So rest remains 60 ml. So in this 60 ml, the inhalational agent that was present 1%, now it's become 1.7%, right? And the oxygen will be 31.7%, and because 40 ml of nitrous is absorbed, nitrous becomes 66.7%. When the next breath will be provided with the similar concentration, then the added value will be, the inhalational will be 1.4% and the nitrous will be 72%. Okay, so we have seen what we started with 1% becomes the 1.4% because we are using nitrous that have high solubility in the blood and causes the second gas effect. So nitrous become 72% and the second potent inhalational agents become the 1.4%. Elimination, similarly, from tissue to the mixed venous blood, it comes, and from mixed venous blood, it comes to the alveoli and exhale to the atmosphere. The way it goes inside, the way it comes outside. Similar process. Metabolism is very minimal in all the inhalational agents. So during the expiration, there is one mechanism called diffusion hypoxia. So whenever we give nitrous to the patient, our seniors always suggest give 100% oxygen for 5 to 10 minutes after administration of nitrous. So why they say that? Because I already told you nitrous has 50% solubility. So when we stop giving nitrous and we are extubating the patient or we are in the process of reversing from the inhalational agent, so nitrous is now coming from the body. And it has the tendency to dilute the air present in the alveoli. So nitrous will come from body to the alveoli. Now body has some fraction of oxygen. If you are not giving 100% oxygen, it will contain like 30% or 40% oxygen you are giving. So it will dilute the oxygen and it will cause diffusion hypoxia because it has tendency to occupy the same spaces, right? It will dilute and displace the oxygen and it will affect the oxidation. First point. Second, it also dilutes the alveolar air. So it will also decrease the concentration of carbon dioxide. So carbon dioxide is the main factor for the respiratory tract. So these are the two basic causes of causing hypoxia. If we do not give 100% oxygen to the patient who were on nitrous oxide, there are very high chances of getting diffusion hypoxia. So why induction in pediatric patient is very fast as compared to adult patient, and why the MAC intubation of the pediatric patient is so less as compared to the adult patient. We have already told you, and we usually use inhalational induction in pediatric patients. So we should know why this is important. So there is larger ratio of alveolar ventilation to FRC. So FRC is less. First thing. Second, different blood gas solubility because they have low serum protein and low solubility in pediatric patients. So they are less soluble and the MAC will be achieved faster, right? And the cardiac output is disproportionately distributed to the vessel-rich group. Okay, so vessel-rich group includes CNS, which is our target organ. So that's why the inhalational induction in pediatric patient is quite fast and the MAC is low as compared to the adult patient. So let us discuss about the ideal inhalational agents property. Okay, so three properties are there: physical property, pharmacokinetics, and pharmacodynamics. In physical, it should be stable over the range of temperature. It should not be degraded by the light. Does not require the presence of any preservative. It should be non-explosive, does not support combustion. It should be odorless, pleasant, environmentally safe. It should not react with other compounds like soda lime, and has a boiling point well above the room temperature. In pharmacodynamic, it should have predictable CNS depression. Okay, if it is unpredictable, it is very difficult to manage the inhalational agent. Should have analgesic, antiemetic, or muscle relaxant property. Minimal respiratory depression should be there. Minimal cardiovascular effect should be there. There should be no effect on cerebral blood flow or ICP. It should not be epileptogenic. It should not impair. Rather, it should be perfect. And that is our ideal. No agent is ideal, I'm telling you, but these are the required properties. Pharmacokinetic property, it should have low blood gas solubility. So if it is low blood gas solubility, so faster induction, faster recovery. Low oil gas solubility, should have no active metabolites and is excreted completely by the respiratory system. So these are the property of ideal inhalational agents. So in this chart, I am talking about all the most common inhalational agent we use: sevoflurane, desflurane, isoflurane, halothane, and nitrous oxide. These are the 5 most common inhalational agent we use, and I'll talk about these things. So these potent inhalational agents found in the liquid form, physical state, I told you these are volatile liquids, and the nitrous is present in the gaseous forms. Among order, on sevoflurane, halothane, and nitrous. These are pleasant, okay? These are pleasant, sweet smelling, and the nitrous is odorless. But desflurane and isoflurane, they are pungent and irritating. So we cannot induce the patient using desflurane and isoflurane, right? MAC, talking about the MAC, the highest MAC is of nitrous oxide, that is 105. But we cannot give 105%. Maximum we can give 70%. So we cannot use sole nitrous oxide as an inhalational agent. We have to add something with nitrous oxide. Sevoflurane is 1.8, desflurane 6, isoflurane is 1.15, and least is for halothane 0.75. If we talk about blood gas partition coefficient, it's highest in halothane and it's lowest in desflurane followed by nitrous. Okay, so fastest is desflurane and nitrous for induction and recovery, and slowest is our halothane. We already discussed this. Oil gas partition coefficient, it's highest in halothane followed by iso, sevo, des, and nitrous. So oil gas partition is for the solubility in the fat also, right? So fastest recovery is from desflurane and nitrous followed by sevo, iso, and halothane. And we already told the induction and recovery will be very fast from nitrous and desflurane because of all these property, and it will be slow in halothane and isoflurane, right? Metabolism, mostly these inhalational agents are metabolized. They are not metabolized, they are excreted from the respiratory system only. Only 20% of the halothane is metabolized with the liver, and that's why we'll talk about halothane hepatitis, right? Airway irritation, it's minimal in sevoflurane, isoflurane, halothane, and nitrous. Only desflurane is airway irritant, so that's why we avoid giving desflurane in asthmatic patients. Coming to the cardiac effect, all the drugs causes decrease in the blood pressure and mild increase in the heart rate, but nitrous do not have any effect, right? Respiratory effect, nitrous do not have any effect or minimal effect is there, and other agents decreases the tidal volume and increases the respiratory rate. Desflurane is the strong irritant in the airway also and in the respiratory also. So we have to avoid, if any asthmatic or COPD patients is there, so we should avoid giving this patient. And sevoflurane is the drug is the inhalational agent of choice because it causes the bronchodilation also. Okay, muscle relaxant is moderate in sevoflurane and good in isoflurane. These two are good agents for the muscle relaxation. Uterine relaxant is by all the inhalational potent agent except nitrous. Nitrous is not potent inhalational agent, but uterine relaxation caused by sevo, des, iso, and halothane. Hepatotoxicity. Okay, so the most common inhalational agent that causes hepatotoxicity is halothane. Okay, we all know that, and it's very rare in desflurane and isoflurane. Sometimes sevoflurane also called hepatitis, but it's self-limited, but it can cause. Sevoflurane forms a compound A if given for the prolonged duration of time with low flow anesthesia, and it is a debatable topic. Okay, so we have time restrictions, so I cannot talk about all this thing, but we should know, okay, it forms compound A, and that is nephrotoxic. Cost, the most expensive is desflurane, yes, we all know that, and the least is cheapest is nitrous oxide. Okay, which inhalational agent we use in daycare surgery, right? Which have faster induction and faster recovery. These are sevoflurane and desflurane. We want fast recovery, so that's why we use it in daycare surgeries. Few topics we'll discuss, which is left in the table. So contraindication of nitrous oxide. Nitrous should be avoided in any patient of air embolism, pneumothorax, acute intestinal obstruction, tension pneumoencephalus, and tympanic membrane grafting, because it has 50% of the solubility. So it occupies all the cavity with the 50%. If the cavity size is 100 ml, it has the tendency to get soluble in the 50% capacity. So unless and until that capacity has 50% of the nitrous, it will not escape. So the 100 ml will become 200 ml, right? So that's why in any air cavities, if there is a tendency of the body to become any air cavity, nitrous oxide is contraindicated. Toxicity of nitrous oxide. Nitrous oxide interacts with vitamin B12, it oxidizes and inactivates the enzyme methionine synthesis. Okay, so both B12 and folate are used with the enzyme methionine synthesis that affects the myelin formation and ultimately affect the DNA synthesis. So that's why nitrous oxide is toxic, and nowadays so many people are against using nitrous oxide, especially for prolonged. If it is less than 30 minutes, then no measurable change is seen in methionine synthesis activity. But if it is more than 2 hours, it probably interfere with their methionine synthesis activity. So prolonged duration of nitrous is relatively avoided. Halothane hepatitis, it is mostly found in middle-aged women, the patient who are obese with a history of multiple exposure to the halothane. Family history of halothane toxicity may be present. Halothane is oxidized or metabolized by the liver to its metabolite called trifluoroacetic acid, and that metabolite is hepatotoxic. Okay, so there are two types of halothane hepatitis. First is type 1, second is type 2. Type 1 is mild, causes small derangement in the liver functions and slight increase in the SGOT and SGPT level. So it is self-limiting. But type 2 is fulminant and it's severe. If we repeated exposure of the halothane, then the tendency to go into type 2 is more. Jaundice, fever, progression to fulminant hepatic necrosis is there, and high mortality. Ether is not used nowadays, but we should know it is a colorless, highly volatile, pungent odor flammable gas. It is exposed, it is explosive, and it should be stored in a cool area. The MAC of ether is 2 to 3%. It stimulates the respiratory system and increases the secretions. It decreases the urine output of the patient. It has minimal effect on the liver, and it increases the cardiac output. Advantages of ether are, it is a very potent and cheap agent. It has excellent relaxation property, no arrhythmias, and it is very safe to use. Disadvantages are, it is highly inflammable and it increases the mucus secretion. So, and respiratory irritant is also there. So that these are the disadvantages, and no one use ether nowadays, or I really don't know. I haven't used ether anytime soon. Xenon is the most ideal inhalational agent. So, the most ideal inhalational agent which has non-flammable, odorless, the blood gas partition coefficient is 0.14. So, least soluble, has fastest induction and the fastest recovery. The MAC of xenon is 63 to 71%. So, and it is gender dependent. I already told you MAC of inhalational agent is non-gender dependent, but this is the only inhalational agent which is gender dependent. It acts on NMDA receptor. It is cardiostable. It's hypnotic. Analgesia properties is there. No metabolism in the body is there, and does not deplete the ozone layer. It is environment safe. But the disadvantages are, it is very costly and they need special equipment for delivery. So maybe in future, we'll use xenon as our common inhalational agent. So thank you so much, everyone. Thank you so much, ma'am.
Faculty sometimes you have to read and reread value to understand before you have to teach to the students. So this was actually a great topic, and you could explain it very well.
Thank you, ma'am. So I hope you all understood the topic in relational agent. I know it's a difficult topic, and can I have the MCQ for the next lecture? I would like to thank Dr. M.D. Kaur. Thank you so much, ma'am. Before starting the next session, can I have the MCQ, pre-lunch MCQs? So this is pre-lunch MCQs. What is the primary compensation for respiratory alkalosis? A, decrease respiratory rate. B, increase renal reabsorption of hydrogen ion. Decrease reabsorption of bicarb ion. And increase production of lactic acid. Second question is, can you please change the slide and show me the second? Which inhalational anesthetic agent has the lowest blood gas partition coefficient and what is its clinical implication? A is desflurane causing slow induction. B, sevoflurane with smooth emergence. D, desflurane with rapid emergence. And D, isoflurane with minimal cardiovascular effects. So we are running out of time, so we'll skip the lunch and we'll start with the case. Before starting the case, I would like to announce the winners of yesterday's quiz. First was Dr. Shubhajit Mahapatra and second is Dr. Hina Samar. Congratulations, you two. Your registration fees will be reimbursed to you. Please share your bank details with the authorities. We'll contact you and you have to share your bank details with the authorities and we'll reimburse 100% to you. So next case is will be moderated by Dr. Nisha Kachru. Next case is a long case with BMI of 42 kg per meter squared, planned for sleeve gastrectomy. To moderate this, we have Dr. Nisha Kachru. Ma'am is Director Professor in Department of Anesthesia with ABVIMS and RML Hospital, New Delhi. Ma'am has several publications and book chapters in national and international journals. Ma'am is founder member and secretary of Neonatal Anesthesia Society. We welcome you, ma'am.
Thank you. I hope you can hear me.
Yes, ma'am.
Okay. So can we start the case? Where is Dr. Deepak? Okay, so Dr. Deepak, can we start? I can see you and Dr. Jyoti are sitting there. Can we start, please? Can we have it on the full? Good morning. Can you just make the slide full screen?
In the case of morbidly obese patient, sleeve gastrectomy.
Okay.
Patient is 42 resident.
I don't think Dr. Deepak's voice is clear. I can't hear him.
Good morning, ma'am. My patient is Nazia. She is a 42-year-old female patient resident of Karol Bagh and she is a housewife.
Yes, please continue.
Ma'am, she has chief complaint of excessive weight gain for last 4 years and loud snoring for last 1 year, ma'am. Ma'am, my patient was apparently well when she started gaining weight, which was gradually in onset, gradual and progressive in onset. And ma'am, it was associated with sedentary lifestyle and increased hunger. Ma'am, her total weight gain was 50 kgs. Ma'am, she has history of snoring, which was observed by her husband, initially faint in intensity, but now loud enough to be heard across the room. Closed door, ma'am. It was relieved on using multiple pillows. There was no history of sudden awakening during daytime tiredness and sleepiness. No episode of cessation of breathing observed by her husband. There was no history of breathlessness on normal activity or exertion. No history of breathlessness.
Dr. Deepak, just hold. Can you go back to the last slide? Now you have a patient who has been gaining weight, and you have taken this history, which is written in this slide. Can you tell me why you have taken this history? What is the relevance of this history?
Ma'am, can you repeat the question, please?
Yeah, I said, what is the importance of this history which you have taken here?
Ma'am, I have taken history of snoring, ma'am, to rule out OSA, ma'am.
Okay. And what about, why do you want to know whether the patient has OSA or not?
Ma'am, because OSA is associated with increased complication in during pre-op and post-op time, ma'am, and intra-op, ma'am.
So we need to know history of OSA in these patients, which we can make out by history of snoring and history of maybe using multiple pillows or sleeping in a propped up position, and also ask for history of whether there is anyone who has observed any periods of apnea. The importance of OSA is, as you said, to know, to basically understand that OSA is associated with more complications, higher chance of difficult airway, and higher chance of post-operative respiratory complications. So OSA is one of the most important histories that you have to ask in a patient who is an obese patient. Okay, so please carry on.
Yes, ma'am. There was no history of breathlessness on normal activity or exertion. There was no breathlessness with seasonal variation, whistling sound while breathing. There was no history of chest pain or palpitation. There was no history of blackish discoloration of the neck or axilla. There was history of heartburn after taking meal. No history of cramping and swelling of leg. No history of cold intolerance, hair loss, drying of skin, increased sleep and constipation. No history of polyuria, polyphagia and polydipsia, ma'am.
Okay. Now, since we are taking history, our objective as an anesthetist is not to make a diagnosis. We take history because it is important for management of the patient as an anesthetist. So can you tell me why you have taken all these history? What is the importance of this history? And in the exam also, you should take all important positive as well as negative history. So now you tell me the importance of this negative history.
Ma'am, I have taken all this history to know the I want to know if obesity is associated with any other comorbidities, ma'am. It can be associated with respiratory complication and cardiovascular complication, and then ma'am, there can be diabetes. So I want to rule out everything.
Okay, so the history of breathlessness which you have taken is to rule out any cardiorespiratory disorders, and the history of what you have said, breathlessness on seasonal variation of whistling sound, what is it suggestive of? What are you trying to rule out?
Ma'am, these patients have restrictive type of breathing pattern. So I want to rule out if there is any asthma in these patients or not, ma'am.
Okay, now you can have asthma in these patients, which can also be because obesity is a pro-inflammatory kind of a state, and there may be bronchoconstriction in these patients. Losing weight will improve the condition of these patients. Now, history of chest pain and palpitations.
Ma'am, these patients can have baseline arrhythmia. So, ma'am, I want to know history. I want to take the history of arrhythmia.
Dr. Jyoti, why are they predisposed to arrhythmias? And which is the most common type of arrhythmia you can see?
Atrial fibrillation is the most common type of arrhythmia seen in obese patients. These patients are prone for conduction blocks and ischemic heart disease as they have a very inflammatory state.
Yeah, in these patients, adipose tissue can be deposited in the conduction pathway of the heart. Because of that, you can have arrhythmias, and as you said, also because of ischemic heart disease. And that is why I can see, Dr. Deepak, you have asked history of chest pain also. What other cardiac complications may be present in these patients?
Ma'am, these patients have increased blood volume. So, ma'am, there is increased cardiac output, which causes left ventricular hypertrophy. And due to prolonged left ventricular hypertrophy, these patients are prone for left ventricular failure. And then, ma'am, due to increased cardiac volume and there is increase in right ventricle size, ma'am. There is right ventricular hypertrophy, and then, ma'am, these patients can have biventricular heart failure, ma'am.
Okay.
Then, ma'am, there is increased chances of atherosclerosis in these patients, ma'am.
Okay, so these patients, as you said rightly, they have increased risk of biventricular failure. So your history should always include a history of dyspnea and any swelling in the feet, which is suggestive of cardiac failure. Okay, and yes, they have deranged lipid metabolism, increased atherosclerosis, more chances of already mentioned ischemic heart disease and stroke. Okay. Then what? Why have you been asking about heartburn and swelling in the legs and other history?
Ma'am, I want to rule out the history of DVT in these patients. So I asked the history of cramping and swelling in leg. And then, ma'am, these patients have chances of GERD due to increased gastric volume, decreased tone of lower esophageal sphincter. So I want to take the history of GERD, ma'am. This patient have, ma'am, the history of heartburn.
Okay. And as you rightly said, DVT is one of the most common complications which is seen in obese patients. And this is because, why are they more prone to DVT?
Ma'am, they have increased coagulable state of this of blood, ma'am. Hypercoagulable state hoti hai, or ma'am, there is sedentary lifestyle of this patient, and then, ma'am, there is decreased tone of muscles in this patient, ma'am. So there are chances of DVT in these patients, ma'am.
Yeah.
Venous stasis.
Yes, they have venous stasis, reduced mobility, hypercoagulable states because of decreased fibrinolysis, and also polycythemia. Why do they have polycythemia? Which patients are likely to have polycythemia?
Patient with
Polycythemia is usually seen in patients who have obesity hypoventilation syndrome. Okay, so this polycythemia also predisposes them to DVT, and these patients have GERD. So these are some of the comorbidities which are associated with obesity. And moving to the others, cold intolerance, dry skin, and others, polyuria, polydipsia, polyphagia.
Ma'am, there are chances of hypothyroidism in these patients, so I want to rule out the history of hypothyroidism. And then, ma'am, there are chances of diabetes in this patient, so I want to rule out the history of diabetes, ma'am, in this patient.
Again, so these are the important history components of history which you should take for every patient. Now, what is metabolic syndrome?
Ma'am, metabolic syndrome is the cluster of group of metabolic or physiological abnormality in obese patients. Ma'am, when any three of the five conditions are fulfilled, then, ma'am, it is metabolic syndrome. Ma'am, first condition is patient. Yes, ma'am.
Yes, please go on. What are the five conditions?
Ma'am, the patient have central obesity. Central obesity is, ma'am, waist circumference more than 102 centimeter in males and more than 88 centimeter in female patients. Then, ma'am, these patients have deranged lipid profile, ma'am. Their triglyceride level is more than 150 mg per deciliter. And then, ma'am, they have decreased HDL level, ma'am, less than 14 male patient and less than 15 female patients, ma'am. Then, ma'am, there is hypertension. Hypertension, ma'am, BP of 130/85. And then glucose tolerance, increased glucose level, ma'am, 110 mg per deciliter, ma'am.
So
If any of the three.
yes. So in patients who have at least three out of these five, they are prone to higher risk of cardiovascular morbidity. So you have to be aware of all these things and you have to ask them in the history. That is why the history of diabetes, hypertension, dyslipidemia is very important in these patients. Okay. Can we go to the next slide, please?
There was no history of any alternate medications. There was no history of rapid weight gain, no history of headache or blurring of vision, no history of low mood, and no history of binge eating, ma'am.
Okay. Move on.
And then ma'am, her past history, she's a known case of hypertension for last 4 years, control on medication, and she's compliant to treatment. Then ma'am, there is history of 2 LSCS under subarachnoid block, which were uneventful, and no history of drug allergy, no history of blood transfusion, and no history of tuberculosis and bronchial asthma, ma'am. There is no history of psychiatric illness, ma'am.
Okay, this history of past surgery, cesareans, which she had, was that more than 4 years ago? Because you said her weight gain has started, excess weight gain has started 4 years ago. So was she
Yes, ma'am.
obese at the time of these previous surgeries?
No, ma'am, she was not obese at that time of surgery, ma'am. It was 10 years ago, ma'am.
Okay, okay, carry on, please.
And in her treatment history, my patient is taking tablet amlodipine 5 mg once daily and tablet telmisartan 40 mg once daily, ma'am.
Okay.
In her personal history, she's a married woman, and she is taking mixed diet, normal bladder and bowel habit. There is no history of smoking, alcohol intake, or any substance abuse, ma'am.
Okay. Okay,
Family.
please. Yes.
Yes.
Yes, go on, go on.
Ma'am, in family history, no history of obesity in the family, no history of similar complaint in parents and sibling. And in her menstrual history, ma'am, she had menarche at the age of 15 years. And ma'am, socio-economic status, ma'am, she is a middle socio-economic status, ma'am, she has.
Okay.
In general visit.
Yes, please continue.
Continue.
Yes, continue.
In general physical examination, consent was taken. Patient was conscious and oriented to time, place, and person. She was sitting comfortably on her bed. Her current weight is 122 kg and her height is 177 centimeter. And her BMI is 42 kg per meter square, which is obese class 3, ma'am. And her waist circumference is 94 centimeter. Hip circumference is 105 centimeter. And her waist to hip ratio is 1.1, ma'am.
Okay, Dr. Jyoti, can you tell me why he is classifying her as an obese class 3?
Yes, and obesity is classified according to the BMI. 18.5 to 24.5 comes under the normal range. Less than 18.5 comes under underweight, and 24.9, 25 to 29.9 comes under overweight, and 30 to 34.9 comes under obese class 1. 35 to 40 kg per meter square BMI comes under obese class 2, and more than 40 kg per meter square BMI comes under obese class 3. Then there are two other classification also, super obese and super obese. Super obese comes under more than 50 kg per meter square BMI, and super obese is more than 55 to 60 kg per meter square BMI.
What is the importance of waist circumference, hip circumference, and waist hip ratio that Dr. Deepak has taken?
Yes. Waist circumference correlate more with the adipose tissue, as in when we are calculating BMI, they only correlate with the lean body mass. Bodybuilders can have high BMI, but they are not obese.
Yes.
So according to the waist circumference, in male patients more than 40 inches, and in female patients more than 35 inches comes under high risk of obesity. Comes under obesity.
So that is correct. As you said, BMI is not a true reflection of the increased adipose tissue. There may be increase in the lean body mass also, and better indices are present. Waist circumference is important, and waist circumference of greater than 102 centimeters, I will answer in centimeters, and in males and 88 in females is another high risk factor, and a waist hip ratio of greater than 0.5 is also another high risk factor for obesity. Okay, and basically it is because this explains the distribution of fat in the body rather than the total fat per se. So in patients with an increased waist circumference, what is the distribution of fat is more of the android or central obesity rather than peripheral or gynecoid obesity. So central obesity is associated with higher chances of cardiovascular problems. So waist circumference is definitely a better measure rather than just the BMI. Okay. Next slide, please.
Ma'am, her pulse rate is 92 beats per minute in right radial artery, regular and good in volume and character, with no radial or radiofemoral delay. Ma'am, all peripheral pulses were palpable. Her BP is 139/84 mm of Hg in right upper arm in sitting position using an appropriate sized cuff. Ma'am, her respiratory rate is 15 per minute, regular and abdominothoracic, ma'am. Her saturation was 96% on room air. Temperature febrile to touch. There was no pallor, icterus, clubbing, cyanosis, and pedal edema and lymphadenopathy. Ma'am, her JVP is not raised. IV access, ma'am, it was visible on the dorsum of hand, ma'am.
What do you mean by an appropriate sized cuff? And what do you do if you don't have an appropriate sized cuff?
Ma'am, appropriate size cuff mean it should cover more than 75% circumference of the upper arm. And ma'am, if we do not have appropriate size cuff, ma'am, usually we take invasive BP, ma'am.
No, you can also put the cuff on the forearm or the lower limb. However, they tend to give higher readings. They tend to overread, so they are not very reliable. And of course, if there is no option, then intraoperatively you can do invasive arterial blood pressure monitor. So, are you satisfied with an SpO2 of 96% on room air? At what level would you be worried?
Ma'am, these patients can have a lower saturation compared to the normal patients. So, ma'am, I'm satisfied with the saturation, ma'am.
Okay, saturations of less than 94% tend to show presence of arterial hypoxemia and increase alveolar arterial gradient in these patients. Okay, continue, please.
On airway examination, there was no visible maxillofacial deformity, no apparent deformity of nose, cheek. Both nostrils were patent. Good oral and dental hygiene, no loose teeth or artificial dentition. Mouth opening more than 5 centimeter. Modified Malampatti grade 3. There was large tongue and submental fat was present. Upper lip bite test class 1. Neck is short neck with hump on the nape of neck. Large neck circumference was 40 centimeter and neck movement was normal. And hyomental distance is 5.5 centimeter. Thyromental distance is 6 centimeter. Sternomental distance is 11.5 centimeter. Cricoid cartilage was palpable. Large breast was present and stop bank scoring was 4 out of 8.
So in your patient
respiratory system on inspection, there was no obvious deformity of chest.
Just wait, Dr.
Appeared
Deepak.
to be central.
Just a minute.
Respiratory.
Just wait. Can you hear me? Can you hear me? Let us go back to the airway. Why are you worried about the airway in these patients? And in your patient, okay, why are you worried about the airway? Can you hear me?
Ma'am, can you please repeat the question?
I said, why are you worried about the airway in these patients? Are you worried about the airway? And in which
there is
patients are
difficult
you more
airway in
worried?
this patient, ma'am, due to
No,
deposition.
specifically in your patient, why are you worried about the airway? Hello, can you hear me? Hello? Dr. Deepak, can you hear me?
Ma'am, these patients have difficult bag and mask ventilation. These patients are prone for difficult laryngoscopy and intubation. So I want to take a good examination of airway.
What is significant in your patient because of which you are extra worried about the airway?
Ma'am, their neck circumference is more than 40 ma'am, her neck circumference is 40 centimeter, and then ma'am, her sternomental distance is 11.5 centimeter, ma'am. And there was a fat deposition at the nape of neck, ma'am, and large breasts were present. And then ma'am, this patient can also have OSA, ma'am. Her stop bank questionnaire is stop bank score is 4
So
of 8,
that
ma'am.
is very good. One of the first of all, your patient has a history of snoring, and so that means that she is predisposed to airway obstruction. So you're worried about difficult airway. Why is there a airway obstruction in these patients? This is because there is an increased deposition of fat in the oral and the pharyngeal airway. So these patients, if the pharyngeal tone is lost, they can go into obstruction. That is why airway examination is especially important in those with snoring. Your patient has many high risk factors. The most important to predict a difficult airway is the neck circumference above 40, which is seen in your patient. The what is the importance of the cervical pad of fat or the hump on the nape of the neck?
Ma'am, it will hamper the extension of the neck, ma'am.
Okay, so you will not be able to align all your oral, laryngeal and pharyngeal axis in the for a better visualization of the larynx when the patient is put in a sniffed position. So what position would you like to arrange for this patient when you have to take her for induction?
Ma'am, I would like to make ramp position in this patient, ma'am.
Okay. Why is ramp position important? Because it
Ma'am,
will
line
all
the pharyngeal laryngeal axis in a straight line, ma'am, and
okay. And so then, as you said, all your distances are also low. So she has a short neck. So your patient is likely to be a difficult airway, which can mean difficult bag mask ventilation or difficult intubation. But I don't think she will have difficult front of neck access because you've said the cricoid cartilage is palpable. In patients who patients who are so obese that you're not able to palpate the landmarks, in those in the preoperative period, you should also do an ultrasound examination of the airway so that you can identify the cricothyroid membrane in case front of neck access is required. Now, stop bank is 4/8. What is when are you worried about the stop bank? Is this something to be worried about at 4/8 or when?
ma'am, stop bank questionnaire predict the chances of OSA in any patient. Ma'am, it has 8 parameters which are scored 111. Ma'am, stop is snoring. Ma'am, it is scored as 1,
Oh,
and then
that's fine. So what at what parameter do you think the patient is likely to have OSA? Above what level? Out of 8? What score out of 8?
ma'am, if the score is more than 5, then ma'am, patient have high chances of OSA.
Okay. So, okay. Continue, please now. Move on to the next slide.
Ma'am, in respiratory system, on inspection, there was no obvious deformity of chest. Trachea appeared to be central. Respiratory rate was 15 per regular abdominothoracic. There was no use of accessory muscle of respiration. No chest movement was bilaterally equal. No visible swelling, scar, and venous pulsation over chest, back, or wall. Ma'am, no audible wheeze. On palpation, inspectory findings were confirmed. Surface temperature normal. Trachea position in midline. No tenderness or bony deformity. Bilateral equal movement of chest wall. Ma'am. On percussion, reduced resonant note in all area. On auscultation, bilateral vesicular breath sound in all area. No creps or added sound. Vocal resonant normal. And ma'am, bedside PFT is ma'am, breath holding time was 26 seconds.
So, in the respiratory system, what are you looking for? Everything is negative, but what were you actually looking for?
Ma'am, these patients are
Yes, continue.
ma'am, these patients are prone for COPD and ma'am asthma. So I want to rule out that, ma'am. And secondly, these patients have reduced functional residual capacity. So their apnea time is less, ma'am. So I want to see if they have normal respiratory, if their respiratory system is normal or there is any associated
So
comorbidity.
basically, you're worried about presence of COPD and asthma, which you will identify by presence of wheezing, or if the presence of any heart failure, for which you will look for any rales or creps in the lung. Okay. Okay. Now in the cardiovascular system.
In cardiovascular examination, ma'am, on inspection, no precordial bulge, no pulse, no visible pulsation, no venous deformity. Apex beat was not visible. No scar, sinus, dilated veins in any part of thorax. On palpation, inspectory finding confirmed. Apex beat not palpable. Not palpable thrill. No presternal heave. No other pulsation were felt. Percussion cardiac border could not be adequately appreciated on auscultation. S1 and S2 heard no murmur, ma'am.
So again, in the cardiovascular system, these cardiovascular and respiratory system, these are two important systems for examination because they will determine whether there are important comorbidities present in these patients. In the cardiovascular system, you have to look for signs of failure. You may look for presence of S3, S4 gallop, raised JVP, and any Krebs again. All of these are indicative of failure. Continue, please.
Yes. In abdominal examination, on inspection, shape was generalized fullness and pendulous, all quadrant moving normally with respiration. Umbilicus was central in position, inverted, and ma'am LSCS scar was positive. No visible lump, no visible pulsation or peristaltic movement. Stretch marks present over the lower abdomen, ma'am. On palpation, inspectory finding confirmed all 9 quadrant palpated and normal in temperature, no superficial tenderness. Organomegaly could not be elicited, and percussion, tympanic note on percussion and auscultation, normal bowel sound were heard, ma'am.
So what were you looking for in the abdominal examination? Here again, you're looking for any hepatomegaly which may be seen in these patients. Why do you want to look for hepatomegaly?
Well, these patients can have non-alcoholic fatty liver disease, ma'am. So there can be hepatomegaly in this patient, ma'am.
Yes, and what is the implication if these patients have non-alcoholic fatty liver disease? Does it affect anything? Most of the time, even if these patients have some degree of NASH or NAFLD, it has been, and even if there is a slight derangement of liver functions, usually drug metabolism is not affected, which is our major concern in these patients. Okay. Also, presence of hepatomegaly, if you can elicit it, can also be suggestive of right heart failure. But as you have said, these are obese patients. Very many times, all these signs may not be appreciable in these patients, whether it is hepatomegaly or even auscultation. So that is why we have to rely on investigations in these patients. Okay, continue, please.
In central nervous system examination, patient conscious and oriented to time, place, and person. Cranial nerve examination within normal limits. Speech normal. No sensory and motor deficit was present.
Okay. So what is your final diagnosis? What is your diagnosis?
Ma'am, my final diagnosis. Ma'am, she's a 42-year-old female with class 3 obesity and known case of hypertension and OSA, and she's posted for sleeve gastrectomy.
So, Dr. Jyoti, Dr. Deepak has written
Laparoscopic sleeve gastrectomy.
ASA 3. Why is she ASA 3? Why is your patient ASA 3?
Yes, ma'am. Yes, ma'am. Ma'am, ASA class 2 incorporates BMI 30 to 40 kg per meter square, and in ASA class 3, BMI more than 40 kg per meter square.
Okay. So, although there are some studies which say that up to 40, they are all called ASA2, but then there are other articles which suggest that these patients should be called ASA3. Okay. So now you have this patient, and as you said, she is posted for laparoscopic sleeve gastrectomy. So, what investigations will you ask for in this patient?
Ma'am, I would like to have routine blood investigation and then ma'am special investigation for this patient. In routine blood investigation, I would like to have CBC, including hemoglobin, ma'am TLC count and ma'am platelet count and ma'am RBC count and ma'am LFTs, KFTs and ma'am.
Okay, so you need baseline tests which are done for any patient, which includes your CBC, in which you will specially look for polycythemia. Can you hear me? Yeah.
Yes,
so, yeah. So, and then of course you want a blood sugar. You have to rule out diabetes in these patients, and blood sugar and HbA1c, KFT, they should be done because these patients are hypertensive and you have to rule out any end organ damage secondary to hypertension, and you get baseline values of KFT. If these patients have been on any kind of drugs which can affect their absorption, you will also ask for serum electrolytes in these patients. And again, there are certain drugs if these patients have been taking which can affect the fat absorption and vitamin K absorption. So if you have any medication history related to such drugs, you will ask for history of you will also ask for PT-INR because they may have vitamin K deficiency because of fat malabsorption. Okay. So what other investigations, what are you looking for in the chest X-ray?
Ma'am, in chest X-ray, ma'am, there is reduced FVC and ma'am.
No, that you cannot
Cardiomegaly
see
in chest X-ray, ma'am. I want to see.
Okay, in the chest X-ray, you will look for the cardiomegaly, the lung fields, and whether there is any sign of infection and increased blood changes because of increased blood volume. What will you look for in the ECG?
Ma'am, in ECG, I will look for arrhythmias, ma'am, and signs of any left ventricular hypertrophy, ma'am.
Okay, very good. Apart from that, you may have low voltage complexes, and then prolonged QT interval also can be seen in these patients. Okay. So what other investigations do you want to ask for? In the ECG, you will also look for any presence of ischemic heart disease, coronary artery disease. Okay. Okay. So now, what other investigations will you ask for?
Ma'am, in special blood investigation, I would like to have the thyroid profile test of this patient, ma'am, and then ma'am lipid function of this patient, and then ma'am other special tests, ma'am, 2D echo and ma'am stress echo can be done. Ma'am, if the patient have OSA, then ma'am polysomnography can be done, ma'am. And
So-
PFT can also be done.
Okay, so as far as these patients are concerned, as I already said, sometimes clinically the signs may be masked and the patients are not mobile. So it is very difficult to assess their exercise tolerance or the MET scoring system. So for these reasons, an echocardiography, you should have a low threshold for asking the specialized cardiac investigations like echocardiography and stress echo. And out of the stress echo, dobutamine stress echo. You will need the pharmacological type of stress echo. Okay. Can you hear me? Because I cannot make out if you people can hear me. Can you hear me?
There is some delay.
Okay. So as I was saying, you need to get echo. You might need a dobutamine stress echo. PFT may be required. And more than that, a baseline ABG may be required if these patients have a history of OSA, because at least that will help to guide you in the post-op and the intraoperative period. Okay. So now this patient has come for surgery, and what are the pre-op orders you would like to give to this patient?
Ma'am, in pre-op order, first of all, ma'am, I would like to have NP of longer duration, NP of 8 hours, and then ma'am, high risk consent, informed consent, consent for ICU bed or HD bed. Then ma'am, DVT prophylaxis in these patients, ma'am, incentive spirometry, and ma'am, continue antihypertensive till the day of surgery. And
so as far as fasting guidelines go, there are no specific recommendations for increasing the fasting time in these patients. However, there is no harm if you can increase a little, especially those who are on some drugs which reduce gastric emptying. Okay, and DVT prophylaxis, how will you give DVT prophylaxis?
ma'am, low molecular weight heparin 40 mg subcutaneous BD.
Okay, so you can give low molecular weight heparin. You need higher dose in obese patients, and the BD dosing should be started. And TED stockings can also be used in these patients. Yes, then these patients are prone to infections. You might need to give them prophylactic antibiotics in the beginning only. And what else did you say? If the patient is on CPAP, you will ask them to bring their CPAP device. If the patient has been on CPAP, you will ask them to bring their CPAP device and it may be used in the required in the post-operative period for these patients. Okay. Now,
Yes, ma'am.
as far as consent is concerned, now you have to explain the risk to these patients. So, how do you determine the surgical risk?
Yes, ma'am.
Yes.
Ma'am, there is obesity surgery mortality risk stratification score in these patients, ma'am. We have to explain the risk on basis of that score, ma'am.
Okay. So, according to that, the scoring system, your patient is probably not probably must be 1 or 2, and the risk is mild in this patient. Okay.
Ma'am, my patient is at score of 1 and mild risk.
Okay. So the risk in these patients is 0.5%. Mortality risk is 0.5%. So you can explain that to the patient in the pre-operative period. Okay. Apart from that, you, as already mentioned, you have to give deep breathing exercises, incentive spirometry. All these you can start in the pre-operative period, so that the patient knows also in the post-operative period what exercises can be done and how they can be done. Fine. Okay. Now, how will you prepare the?
Yes.
How will you prepare the? Would you like to give anti-aspiration prophylaxis to your patient? Do you want
Yes,
to
ma'am.
give?
I would like to give anti-aspiration prophylaxis to these patients, ma'am, as they are more prone for risk.
Okay. So any patient, especially your patient, he has a history of GERD. So it is better to give anti-aspiration prophylaxis in the form of ondansetron to these patients. And some patients, you may also need to give perinorm, especially if they are diabetic and gastric emptying time is delayed. Okay. So then what other, how will you prepare your OT?
Ma'am, patient to be shifted in the OT on the weight-bearing trolley with extension. And ma'am, in OT, I'll make sure that the table is weight-bearing, and ma'am, it has extensions also. Then ma'am, I'll check the machine suction, and then ma'am, monitors, ASA monitors, and ma'am, airway difficult.
I can't hear you again. I think there is some disturbance. Hello? Hello, hello. Hello?
Ma'am, there was some network issue. They are just looking at it.
Yeah, because I can't hear anybody.
Ma'am, there was some network issue.
Okay.
Ma'am, can you hear me, ma'am?
Yes, you are audible, Jyoti.
Nisha, ma'am?
Yes, yes, I can hear you.
Yes, ma'am.
So, how will you prepare the OT? I was asking you.
Ma'am, I will arrange for padding and strapping of the patient. Ma'am, I will arrange the OT table, which is weight bearing with extensions. Then I'll monitor and machine check, and ma'am, suction check. Then ma'am, in monitors, standard ASA monitors to be prepared, ma'am, which include the adequate size BP cuff.
So, you said now your patient, you are anticipating a difficult airway. And the difficult airway, can you hear me? I don't know if you can hear me. Yeah, the difficult airway cart is very important. What all will you make sure is present in your difficult airway cart?
Ma'am, adequate size of mask to be present. Ma'am, adequate size of LMA. And then ma'am,
Supraglottic airway device, which is very good. Yes.
supraglottic airway devices, and ma'am, bougie, gum elastic bougie. Then ma'am, airway exchange catheter, and ma'am, front of neck access के लिए ma'am, cricothyroidotomy set, and ma'am, awake fiber optic, मतलब fiber optic के लिए भी ma'am, fiber optic to be set.
One more thing which is very important in these patients is the video laryngoscope. And use of video laryngoscope can make your difficult airway much easier. So it should always be present in these patients. Now, as far as the, okay, so you have arranged a difficult airway cart. Apart from the trolley and the weight bearing OT tables, where you can use either 2 tables or a larger size table which is broader and has the capacity to hold around 450 kg of weight, you also need manpower, and you need devices which will help to shift your patient, slide them. So, things like hover mats or shifting devices should be present in these patients. Okay.
Yes, ma'am.
Okay, now how will you induce your patient?
Ma'am, I would like to induce my patient with RSI technique, ma'am. I will give fentanyl according to the lean body weight of patient, and ma'am,
No, first you have moved the patient to the OT table. At that time, first you have to decide what is the position of the patient you are going to begin.
Yes,
So
ma'am.
in these obese patients, if you keep them in the supine position, they already have a low FRC, and the FRC will go further down, and they will have more chances of hypoxia, hypocapnia. So you have to keep these patients in a head-up position or a reverse Trendelenburg position, which will move the abdominal fat away from the diaphragm and improve compliance of the lung in these patients. Also, you have to keep ready your ramp in these. As you already mentioned, you want a ramp. So, what do you know? How will you make that ramp? If you
ma'am, in our institute, there is preformed ramp is present, but if it is not available, I will stack the towels or blankets under the patient so that the sternal notch is aligned with the external auditory meatus, ma'am.
Yes. So this is, as you already said, this will align your axis. So you should have ramp position and the head elevated laryngoscopy position. Both of these are different. One is for the alignment of the axis, and one is to keep your patient in a head up or a position. And in fact, in very obese patients, you may even need to keep them in a semi-sitting position. Okay. So then, as far as IV access goes, you said your patient had easy IV access. If it is not present, you may need to do an ultrasound guided. Look for an ultrasound guided IV access. And when you take the consent, you have to explain to the patient that she may require some kind of invasive lines. As you already said, she may need an invasive arterial line if the proper size BP cuff is not available. If you don't have a good IV access, you may need to put a central venous CVP line. So all this has to be explained, plus the risk of post-op stay in ICU, risk of post-op ventilation. Now in these patients, as you said, you will start an IV line, you will put the monitors. What are the monitors you are planning to use?
Ma'am, saturation, and then ma'am, BP, and then ma'am, ECG, temperature, and ma'am, ETCO2, ma'am.
Okay. Okay.
And ma'am, in special में ma'am इनके अंदर NMT monitoring and BIS monitoring हो सकती है.
Yes, this is neuromuscular monitoring is especially good for these patients because they have altered pharmacology, and BIS monitoring because there are chances of awareness because our drug doses will be modified and they may be sometimes not very precise and there may be risk of awareness. So how will you induce this patient?
Ma'am, I will pre-oxygenate the patient in ramp position. And
What techniques will you use for pre-oxygenation?
ma'am, I can use a PEEP of 10 centimeter of water and ma'am flow of 10 liter per minute. And then ma'am, I'll pre-oxygenate the patient and I will.
Any other technique which you can use? Yes, Dr. Jyoti, any other technique which can
Ma'am,
be
I can use CPAP, HFNC and nasal flow, nasal
Yes.
cannulas, ma'am.
Yes, you so for pre-oxygenation and para-oxygenation should be done.
Para-oxygenation.
They are recommended in these patients. So you can use a 100% FiO2 with a PEEP of up to 10 centimeters of water. Along with, and you can use either apneic oxygenation through nasal prongs or HFNC. Okay, so after pre-oxygenation, because you want to build the oxygen reserves, you have to improve your apnea time because these patients can desaturate very fast. Okay. Okay, then?
Then I'll give drugs, ma'am, fentanyl 2 microgram per kg, 1 to 2 microgram per kg weight. And then ma'am, propofol, induction dose according to total body weight of the patient. And then ma'am, I will give injection succinylcholine according to total body weight of the patient, ma'am, 1.5 mg to 2 mg per kg.
Now, all obese patients do not need rapid sequence induction. Normal induction can be done unless there is a specific risk of regurgitation and aspiration, one of which is of course GERD, which is I think present in your patient, or if the patient is diabetic. Otherwise, RSI is not a definite indication in these patients. Okay. So briefly, can you tell me what drugs how will you calculate the doses of various drugs that you are choosing to give to these patients?
Ma'am, different drugs can be given according to the weight of the patient. Ma'am, most of them are given according to lean body weight of the patient, which is calculated, ma'am, 1.3 multiply ideal body weight of the patient.
So actually the pharmacology of drugs is altered partly because the volume of distribution is altered. So the loading doses are changed, drug binding is altered, and drug clearance is also changed. So this is mostly in the lipophilic drugs. However, all drug doses have to be modified. Many people take ideal body weight for dosing, which is not really correct because ideal body weight does not take into consideration the increase in the muscle mass that is also present in these obese patients. So lean body weight is a better measure. Most drugs are given according to lean body weight, except what drugs are given according to total body weight?
Ma'am, total body weight, ma'am, drugs given according to total body weight are ma'am succinylcholine, dexmedetomidine, and ma'am neostigmine that can be only given up to 5 mg, ma'am. Maximum dose is 5 mg, ma'am.
Again, there are little conflicting data given in various books, but if you look at the SOBA guidelines, SOBA is the Society for Obesity and Bariatric Anesthesia guidelines. They recommend that all drugs should be given according to lean body weight, except, as you said, succinylcholine according to total body weight. Higher doses of succinylcholine are required because the action of plasma pseudocholinesterase is increased, and the other drug that you need to give according to total body weight is heparin, low molecular weight heparin. As far as drugs like dexmedetomidine, sugammadex, and neostigmine are concerned, they can be given according to adjusted body weight, which is basically 40% more than the ideal body weight. So it is, you are giving more than the ideal and lean body weights, but little less than the total body weight.
Yes, ma'am.
But if you are not sure, it is always better to give the drugs according to lean body weight and then titrate according to effect. So you do not really have to follow any very hard and fast guideline. The aim is to keep the patient safe. The duration of action may be prolonged, and in anesthesia we have that liberty. So we can see the effect and then give, for example, propofol. You have given it, you feel that you want to give more, you can always add more according to the response of the patient. So it is safer to give drugs according to lean body weight and then add according to titrate according to the effect. Okay. So so you have given, you're preferring to do RSI, then how will you proceed?
Ma'am, I'll intubate the trachea of the patient and ma'am, machine volume control ventilation. And ma'am, inhalation with desflurane.
So suppose you have given succinylcholine and you are finding it difficult to do back mask ventilation. What will you do next?
Ma'am, I can insert the supraglottic airway device, ma'am.
Okay. So that is one of the techniques. You can use various other methods, like you can use an airway, you can use two-hand ventilation, and of course you can put in a supraglottic airway as a rescue device. And then that supraglottic airway device can be used for bag mask ventilation. However, in patients with a BMI of above 35, it is better not to carry out the surgery under the SGD. Use it for intubation or then do a laryngoscopy and intubation. If you're not able to visualize, again, go for other devices like stillets and video laryngoscopy. Now, awake fiber and awake fiber optic intubation is generally not the first line unless you're really anticipating a difficult intubation in these cases. However, that is also an option where it is wherever indicated. So, how will you maintain anesthesia in these patients?
Ma'am, I'll maintain inhalational anesthesia with desflurane, and I will avoid nitrous oxide in this patient, ma'am.
Okay, and what analgesia?
Ma'am, for analgesia, I will give ma'am short-acting opioids, and ma'am multimodal analgesia, ma'am, using different drugs, ma'am, NSAIDs and NMDA.
Okay. Nitrous oxide is not really contraindicated, but if it can be avoided, you can avoid it. Allows you to titrate the FiO2 better, and you can, it also prevents PONV. Desflurane you are choosing because it is one of the shorter acting agents and patient will be come out of it faster. Muscle relaxant of choice can be one of your muscle relaxants which are not depend on organ metabolism like atracurium or cis-atracurium. However, you can even, if your liver functions, kidney functions are normal, you can use vecuronium, rocuronium and such agents. Obviously, it is better to have neuromuscular monitoring so that you can decide the next dose of these patients.
Yes,
now, ventilator settings, what ventilator settings would you like?
Ma'am, volume control ventilation of tidal volume of 6 to 8 ml per kg, and then ma'am a higher PEEP of 10 centimeter of water, and ma'am increased tidal volume, breath, ma'am, respiratory rate 14 to 16.
So you can give volume control ventilation and lung protective ventilation, but pressure support ventilation can also be done, especially in laparoscopy where the airway pressures may again be already going up. So in these cases, you can do pressure control ventilation. I ratio is adjusted to achieve the best oxygenation and respiratory rate to wash out the CO2. Especially because in these patients, if the CO2 is getting absorbed because of the laparoscopy and they already have a pre-existing pulmonary hypertension, that can be worsened by the hypercarbia. The most important thing to remember is that you should give PEEP, and usually PEEP of 5 to 10 is recommended. Higher PEEPs can reduce cardiac output, especially in these patients where because they are in the reverse Trendelenburg position. And recruitment maneuvers should be done to maintain the oxygenation and prevent atelectasis and lung collapse. So what is the position which is used in these patients for surgery? Laparoscopic sleeve gastrectomy.
Ma'am, head up or reverse Trendelenburg position with legs wide apart and surgeon standing in between them.
Okay. So what are the advantages and disadvantages of the patient being in this position?
Sorry.
Advantages and disadvantages.
Dr. Jyoti, can you tell us what will be the advantage? Yes.
Yes, ma'am. Advantages of reverse Trendelenburg position are, ma'am, that our ventilation will be better.
Yes.
But there will be high risk of DVT and venous thromboembolism as blood will be pulled down. And for ventilation, our FRC will be better, reserves will be better, and cardiac output will also be.
Yes. So all these factors have to be kept into consideration. Now, as far as positioning goes, you have already said that you would like a larger size table. Adequate strapping should be present. Patients have a tendency to slip down in the reverse Trendelenburg position, so you have to stabilize that. Padding is very important. They are at risk for nerve injuries, pressure sores. So all you have to ensure good padding. Another thing to remember is that because of pressure on the gluteal region, these patients are at a risk of rhabdomyolysis. So in the post-op also, you have to watch for that, and AKI has to be prevented by being awareness. So you can modify the position, manage your fluids, and watch for it. Now, what fluid management will you give? How do you decide how much fluid to give to these patients?
Ma'am, it will give goal-directed fluid therapy based on the cardiac output of the patient, ma'am, and the hemodynamics of the patient, ma'am.
Okay, ideally the fluid is given according to lean body.
Lean body.
Yes, and you have to avoid excessive fluid. Why?
Ma'am, these patients can have, ma'am, pulmonary hypertension and due to, ma'am,
They are
hypervolemia.
more prone to failure. You do not want to overload these patients. However, you also don't want hypovolemia in these patients. So ideally, goal-directed fluid therapy is best. So we will not go into the details of that. But if you have invasive monitoring, you can do stroke volume and pulse volume variation. Otherwise, you can do plethysmographic waveform variation, which is a non-invasive type of goal-directed fluid therapy measure in these patients. It is also better because it is bowel surgery and you will reduce chances of bowel edema and in these patients if you do goal-directed fluid therapy. And urine output is usually not a good guide. Now, what are the problems which will occur because of laparoscopy in these patients? As already mentioned, you will have you can have hypercarbia, you can have increase in the intra-abdominal pressure, which will further compromise your venous return and predispose these patients to venous thrombosis. So you should use pneumatic compression devices apart from your low molecular weight heparin in these patients. Now, as far as analgesia is concerned, you said you would like to use multimodal analgesia, which is also what anesthetics, what agents would you like to use in these?
Ma'am, short-acting opioids like fentanyl and ma'am, NSAIDs, ma'am, PCM, ma'am, ketorolac can be given, ma'am. And
Yes.
ma'am,
So,
Alpha to agonist, alpha to agonist.
Pardon?
And you can also use block.
So in these patients, you can give tab block in the post-operative period. Wound infiltration can be done with the local anesthetic. Fentanyl or short-acting agents like remifentanil, both of these can be used. NSAIDs, paracetamol, all of these can be used. Again, to reduce the dose of opioids, intraoperatively, you can use infusions of dexmedetomidine, clonidine, low doses of ketamine. All of these reduce the opioid requirement, and the same can be continued in the post-operative period. Now, what about reversal? What precautions will you take during extubation of these patients?
ma'am, during reversal of the patient, ma'am, I will make sure to have instrument for reintubation, and ma'am, I will make sure that patient is fully conscious and oriented. Ma'am, have adequate airway reflexes present, and ma'am, in to be done in the ramp position, ma'am, in which position he was intubated.
Okay, so the same way, like for any other patient, you have to ensure patient is fully awake, all your patient is adequately reversed, muscle power is okay, reflexes are there, and you have to extubate in the ramp position and be ready for any reintubation if required. Anything else? It is always better to put in a nasopharyngeal airway at the time of extubation so that there is no collapse and you do not have an obstructed airway. And an airway exchange catheter can also be used in these patients, and it can be left there in case reintubation is required. Another precaution you have to take is that after extubation, you should start them on oxygen. And even when you observe the patient first in the operation theater, shift them to recovery, then shift them to the HDU or ward or wherever you are shifting them, you should monitor them very closely. SpO2 monitoring, oxygen if required, and if patients were using CPAP pre-operatively, that should be continued in the post-operative period. What else other care do you want to take of these patients in the post-operative care? So one we said is oxygenation, second we said is multimodal analgesia. What else?
Ma'am, early ambulation is necessary in this patient as these patient have high chances of DVT, ma'am.
Okay, so early ambulation is important, and for that adequate pain relief is important.
And then ma'am, incentive spirometry can be done in this patient.
Yes, post-operative breathing exercise in incentive spirometry, then it is bowel surgery. If you want early ambulation and early mobilization, you have to look after PONV also. So all of these are part of the ERAS guidelines also in the obese patients for early recovery, which of course also includes use of laparoscopic surgery and less use of any nasogastric tubes and drains in these patients. So in the pre-op period, even if the patient has not been using CPAP in the pre-op period, they may require it in the post-op, and you have to explain that to these patients. Okay.
Yes.
Okay. So any special precautions you have to take intraoperatively apart from the ones that you take for any other laparoscopic procedure? So how is lap sleeve gastrectomy done? Usually they have a bougie, and the surgery involves removing the greater curvature of the stomach. About 80% of the stomach is removed. So when that bougie is being used, you have to be careful that it is removed completely. Why?
Because it can get stuck in the gastric pouch and get stapled in the gastric.
Yes, so you have to be careful, and whenever they are, so that is one precaution you have to take while that is being used. Okay. And anything else? Anything else as far as management of this patient is concerned? Anything you would like to add? So maybe we can go to Dr. Rima and she can give us the summary of the case now. Thank you very much, Dr. Jyoti and Dr. Deepak. Very good.
Thank you, ma'am. Thank you, ma'am.
Okay. Dr. Rima.
Good afternoon, ma'am. Today we have discussed anesthesia for bariatric surgery. We had more than 40. It is defined as a metabolic disease in which adipose tissue comprises more than normal proportion of body weight, which is more than 25% in males and 30% in females. It's a disease of caloric imbalance between intake and consumption by. As we have already discussed, there are two types of obesity, central and peripheral, also called as android and gynecoid obesity. Central obesity is more prominent in the upper body in the central area, and peripheral obesity is more in the thighs and buttocks and peripheral area. Central obesity, the fat is more metabolically active, so there is higher consumption and increased incidence of cardiovascular disease. In gynecoid or peripheral obesity, there is less oxygen consumption and less risk of cardiovascular disease. Central obesity is more common in males and peripheral is more common in females. Before classifying obesity, let's go through some basic definitions, starting with body mass index, which is calculated as weight in kilogram divided by height in meter square. Ideal body weight is calculated according to height of the patient in centimeters minus X, which is 100 in males and 105 in females. Lean body weight is total body weight minus adipose tissue. It is usually 80% of the ideal body weight and 75% of the ideal body weight in males and females respectively. There is one more term called adjusted body weight, which is ideal body weight plus 0.4 into total body weight minus ideal body weight. Normal is 5 to 24.9. Overweight is 25 to 29.9. From 30 on obesity classification starts, 30 to 34.9 is class 1, 35 to 39.9 is class 2, class 3 is 40 to 49.9, super obese is more than 50 BMI. There's one more classification, super obese, which is more than 60 BMI. And the risk of health problems increases with increasing class of obesity. Similarly, according to waist circumference, if the circumference of waist is more than 40 inches in males and 35 inches in females, the risk increases of the comorbidity risk increases in respective classes of obesity. Let's talk about pathophysiology, starting with airway. Obese patients have poorly defined landmarks. They have increased amount of fat deposition in oral pharyngeal tissues, which leads to decreased size of airway obstruction. And especially after giving opioids and benzodiazepines to these patients, the airway obstruction increases. Again, they have limited atlantoaxial joint and cervical spine movement because of dorsocervical pad of fat. Also, there's suprasternal, presternal, submental pad of fat. There's short neck, more than 40 centimeters, large tongue, large breast. All of these airway changes contribute to difficult bag mask ventilation as well as difficult laryngoscopy and intubation. In respiratory system, there are four main things. One is restrictive lung disease, obstructive sleep apnea, which can lead to obesity, hypoventilation syndrome, and pulmonary hypertension. Since these patients have increased BMI and metabolically active adipose tissue, the oxygen consumption increases, CO2 production increases, there's increased minute ventilation. Because of heavy chest wall, increased pulmonary blood volumes, and splinted diaphragm, there is reduced lung and chest compliance up to 30%. Increased minute ventilation and reduced lung compliance increase the work of breathing. Also, there is reduction in lung volumes, which includes FRC, vital capacity, total lung capacity. As your functional residual capacity reduces and reaches near closing capacity, there is early closure of small airways, leading to atelectasis, leading to ventilation perfusion mismatch, shunting, and arterial hypoxemia. That is why these patients are more prone to hypoxia and they have a low apneic reserve because of reduced FRC, and therefore they require meticulous pre-oxygenation, preferably in a semi-erect position. Because of decreased lung compliance, they need higher inflation pressures for ventilation, and that is why LMA should not be used in these patients for a intraoperative period. Application of PEEP with an ETT is helpful in improving oxygenation by reducing small airway collapse and is the preferred airway device. Post-operative physiotherapy, incentive spirometry, use of epidural analgesia, all of these things help reducing post-op atelectasis and respiratory failure. Also, early post-op mobilization is vital. Second thing is obstructive sleep apnea, defined as complete cessation of airflow lasting more than 10 seconds or more than 5 episodes per sleep with a decrease of oxygen saturation at least of 4%. This can lead to hypoxia, hypercarbia, pulmonary systemic hypertension, polycythemia, arrhythmias, increasing the risk of IHT, stroke, and cor pulmonale. We can diagnose OSA with AHI on sleep studies called as polysomnography. This is apnea-hypoapnea index, where we count the number of events of apnea and hypoapnea overnight. So according to that, OSA is classified as mild, moderate, and severe. Mild disease, in which the index is 5 to 15 events per hour. 15 to 30 events per hour contributes to moderate disease. Severe disease, the AHI is more than 30. For mild disease, we generally recommend lifestyle modifications and weight reduction to the patients. Moderate and severe disease patients may require CPAP preoperatively. Also, patient with severe AHI may require surgery like uvulopalatopharyngoplasty. Then we have already spoken about the stop bank questionnaire, which is required as a pre-op screening tool for OSA. It's about snoring, feeling tired, any incidence of observed apnea, high blood pressure, BMI more than 35, age more than 50, neck circumference more than 40 centimeters, and gender of male. High risk of OSA is if the scoring is 5 to 8. Any patient with OSA, we should avoid sedative pre-medications. Obviously, regional anesthesia and short-acting anesthetic agents are preferred to reduce post-op drowsiness. To avoid post-operative airway obstruction, nursing in a HD or ISO setting with pulse oximeter monitoring, proper positioning, oxygen supplementation, and CPAP should be available. Consider nocturnal oxygen for 5 days post-operatively if available. Then we have OHS, obesity hypoventilation syndrome, also called as Pickwick syndrome. This is a long-term sequel of OSA. It combines obesity and chronic hypoventilation and ultimately leads to pulmonary hypertension and cor pulmonale. It is with more than 3 km² with awake arterial hypercapnia with a PCO2 of more than 45 millimeters of mercury in the absence of any other known causes of hypoventilation. Next, we have the cardiovascular system. In cardiovascular system, there is increased blood volume. There is increased cardiac output. For every kilogram of increase in adipose tissue, 100 ml per minute of increase in cardiac output is there. Left ventricular hyperdilatation and hypertrophy causes obesity, cardiomyopathy. There is sympathetic activation contributing to hypertension. Accelerated atherosclerosis, increasing the incidence of ischemic coronary events. Infiltration of the conductive system can cause arrhythmia, as we already spoke. Most common arrhythmia is atrial fibrillation. Obese abdomen can compress the venous return from legs. It can increase the risk of DVT, pulmonary embolism. Also, polycythemia, decreased mobilization, increase the risk of DVT. This only we discussed in the last slide. So in an obese patients, taking detailed cardiac history and examination is important. We can even take the help of special investigations like 2D echo, stress echo, invasive BP monitoring may be required for such patients. Cardiac drugs, if the patient is already on cardiac drugs preoperatively, they should be continued in the perioperative period. DVT prophylaxis, including TED stockings, pneumatic compression devices, early mobilization, heparin prophylaxis should be given to the patient. Next, we have drug dosing. As ma'am already told, volume of distribution, binding, elimination of drugs is unpredictable in obese patients. So more attention should be paid to the clinical endpoints of drug action like loss of verbal contact, tachycardia. And also the drug dosing is adjusted according to total body weight and lean body weight as we discussed. These patients also have difficult IV access, difficult positioning, more chances of pressure injuries. So special padding is required for these patients. We have already discussed about the drugs which should be given according to total body weight and lean body weight respectively. In the endocrine system, these patients are prone to subclinical hypothyroidism, diabetes mellitus, hypercholesterolemia, gout, osteoarthritis, and metabolic syndrome. Metabolic syndrome is defined as central obesity, that is waist circumference more than 102 centimeters in men, 88 centimeters in women, with any two of the following, which include triglycerides more than 150 mg per dl, HDL less than 40 milligram per deciliter in men and less than 50 in women, blood pressure more than 130/85, and fasting glucose more than 110 milligram per deciliter. So we should do RBS for all obese patients to rule out diabetes and metabolic syndrome. Control of blood sugar perioperatively reduces wound infection and the risk of myocardial events. And if the patient has hyperlipidemia and is on statins, they should be continued in the peri-op period because it improves plaque stability. In GI system, the patient can have increased gastric residual volume, increased acidity. They have more risk of reflux disorders like we had in our patient. They are more prone to regurgitation and aspiration pneumonitis. Some patients can have fatty infiltration of liver and they can have non-alcoholic fatty liver disease and they may have liver function test deranged. And so we'll need to alter the dose of our drugs. These patients are more prone to hypercoagulability as we already told. Musculoskeletal system, again, osteoarthritis, varicose veins, lymphedema, incontinence. In general, risk of infection is more in these patients. Some patients are on medical management of obesity. They must be on some anti-obesity drugs like tirzepatide, liraglutide, semaglutide, and orlistat. These are GLP-1 agonists, and these drugs should be stopped according to their dosing preoperatively. Surgical options for obese patients can be malabsorptive procedures like jejunal bypass, restrictive procedures like sleeve gastrectomies like we had done in our patient, adjustable gastric bending, vertical banded gastroplasty, and combined options like Roux-en-Y bypass. We already spoke about the obesity surgery mortality risk score, according to which we should counsel the patient preoperatively and risk stratification should be done. Let's talk about perioperative management, pre-operative assessment, detailed history, examination, then respective system history should be taken, respiratory system, CVS, GIT, because obesity affects all the systems as we already discussed. Stop bank questionnaire should be assessed if the patient has history of obesity and BMI more than 30. Airway assessment, again, detailed airway assessment should be done so that we can predict difficult airway in the preoperative period. It includes your neck movement, thyromental distances, and neck circumference, cervical pad of fat, MPC grading, USG assessment, if required, should be done. Investigation include all the routine investigations and special investigations, including baseline ABG, PFT, polysomnography, stress echocardiography, and others. These are preoperative orders. Other than the usual NP orders, we should tell the patient to continue medications except insulin and OHA. Anti-aspiration prophylaxis should be given, sedatives to be avoided, DVT prophylaxis, pre-op spirometry, deep breathing exercises to be encouraged. Morning serum electrolytes, if the patient is on drugs affecting the electrolyte, should be done. Pre-op ABGs should be done in patients having history of OSA, and preferable to transfer the patient in head-up position. Written consent should be done. This is how special OT preparation for obese patients. As we can see, difficult airway card should be ready. Ramp positioner is there. We have appropriate size BP cuff should be there. Air mattress for the post-op period. Then we have DVT pump is there. And we have HFNO for pre-oxygenation. Positioning, as we have already discussed, appropriate size operating table should be there. If it is not present, we can combine two tables. All the equipment required for strapping and pressure padding should be made available. Then we have already discussed about FRC and decreased safe apnea time of this patient. So we should pre-oxygenate the patient in a semi-erect position. Preferable position Trendelenburg position is not well tolerated. Reverse Trendelenburg position is better tolerated in these patients. Again, for monitoring, standard monitors, NIBP cuff should be appropriate size for the patient. We can always do invasive monitoring if required. Central venous catheter can be used for major abdominal thoracic procedures when peripheral IV access is not obtained. Induction, again, we already spoke about the HELP position, ramp position. We anticipate difficult mask ventilation. So we can use the 2-hand technique, 4-hand technique. Pre-para-oxygenation should be done. Difficult airway card should be ready. CPAP and PEEP should be given to compare operative hypoxemia and drugs total and lean body weight. Then this is the ramp positioning where external auditory meatus is in line with the sternal notch. Adequate pre-oxygenation is vital. Oxygenation, we already spoke about it. For RSI, we are giving IV agent with choline with cricoid pressure. Maybe intubation is anticipated in the preoperative period. We can plan awake fiber optic intubation. Sedation with dexmet may be required for anxiolysis. Again, we spoke about intubation, that video laryngoscopy is helpful. It gives a better glottic view and decreased intubation time. For ventilation, you should maintain head-up position if possible with pressure control ventilation. 6 to 8 ml per kg of tidal to be delivered, per 5-10 centimeters of water. Else again, C-point preferred compared to isoflurane. Urine output, airway pressure, BIS, NMT are extra monitoring to be done. Then addition of sufficient PEEP recruitment manuals can help to reduce intra and post-operative atelectasis. Pneumoperitoneum should be 12 mercury. Thromboprophylaxis, we have already talked about it. Fluid according to the goal-directed fluid therapy and based on lean body weight. Emergence should be done in the same position as intubation. Be ready for re-intubation. Placement of tube exchanger before extubation is preferable. Supplemental oxygen to be given. And for reversing, we can use neostigmine or sugammadex according to the total body weight of the patient. And patient should be extubated when awake, following oral commands, have adequate strength, adequate tidal volume, and brisk airway reflexes. For post-op care, we'll give propped up position. Supplementation of oxygen is must, may require CPAP, BiPAP, maintain adequate temperature, multimodal analgesia, continue antiemetics, pneumatic compression stockings. Thank you, everyone.
Thank you, Dr. Rima. That was very, very comprehensive and complete. Thank you.
Thank you, ma'am.
Thank you, Nisha ma'am. It was an enlightened lecture. And thank you, Dr. Rima. Thank you, Deepak. Thank you, Jyoti.
Okay.
Thank you. For the next lecture on supraglottic airway device, I would like to invite our next chairperson, Dr. Geeta. Dr. Geeta is a senior professor in SN Medical College, Jodhpur. Ma'am has many achievements, including Honorary Secretary of Rajasthan Society of Anesthesiologists, Organizing Secretary of Rajisakon 2024, Treasurer, Executive Member of ISA Rajasthan State Chapter from 2017 to 2021. She is an affiliated member of Institutional Ethical Committee, Additional Nodal Officer of MDRU, NBE examiner, and ISI certified BCLS instructor. We welcome you, ma'am. Geeta ma'am.
Good afternoon. Am I audible?
Yes, ma'am, you are audible. Your video is not visible, ma'am. Yes, ma'am. Now we can see.
So, good afternoon to everyone. First of all, I thanks to organizer and organizing team to give me opportunity to be a part of this APPEC 2025. And introduce Bhavya Krishna. So it's pleasure to introduce the Bhavya. She is assistant professor at VMMC Safdarjung Hospital, and she is a ASA Global Scholar 2024. ATLS, CCLS, NALS instructor, author of several national and international publications, chapter, and faculty in various conferences. The area of interest is pediatric and the regional. And she is going to speak on the essential topic in the modern anesthesia and the emergency medicine, that is the supraglottic airway device. So as we all know, the supraglottic airway device has the revolution airway management by offering the alternative and traditional endotracheal tube in both routine and as well as in emergency conditions. So they are the particularly beneficial in cases where the rapid effective airway control is necessary and endotracheal tube is difficult to introduce. So today's session, Bhavya will describe the various type of the supraglottic airway, their indication, uses, contraindication, and clinical evidence supporting for their use. So, welcome, Bhavya. You can start now.
Thank you, ma'am. Hello, everybody. This is Dr. Bhavya Krishna, and I will be talking about supraglottic airway devices. The supraglottic airway devices, like we all know, were invented by Dr. Archie Brain, where he combined a Goldman nasal mask with an obliquely cut endotracheal tube to give to us an airway that was intended to open, secure, and seal the supraglottic airway to provide an unobstructed airway in either spontaneously breathing patients or ventilated patients. Now, what are its advantages as compared to a face mask? Advantages of supraglottic airways as compared with the face mask are it has more reliable ventilation, there's lower risk of aspiration, the dead space is lesser, there's better correlation with your end tidal and end tidal carbon dioxides, and it is hand-free. Whereas the disadvantages are there are more complications like sore throat and more time is taken to secure it. Compared with an endotracheal tube, a supraglottic airway device is way less invasive. It has an easier learning curve, a much faster insertion time. It avoids laryngoscopy and the complications associated with laryngoscopy, like the pressure response, which increases your mean arterial pressures, intraocular, intracranial pressures. It is less traumatic and less neck movement is required. Whereas the disadvantages of supraglottic airway are that it does not protect against aspiration, it is contraindicated in high-risk aspiration patients, and it has lower seal pressures. There are various indications for using supraglottic airway devices, and the main one being the airway. It's used as an airway management device for anesthesia, and it is used in a wide variety of clinical scenarios. In the present day, where it is used even in neonates and laparoscopic surgeries, it is used as an airway rescue device, finding its name in most of the airway guidelines when there's a difficult mask ventilation, when there's an inability to intubate. It has also found its very important role with the EMTs for pre-hospital care as well as resuscitation because of its ease to use and fast learning curve, as well as a tracheal intubation aid, where it is again finds its place in various airway guidelines. It is also used as an extubation aid to see in thyroid surgeries to see the vocal cords. It's found its role in intensive care units as well as non-operating room anesthesia. There are various absolute and relative contraindications for using supraglottic airway devices, but the main one would be inability to insert the device, where there are anatomic pathologies present like reduced mouth opening. There are known or suspected foreign body or pathological airway obstruction. There is known trauma to the neck, trachea, or the oropharynx. And when there is a high risk of aspiration, for example, non-fasted patients and patients with bowel obstruction, etc. And when there is a requirement of a higher peak inspiratory pressure. Now, supraglottic airway devices can be classified in various ways. They can be classified either with the presence of a cuff or no cuff, where they sit either supraglottically or retroglottically, whether they have a gastric tube present or not, and what the sealing mechanism is. And there are two other classifications. The ones that we use clinically are the Cook classification and the Miller's classification. Now, the Miller's classification classifies supraglottic airways in various generations. First generation, second generation, and most recently the third generation. First generation supraglottic airway devices are the ones which have only an airway tube. And examples of those would be our classic LMA and the fast track LMA. Second generation supraglottic airways are those which have some additional design to reduce the risk of aspiration. They have higher seal pressures. They allow higher seal pressures, and most of them could also have integral bite blocks. Now, what this essentially means is that they have a gastric tube present. An example of those, like we all know, are Procele LMA and the iGel. There's also another generation, like I mentioned, called the third generation supraglottic airway devices, though its exact definition is not yet clear. It could be those supraglottic airway devices which have a dynamic sealing mechanism present, like the BASCA LMA, or more recently, LMAs with video laryngoscope present. So there are various first generation and second generation supraglottic airway devices present in our armamentarium. Based on the sealing mechanism, Miller also gave a classification where either there is a cuffed perilaryngeal sealer, cuffed pharyngeal sealer, and cuffless pre-shaped sealer. The cuffed pharyngeal sealer could be either with esophageal sealing or without esophageal sealing, and there are various examples present for each of these. In our armamentarium for your examinations, there are over 30 different types of supraglottic airways present. But if you understand the basics, like we've already mentioned till now, know the basic parts which are present in all supraglottic airway devices, know each one's advantages, disadvantages, you will be good to go. So don't worry, we'll cover the basic parts, the basic mechanisms, the basic concepts that you need to know, and one by one, you will be able to describe your supraglottic airway devices. So when a supraglottic airway device is either handed over to you or you're asked to pick one up, you should be able to tell its type, its classification, basic parts, and some specific parts or features of that particular device, how it's inserted, what its uses are, and if there are any specific advantages and disadvantages. So there are some basic parts of a supraglottic airway device which are common to all your supraglottic airway devices. And they are the presence of an airway tube, because that is the most important part. And as you can see, this is a classic LMA which looks very similar to what Dr. Archie Brain made with his nasal mask and an obliquely cut endotracheal tube. So this is an airway tube through which the ventilation is done. It always has a proximal aperture and a distal aperture. The distal aperture is the one which helps us with the ventilation oxygenation. It has an inflatable, or if it's cuffless, an inflated part, which could either be a mask or a cuff. There is an inflation line through which this cuff is inflated. And there may or may not be a drainage tube depending on the generation of the supraglottic airway device. So if we remember at least these parts of a supraglottic airway, even if we don't know the specifics, we should be good to go. And any other feature which is there beyond this, you will be able to tell. The prototype, like I just mentioned, is a classic LMA. A classic LMA was the original reusable first generation airway invented by Dr. Archie Brain. It has a cuff. It is reusable for up to 40 times. It sits perilaryngally, and it has almost 8 sizes, which can be used right from the neonates to the adults. It has a soft silicone cuff, and it has aperture bars to prevent airway collapse by the epiglottis, and the airway tube sits at a 30-degree angle with its cuff. Now, when you are inserting an LMA, how do you assess the adequacy of anesthesia for LMA insertion is a pretty commonly asked question. The absence of a motor response to a jaw thrust is a reliable method for assessing adequacy of anesthesia for LMA insertion. Now, you may be asked, what are these steps for insertion? These steps for insertion are almost the same for all your supraglottic airway devices, depending on what features it has. There are pre-use checks where you do the size selection inspection. There is pre-use preparation where you do inflation, deflation, mounting, lubrication, neck positioning, insertion, depending on the type of supraglottic airway device, how you insert it, the cuff inflation, insertion of the gastric tube, verifying its placement, and securing it. So like we can see in these videos, you first do a visual inspection to check if there are any abnormalities. Then you take a syringe and do an inflation followed by a deflation. The deflation can be done either manually or using a deflation device that is present. You then position the neck in the neutral position or in the sniffing position. Remember that with a supraglottic airway device, even a neutral position is a reliable position to insert your supraglottic airway device. The insertion here, because this is an LMA supreme that is being done, does not require either the digital method or use of an introducer. Then the gastric tube is inserted. Cuff can be inflated if it is a cuffed supraglottic airway device, and then you verify its placement. So how much volume needs to be inserted in supraglottic airways which have a cuff? Now, the cuff volume in most of the supraglottic airway devices depends on the size, and the size depends on the weight. So here you can see the different sizes that are marked, And each one comes with a specific weight of a patient that we have to insert it in. And that's the maximum cuff volume that needs to be inflated. There's also a formula for it. For example, if you have a size 3 LMA, so you do 3 minus 1, that's 2 into 10, which is the amount of cuff volume that you need to insert, right? And how much should be the cuff pressure? It should be between 20 to 60 centimeter water. We'll just talk a little bit more about this in a while. There's a concept called the oropharyngeal leak pressure or the airway ceiling pressure. This is the pressure of fluid at the posterior pharyngeal wall if the oral cavity was flooded with the fluid. And the measurement of this OLP helps to determine the maximum airway pressure which is achieved before which air leakage occurs. If we overdo this, the risk of gastric inflation and impaired ventilation increases. As a rule, in positive pressure ventilation, the leak pressure should be more than 20 centimeters of water. And in spontaneous ventilation, it should be at least more than 10 centimeters of water to avoid aspiration. How it is checked is, again, there are various steps. After inserting the specific supraglottic airway device, you have to inflate the cuff as per the cuff volume and turn off the ventilator. Following that, the APL valve is closed and the fresh gas flow is set at 3 liters per minute of 100% oxygen. And a gradual increase of the airway pressures is checked. Whenever there is an audible leak or a suprasternal notch, auscultation at the suprasternal notch, and you can also see when the manometer stabilizes, is the oropharyngeal leak pressure. There are various values that have already been given to us. For most of the first generation supraglottic airway devices, the OLP is much lesser than that of the supraglottic airway devices of the second generation, which is why they are preferred, which is one of the reasons why they are preferred now. Some of the supraglottic airway devices have a higher OLP as compared to others. Now, how much air to inflate in cuff for a best seal, you may ask? What is recommended is that you inflate the mask with half the maximum inflation volume recommended, check for the OLP, and then add more air if necessary. Remember, the cuff size is more important than the volume in determining the seal, and upsizing LMA provides a better seal than adding more air in smaller size LMA. How can we verify that a supraglottic airway device has been placed correctly? There are various markers for it. Number one is a visual assessment. Then you can do a suprasternal notch test. There's an expired tidal volume, which you can correlate with your inspired tidal volume. You can check the peak pressures, easy passage of gastric tube, a gel displacement test where you can put some lignocaine jelly in the gastric tube and watch its movement along with ventilation. More recently, ultrasound neck can be done, and fiber optic visualization. In terms of the fiber optic visualization, a BRIMACOM scoring can be done, in which there are various grades that have been described depending on what is visible to us. And it helps us determine how well the airway is visualized and how well the supraglottic airway device is positioned. Grade 3 and 4 is what we're trying to achieve, which tell us that the device has been placed correctly, whereas grade 1 and 2 indicate a malposition of the device. Now, one by one, we'll just quickly go through the main features of the most commonly asked supraglottic airway devices, starting with the ProSeal element. This is the one which I believe is most commonly available in most institutes in the present day. It is a second generation device with a double tube arrangement where the airway tube and the drain tube run parallelly to each other and they sit laterally to each other. It is cuffed and it sits perilaryngally. There are in fact two cuffs, a dorsal cuff and a ventral cuff. The second dorsal cuff is not present in these three sizes, and the second dorsal cuff is present for obtaining a better seal pressure as compared to the classic LMA. The cuff is made of silicone and it is reusable up to 40 times after doing a steam autoclave. So if you're able to describe all of these features in a ProSeal LMA, your examiner will be happy with you, and try to explain each device trying to cover these main features. There are four parts in a ProSeal LMA: the cuff, inflation line with pilot balloon, airway tube, and the drain tube. It is available in 7 sizes. As compared to the classic LMA, the airway tube is shorter and smaller in diameter, and it is wire reinforced, making it more flexible. It also has a built-in bite block, and there is a strap an insertion slot for the introducer placement. Now, the next device that we talk about is the iGel device. The iGel device is a second generation supraglottic airway with the gastric channel. It has a dynamic seal. It is available in 7 sizes. And interestingly, like you all know, it is cuffless. It has an integral bite block, and it has a buccal cavity stabilizer and an epiglottic rest. The interesting thing about the iGel is it's made of a thermoplastic elastomer called SEPS, which is styrene, ethylene, butadiene, styrene. This particular material adjusts to the body temperature, which is much higher than the room temperature, and it activates this elastomer. This causes it to expand and conform to the anatomy of the hypopharynx without the need of a cuff, hence it is cuffless. The iGel also has a much wider airway lumen, hence it is a good conduit for intubation. It has much higher seal pressures, which means higher OLP, which means we can give higher peak inspiratory pressures through it. And it is also commonly used in pediatrics because of its short insertion time, similar OLP, and similar complication rate as compared to a classic LMA. The next LMA that we'll discuss now is the intubating LMA or the LMA fast track. This, like we all know, is a first generation LMA. It is available in size 3, 4, and 5. It is cuffed with perilaryngeal placement. It is devised for blind intubation with an anatomical curve of 128 degrees. This helps with ease as a tracheal intubation aid. It has a steel handle, an airway tube epiglottic bar, and a low volume, high pressure cuff in the wire reinforced endotracheal tube, which comes along with it, along with the stabilizer. So this is used as a tracheal intubation aid. The next LMA is a LMA Supreme. Now, LMA Supreme, again, it's cuffed. It sits perilaryngally. It is second generation because along with the ventilating tube, it also has a drainage tube. It has a fixation tab and an integrated bite block, like you can all see. And the drainage tube orifice sits at the tip of the cuff. It also has epiglottic fins, and it is available in 7 sizes. It is the device of choice in patients with limited mouth opening. Also, another interesting feature of the LMA Supreme is the presence of a second seal. So the first seal is with the oropharynx at the oropharyngeal seal, and the second seal is an esophageal seal, hence minimizing gastric insufflation and reduces risk of aspiration. Talking about the Ambo again, it is a second generation device and can be used as a tracheal intubation aid. It is single use and disposable, and it has an anatomical curve. You can see the various parts without even reading all of this, that there is a gastric access, there is a ventilating tube, there is a bite block, there is a pilot balloon, there's a gastric channel drain, there is a cuff, it is anatomically curved. The features about this is it is MRI safe, and a larger nasogastric tube can be passed through its insertion port. The next device is an LMA Blockbuster. Now, the LMA Blockbuster, I'm sure you can all see and try to describe it by yourself now. It's cuffed, it's perilaryngeal. We can see a second drainage channel, so it's second generation. It is made of silicone material. This again was designed for rapid blind insertion, so it is used as a tracheal intubation aid. The curvature of the airway tube is at 95 degrees, and it aligns with the oropharyngeal curve. It has a Parker flex, that is an inverted tip of a Blockbuster, which helps overcome obstruction of tube by anterior tracheal wall, an integrated bite block, and a 4-way connector. One of the newer airway devices present is the LMA Gastro, which has a channel for the endoscope to pass through, and a cuff pilot technology, which is an integrated single-use cuff pressure indicator that constantly monitors cuff pressure. It is used during endoscopic procedures to allow ventilation while endoscopy procedures are happening. Now, some other ones that could be asked in your exam is the SLEEPA device, which is second generation device, also considered third generation because of its dynamic seal. It has an anatomically preformed cuff and a hollow boot-shaped distal end, which has parts like the toe, the bridge, and the heel. Another device is the BASCA device with a self-sealing membrane cuff. It has 2 gastric drains, a full-length bite block, a tab for fixation, and a suction elbow. So whatever device you're given, if you know the basics, if you know the generation, if you know the parts, you should be able to answer them. Now, talking about some non-conventional clinical settings, of late, Supraglottic airway devices have been used in neonates, in laparoscopic surgeries, in airway surgeries, in patients who are morbidly obese who require higher peak inspiratory pressures because of the better OLPs that the newer devices have. It has also been used in pregnancy, in prone position, in airway surgeries, in difficult pediatric airways, and in NORA. But remember, this must only be done when you have a backup plan, it is under supervision, and there's enough literature available. There are various complications of your supraglottic airway devices, some of them being the most common one, hazardous one, dangerous one that we all want to avoid is aspiration of gastric contents, followed by gastric distension, foreign body aspiration, airway obstruction or laryngospasm if it is placed in an inadequate depth of anesthesia, trauma, sore throat, inadequate sealing, dislodgement or misplacement, damage to the device, the device failure of cuff to inflate or deflate, and there have also been reports of nerve injury. There are various recent advances in supraglottic airway devices, and the most common one, which is a recent advance in all our throughout anesthesia, is the use of ultrasound. Ultrasound has been used for confirmation of correct placement of the supraglottic airway as well as assessment of size. There is a new type of LMA called the SACO VLM, which is a disposable video laryngeal mask, where it uses technology of camera plus a laryngeal mask, and you can visualize the condition around the glottis during insertion for a rapid and accurate insertion, leading to higher success rates, higher sealing pressures, and smooth gastroesophageal drainage. Like I mentioned earlier, it is also being used in certain clinical scenarios where traditionally it was considered contraindicated, like pregnancy and prone positioning, and requires more published literature and research to use clinically. So just summarizing, when you're describing a supraglottic airway device, you must know its type, its classification, specific parts and features, its uses, its advantages and disadvantages. My suggestion for you to read supraglottic airway device is the Bible of anesthesia equipment, which is Dosh and Dosh. There's also another book called Ward's Equipment. If you get your hands on it, you can also read that for easier understanding. Thank you and best wishes for your exams. I hope whatever device is given to you, you will be able to identify it and do very well. Thank you so much.
Thank you, Bhavya. It was such an informative and engaging presentation on the supraglottic airway device. You have clearly highlighted, according to PG, their indication, advantage, uses, method to use. So your practical tips and discussion really helped all the PG.
Thank you so much, ma'am. I don't see any questions in the chat box as of now.
Yes, there are no questions in the chat box. Thank you, Dr. Bhav.
All doubts are
Thank you
cleared.
so
All
much.
doubts are cleared. Yeah.
Ekdam clear lecture.
Ekdam clear.
It's a well-structured presentation, so there are no doubts.
No, it is a
It was very enlightening, and supraglottic airway device is like one of the most common.
Most common and most marking system is if PG pick the endotracheal tube and if pick the supraglottic, that is better to use pick the supraglottic airway device.
Yes, yes.
Okay, thank you.
Thank
Thank you
you.
so much.
Thank you,
ma'am.
Jyoti. Thank you, ma'am.
Thank you.
Thank you, Bhavya. Thank you, Geeta ma'am. Thank you, Bhavya. I would like to invite Dr. Pranav Bansal. Dr. Pranav Bansal is professor and head in BPS Government Medical College for Women, Kanpur, Kalan, Sonipat. He has more than 60 journals in international and national journals. Sir's area of interest is USG-guided regional anesthesia and pain management. We welcome you, sir.
Thank you very much, ma'am, for the introduction. It's my pleasure to introduce Dr. Rakesh Kumar, who is working as additional professor in AIIMS, Jodhpur. And sir has achievements such as he has won Usha Mehta Award in RSCCPCon 2025 recently. And his area of interest is cardiac anesthesia and pediatric anesthesia. Sir will be speaking on modern vaporizers, apart from the conventional ones, he'll be enlightening us on the newer aspects and the newer developments in the vaporizer. So I welcome Dr. Rakesh Kumar for this lecture. Thank you.
Hello everyone, I am Dr. Rakesh Kumar from AIMS Jodhpur. So today we will discuss about modern vaporizer. So from my side there is no conflict of interest. I have taken few of picture from the Google which is only for academic purpose. So why do we need vaporizer? Can we directly install isoflurane to our lung to anesthetize any patient? I think we know, because all inhalation agents are liquid at room temperature and atmospheric pressure, and they have to convert into the vapor before administration. And they are very potent, and so they has to be diluted with carrier gas before administration to the patient. So what is the vaporizer? It is the device that allows vaporization of the liquid anesthetic agent, and after vaporization mix with carrier gas before administration to the patient. So what are the function of the vaporizer? These are the first, convert liquid volatile agent to the vapor, and then it allow administration with carrier gas and in a controlled manner, so that we can increase or decrease the depth of anesthesia by controlling the concentration given to the patient. So what are the characteristics should a vaporizer have? Two. So what is the characteristic of a ideal vaporizer? So first was that their performance is unaffected by the change in the gas flow, volume of liquid agent, ambient pressure, ambient temperature, latent heat of vaporization, and pressure changes related to the respiration. Then it should be low resistance to the flow, and it should be lightweight and durable, and it should be economical and require minimum services, and corrosive and solvent resistance, and cannot fill with incorrect agent, and should not allow two agent administration simultaneously. So then some physics related to the vaporizer. So first, these are vapor pressure, saturated vapor pressure, boiling point, heat of vaporization, specific heat, and thermal conductivity. So we will discuss in shortly one by one. So vapor pressure. So how a liquid convert into the vapor? So that in liquid molecule are having two kind of force. First is cohesive force, which try to keep the molecule together, and another is kinetic energy, which allow molecule to move and go above. So when we suppose in this container there is liquid, and in liquid they are having two kind of force, cohesive force, and so cohesive force is try to keep the molecule into the liquid, but some of in at upper level some of molecule get kinetic energy and try to escape, and these are the molecule this called the vapor, and these vapors create a pressure to the container wall, and this is called the vapor pressure. So what is vapor? Vapor is the gaseous form of volatile agent. So what is the saturated vapor pressure? Saturated vapor pressure at equilibrium, when the molecule that is entering into the vapor phase is equal to the molecule that again re-enter to the liquid phase. So saturated vapor pressure depend upon the temperature, and it also depend upon the physical property of the liquid. So these are the saturated pressure of the different agent like isoflurane 238, halothane 243, sevoflurane is 160, and desflurane is 664. So what is the boiling point? Temperature at which vapor pressure is equal to the atmospheric pressure and liquid start to boil. Then what about the volatility? Volatility means speed at which liquid start vaporize. So if any liquid which is more volatile, it means that the molecule having weaker cohesive force. Cohesive force is that force that keep molecule together. So it means that volatile liquid having weaker cohesive force, so they require less energy to become volatile. And heat of vaporization, it means number of calorie required to convert 1 gram of liquid into the vapor. So it means that you have to supply this much of calorie to heat up a liquid, or number of calorie necessary to convert 1 ml of liquid into the vapor. Then specific heat, the amount of heat required to raise the temperature of 1 ml of substance by 1 degree. So what is the importance of specific heat? It means that amount of heat supplied to the liquid to convert into the vapor. And it's also very useful when we use any metal to manufacture the vaporizer. Then thermal conductivity is used for the speed at which the heat flow from a substance. High thermal conductivity means that substance means that from that substance heat is conducted fast. So how we can express the concentration of gas or vapor? By two way we can we express. First is the volume percentage and another is the partial pressure. In two way we can express the concentration of vapor or gas. So first is the volume percentage. So what is the volume percentage? Volume percentage is volume upon 100 ml. Yeah, percentage of volume occupied by a particular gas relative to the sum of all gas present in. So it means is that particular percentage of the volume in all gases. So like in environment, 21% is oxygen. So volume percentage is when we express that 21% of oxygen in 1 atmospheric pressure of 760 mm Hg. It's same, or when if we express volume percentage at high altitude. So still then also it's called 21% of oxygen, despite there is low ambient pressure like in mountain. But when we express concentration in partial pressure, then it is different at different level. Like if we express partial pressure at sea level, then we get that partial pressure of oxygen at sea level would be 160 mm Hg. But when we express that partial pressure at higher altitude, like suppose where the main pressure is 500 mmHg, then the partial pressure of oxygen would be 105. So partial pressure is the better way to express concentration of vapor or concentration of gas. So this is how we can convert different scale. So then we say that in a bottle of halothane or like this bottle, this is halothane bottle. So how much vapor pressure above the halothane or this fluorine bottle? So this is why we can create that this is how that like saturated vapor pressure of halogen is 243 mmHg at 20 degrees of centigrade and atmosphere pressure is 760 mmHg. So volume percentage of halogen above in this halogen bottle is 243 by 760 into 100. So it is 32% volume percentage. And when we see that how much volume percentage in dashboard bottle, so it's a 664 upon 760 into 100. So it around 87%. So that is why, because volume percentage is very high and this is it's a too high concentration to deliver into the to the patient, because it's then it is very toxic. That is why we require vaporizer, so that that high concentration, because like in so that we can like MAC value is MAC of dashboard is 6 and here it's 87%. So if we deliver this, this is very toxic to the patient. That is why we require vaporizer, so that they mix it into the carrier gas and deliver to the patient. So then we come into the classification, how vaporizer are classified. So first is the how method of regulation of output concentration. By this, vaporizer are two types: concentration calibrated or variable bypass or measured flow. Then method of vaporization means how a vapor is produced, like flow over. These are the TAC vaporizer. Example of these are the TAC vaporizer, pendulum vaporizer, or bubble throw like copper kettle vaporizer, or mix of both flow over or bubble throw like boils bottle, or injection like Diva or TAC 6 vaporizer. Then resistance, whether they are low resistance like draw over vaporizer, where inspiratory effort is patient's inspiratory effort is required like EMO vaporizer, or high resistance like plenum vaporizer like TAC or Ladin vaporizer. Then based on the temperature compensation, no temperature compensation या thermo compensation या temperature compensation by the supplying of the heat. Then whether vaporizer are agent specific or can be used, or whether that same vaporizer used for multiple agent. Then location, whether it is inside the circuit or outside the circuit. So these are the way by which we can classify vaporizer. So what is the concentrated calibrated or variable bypass? It's mean that once, like in this picture, fresh gas flow when the vaporizer in, like here the concentration dial is 0, so that fresh gas flow directly pass to the bypass chamber. And if it because there is vaporizer is not is dial is on 0 setting, so it's go to the bypass chamber and go from here, it go to the outlet. But when vaporizer is open, so part of fresh gas flow go to the most of part go to the bypass chamber, and some part like here it go to the vaporizer chamber, and here it taken up the vapor and again mix with bypass chamber and go to the common outlet to deliver to the patient. So it's mean that part of fresh gas flow some part is go to the bypass chamber, some part is go to the vaporizing chamber. Then measured flow. Measured flow means measure amount of carrier gas flow to the vaporizing chamber. In concentration calibrated, some part is go to the vaporizer. It's all depend upon the dial concentration, means where we have set our dial open. According to this, it's go to the bypass chamber or vaporizing chamber. But here, from start onward, a measured amount of gas is going to the vaporizing chamber. Like here the two parallels, like it is the here one gas flow is from here and one gas flow is there. So major flow of gas is passing through the vaporizing chamber. It taken this vapor and then again mixed to the bypass chamber and mix and go to the common outlet. So example of these are the copper kettle and tax 6 vaporizer. Then how vapor are produced? Like here flow over means the fresh gas flow, it is the bypass chamber, it is the vaporizing chamber. Vaporizing chamber is flow over to the vapor chamber, and these are the liquid volatile liquids, vapor volatile agent. So here from here the vapor are taking these molecules, and here the wicks are kept so that it improves the vaporization by capillary action. So they take this vapor into this, and again here they mix with the bypass flow and go to the common outlet. Here these are the by flow over, and in again in bubble throw method, the bubble are produced by the fresh gas flow directly pour into the liquid agent, and from here the bubbles are produced, and so that and then they taken up by the gas and delivered to the patient. Then drawer vaporizer. Drawer vaporizer are the low resistance vaporizer where the patient inspire and it causes the negative pressure into the circuit, and circuit is connected to the vaporizer. So patient inspired effort is very much important in drawer vaporizer. So nowadays these are the not used in the, these are the only historic value, like initially like Goldman, EMO vaporizer or OMV vaporizer was the example of drawer vaporizer. Then plenum. Plenum means high resistance. So nowadays all are all vaporizer we use in our clinical practice are plenum type of vaporizer, where they carry gas from the high pressure source, like from is then the atmospheric pressure is pushed to the vaporizer to take it up the anesthetic vapor. Then thermocompensation. As we know that escaping molecule, they are volatile agent. After the molecule vapor is made, though escaping molecule reduce the energy left into the liquid. So the temperature of that remaining liquid is fall. So falling temperature means that less molecule are able to escape. As I already told that two type kind of force are available in liquid, like cohesive force and kinetic. So it's mean that less kinetic energy is available. So it will cause vaporization will be decreased once the temperature is fall. So then if temperature vaporization, so then the decrease the concentration of the vapor agents. So how we tackle this problem so that constant delivery of vapor agent delivered to the patient. So we can tackle this problem by giving external heat to the vaporizer to minimize the temperature drop, or increase fresh gas flow to the vaporizer chambers so that they compensate that reduced vaporization by more and more fresh gas flow, or some compensatory valve like bimetallic strip or metal to put some metal so that metal is shrink during when temperature is drop, and they become normal when temperature is normal. So by this flow to the vaporizing chamber is increased depending upon the temperature. So this is how we can tackle constant delivery of vaporization. So how we achieve this? Like here it is bypass chamber and it is vaporizing chamber. As vaporization occur, so temperature of liquid is decreased. So then there is a gradually decreased vaporization. So what will happen? So here this metal rod is, when temperature is normal, it remain constant. Once temperature decrease, so it shrinks. So it cause more and more gas flow to the vapor chamber, so that there is increased vaporization. So the metal rod is act as a temperature compensatory valve. Or we can put two metal of different thermal expansibility, so that they tie together, so that according to the temperature they bending on one side, and this is by this way they increase the fresh gas flow to the vaporizing chamber. Here, like here, that in this diagram we show that two different like red and green color, we show in red color and green color, we show that these are the two metal which is tied together, and they bend on either this side or this side depending upon the temperature, because they are different thermal expansibility, so they one side and one remain on state and another the bed. So here, like in temperature is, when temperature is normal, it fresh gas flow, but once temperature is decreased, so it will bend on, like here it show like it low temperature it bends, so it allow more and more gas fresh gas flow to the vaporizing chamber. Then what is the splitting ratio? The splitting ratio is that how much fresh gas flow is going to the bypass chamber and how much is going to the vaporizing chamber. The ratio of this bypass chamber to the vaporizing chamber is called as a fresh gas flow. So this ratio is depend upon the dial setting, means where we have open at which level we have open our vaporizer dial. So here it is like in this table it's showing that when we open our set our dial concentration of halogen vaporizer at 1, then 46 part is going to the bypass chamber and 1 part is going to the vaporizing chamber. If we same one volume percent is set to the isoflurane vaporizer, so 45 part is going to the bypass chamber and 1 part is going to the vaporizing chamber. If we increase the dial setting, then this spin ratio change, then it will go to the 23 part is going to the bypass chamber and 1 part is going to the vaporizing. According to this different vaporizer, according to dial setting, this splitting ratio is changed. So how splitting ratio is so in this schematic diagram, like here it is fresh gas flow and this is the control. So here this is bypass chamber. So here bypass chamber it is this, and some part is going to the vaporizing chamber. Here it is liquid volatile agent, and they taken of this anesthetic agent, then they meet here and common outlet and deliver to the patient. What will happen when dial concentration is dial setting is high? So dial setting is high, so more part is go to the vaporizing chamber, so that more and more anesthetic agent is delivered at a common outlet. And if it is dial setting is low, then bypass chamber having more flow compared to the vaporizing chamber. And if it is dial setting is 0, as in that mention, nothing will go to the vaporizing chamber. On all gas will be go to the bypass chamber. So what are the factors which influence the vaporizing output? There are certain things like which affect the vaporizer output, like impact of the gas, fresh gas flow. What are the fresh gas flow rate is there? What are the ambient temperature? What are the intermittent back pressure? And what are the impact of carrier gas composition or barometric pressure? So among all these, the impact of fresh gas flow and intermittent back pressure are more important. So how fresh gas flow is impact the vaporizer output? So if fresh gas flow is like at metabolic level very less, like 250 ml per minute or 500 per minute, then output tend to be decreased. Why? At low flow rate, vaporizer output is decreased because when setting is too low, fresh gas flow setting is too low, then there is insufficient turbulence. Insufficient turbulence in the vaporizing chambers, so to advance the vapor to the common outlet. But when it is too high, then still it cause, when like 15 liter, 16 liter, still it cause decrease output to the common outlet. Why it is so? It is so that at very high flow rate, there is insufficient time insufficient time will meet to mixing of the carrier gas with the vapor, and there is failure of saturation of carrier gas will be saturated with the vapor. So flow that output will be less whatever you set in the dial. Then back pressure, intermittent back pressure, how it affect the vapor concentration. It can be like positive pressure when we keep do bag mass, or when we use the oxygen flush. How it is caused? There are two phenomena: pumping effect or pressure effect. In pumping effect, vaporizer output concentration will be increased, and pressurizing effect, vaporizing output concentration will be decreased. So how it is? In next few slides we will see what is the pumping effect. Pumping effect is, what is pumping? It is a positive pressure ventilation result in intermittent pressure change. So when we squeeze the bag, during pressure is increased, and during expansion pressure will be dropped. So this increased pressure is transmitted from here to the vaporizer. So it will cause, there is it cause the effect in the concentration of anesthetic agent delivered to the patient. How it is? When we squeeze the bag, then that is again go to the back to the vaporizing chamber, or in vaporizing chamber and bypass chamber. So vaporizing chamber, because vaporizing chamber is more compared to the volume much larger, more, so that fresh gas flow is compressed here, and in expression there is sudden decrease in the pressure. So what will happen? Because its volume is large, it also, when there is sudden decrease in the pressure, it also cause that this vaporizing this gas is also enter from here to the bypass chamber. And normally in bypass chamber, no anesthetic gas is goes in normal circumstances, but in the effect of positive pressure ventilation, the anesthetic vapor is agent is also go from this to enter into the bypass chamber. So what will be happen? And ultimately it cause increase the vaporizing output concentration, and it is more agent delivery to the patient. So that is why the higher the anesthetic agent delivery. So how we can tackle this? As we know that when there is positive pressure, that it transmitted back to, and it
हाँ
goes
हाँ नीचे रखिए या समर चाप
here to the
उसके पास ही
it
बैठे
return reach into the bypass channel. So if we increase the length of
कल
this
का दिन मैं उसके साथ
inlet
बिताऊंगा
tube, then during
शाम
positive
को
pressure
जाएगा
ventilation it is not reached to the bypass chamber. So this is
सीधी बात
one
साफ है
way by
मैं अपने
which we
बेटे के
can
लिए एक दिन रखूंगा
tackle this solution by increasing length of
नहीं
inlet
नहीं
tube.
इसलिए साहब जब आए तो
Then
उन्हें बताया ना डॉक्टर
increased
को अपने
resistance
बेटे के साथ
means
बैठा है
we can put
इधर आके
here
चाय
bar
पी
so that
लेंगे
when we doing positive pressure
एनडी
ventilation, it
किसकी
not
मिलने
reach to
आता है
the
हमसे कोई मतलब नहीं
it not go revert back into the vaporizing
हम लोगों
chamber
से मिलने थोड़ी आ रहा है
or
एनडीसी की
by
बात करना है राहुल की छुट्टी कैंसिल
putting
करो
one way valve so that
राहुल
only
की और
it allow one way
एनडीसी
valve,
वालों
it
की
allow
छुट्टी कैंसिल
only
करनी हमारी क्यों
gas
कर रहे
pass through
हो
to
हमसे
this
मिलने नहीं
to
आते
this
23 बजे
direction,
कौन मतलब
not in reverse direction. By these three way we
खैर
can
और बता
tackle
छोड़ यार
this situation. Then another situation is pressurizing effect. Pressurizing effect is seen during higher flow rate, and this effect is due to the
कल ही आ रहे
compression
हैं
of the
क्या
fresh gas flow in the vaporizing
कल आ रहे
chamber.
थे
So
यस
amount of vapor added is remains same since the
तो फिर बेटी की तैयारी कर
saturated
रहा है
vapor
ये
pressure is
दिखाने
not
की
affected by the ambient pressure. So during when expiration, when pressure is released, so gas
और
is expanded and so
ताले
total
वाले लेके जाइए
volume
कमरा
of gas is
ताले लॉक लगा
increased.
के
But
आते हो
because
अब
it's
रजाइया भी ले जाइए वो फालतू का सामान
it's not
नहीं डालने के लिए
taken all this vapor,
कंबल
so
ले जा रजाई मत ले जा
ultimately
कंबल
the
ले जा तकिया ले जा
concentration which
ट्रे ले जा फालतू फालतू के सामान मत रखिए वहां
in
पर अलमारी में
fresh gas flow is more, but is not taken up all these vapor molecules, so there is dilution of the
बस बस बस
gases,
तो
so it
इम्पोर्टेंस क्या
less
है
volume
वो रख के
less
आने वाले
vaporizer output concentration will be there. So when we whenever examiner asks about the vaporizer, so we should always describe our vaporizer in following way, like regulation of the output, what are the method of vaporization, whether this vaporizer is what are by which way temperature compensation achieved in this vaporizer, whether it is what are the location, whether it is out of the circuit or inside the circuit, it is agent specific, yes or not, or whether it's a plenum type of vaporizer or raw hour vaporizer. Now we will discuss briefly about the old newer one. Like this is the Tech 2 vaporizer. Here it is the knob of vaporizer, and this is the glass bottle by which we can see about the how much volume of liquid agent is there. This is the filling port by which we can screw filling by which we can fill the liquid agent here. So what is the peculiar feature of Tech 2 vaporizer? It is having knob rather than dial, and it has only single bypass chamber and bimetallic strip. Generally bimetallic strip is in bypass chamber, but here it is bimetallic strip for some compensation is inside the vaporizing chamber, and the capacity of Tech 2 vaporizer is around 150 ml. And this is the Tech 3 vaporizer. So Tech 3 peculiarity of Tech 3 vaporizer is that they are having two bypass chamber and they are color coded. They are available for halogen, isofluorine, and fluorine and sevofluorine. And one peculiar feature is they are having locking lever. So to do dial change in the consent or to open up, we have to press this. Then only we can change our dial setting. So these are the locking lever which is peculiar in Tech 3 vaporizer. And bimetallic strip in Tech 2 vaporizer, bimetallic strip for thermocompensation was in vaporizing chamber, but here bimetallic strip is bypass chamber. And to decrease the or to compensate or to pumping effect, they are having long inlet to the vaporizing chamber, and the volume of vaporizing chamber is small in Tech 3 vaporizer. What about the TEC for vaporizer. TEC for vaporizer. Here it is that there is a releasing button. So after releasing button, we can change our dial setting. And one thing is here, this is select technique means that one at a time only one vaporizer can be used. So this thing, safety mechanism start from the TEC for vaporizer. This is the select a technique, and keep filling or screw filling facility is available, and internal buffer system are present in the bypass chamber, vaporizing chamber to tackle that pumping effect. Then TEC 5 vaporizer. All other TEC 3, TEC 4 to change in dial concentration we require two hand. Here TEC 5 vaporizer onward, only by single hand we can operate this just by pressing this button we can change our dial concentration, and capacity of vaporizing chamber is increased from 125 to 300 ml, and it also having intermittent positive pressure assembly to decrease the incidence of pumping effect. And the most peculiar feature is that second bypass chamber is below in this TEC 5 vaporizer. Second bypass chamber is below the vaporizing chamber, and by thermostatic assembly are also present in the second bypass chamber. Then TEC 7 vaporizer. These are the nowadays most of vaporizer are TEC 7. So use are TEC 7. So there are the variable bypass, and method of vaporization as the flow over with wicks, and they are high resistance plenum type of vaporizer, and fully temperature compensated by using bimetallic strip. And then they are agent specific, and their vaporizer are out of circuit type of vaporizer. Then we come to the less fluent vaporizer. So less fluent vaporizer are, these are the diagram are the less fluent vaporizers. So less fluent vaporizer are measured flow electrically heated vaporizer, and they are the gas vapor blender type of vaporizer and outside circuit, and they are pressurized at 2 atmospheric pressure, and their dial setting is from 0 to 18. So one question is that why do we need different kind of vaporizer for dust fluorine? Why measured variable bypass vaporizer is not used for dust fluorine? Why it is so? So answer is this. So boiling point of dust fluorine is 22.6. It's near to the our operating room, and saturated vapor pressure is 666 mmHg. So it vaporization is highly volatile. So after volatility, because of high volatility, there is rapid cooling of the liquid which is remain. So to maintain constant amount of vaporization, we need to supply heat. So we have to keep electrically heated this vaporizer around 39 degrees centigrade. And then again, as we know that number of vapor molecule above the liquid is wet, it's 87 volume percent, means it's very toxic. So we have to deliver very high or very high fresh gas flow, which is very economical if we use variable bypass. So that is why it's required a separate kind of vaporizer. This is called TEC 6 or TEC 6 vaporizer. This is the liner diagram of TEC 6 vaporizer. TEC 6 vaporization has two parallel circuit, one for fresh gas and one for vapor. Fresh gas from the fresh gas circuit pass from the flow meter to the fixed extractor to the vaporizer outlet. this is desfluence M, and it is electronically heated and at 39 degrees centigrade and 2 atmospheric pressure. Once the fresh gas is passed through the fixed restrictor, a back pressure proportionate to the flow rate each sensed by this diaphragm of this differential pressure transducer. Then this differential transducer relay the pressure difference to this control electronic system. In turn, this pressure difference control electronic system send the signal to the pressure regulating valve to equalize the pressure between desfluent circuit and fresh gas flow circuit. Aladdin cassette vaporizer. In past, we use this tape recorder for different cassettes. In the same way, Aladdin cassette having two components. One is permanent internal control unit and another are cassettes. So Aladdin cassette vaporizer are the electronically controlled vaporizer. They are having different cassettes for different vaporizer and they are color coded. They are concentrated, calibrated, flow over. And the beauty of these vaporizer that they have automatic record keeping and they are self-check automatically. So Aladdin cassette having two parts. One is permanent internal control unit, which is the part of workstation, and detachable part, which is the interchangeable cassette. These are the different for different agent and they are color coded. So this is the different the picture of cassettes. This is the front part, this is the back portion, and this is the back part which is not seen once we cassette is attached to the workstation. So this is the back part. These are the inlet and outlet valve. This is the linear diagram of the internal structure. This is how the Aladdin cassette vaporizer are looks. This is the inlet valve. This is gas from the coming from this and passes through this to the outlet valve. These are the buffers and wicks, and these are the handles, and this is the filling system. This is the schematic diagram of the Aladdin vaporizer. So in Aladdin vaporizer, this part is the Aladdin cassette, which is the detachable part, and this part is in the anesthesia workstation. So fresh gas flow come from this inlet and some part go to the bypass chamber and some part go to the vaporizing chamber. Here it is the check valve. It is a one-way valve, so they prevent the retrograde flow of gases from the vapor chamber into the bypass chamber. So this flow control valve modulated by the CPU is precisely meters the amount of gas flow through the vaporizing chamber, which then joined to the joined with the bypass flow to the common outlet. So this CPU receives the information from the multiple source, like the concentration control dial, the pressure and temperature sensor into the vaporizing chamber, flow sensor into the bypass and vaporizing chamber. So this is how it's work precisely. The last is the injection vaporizer. So in injection vaporizer, the known amount of anesthetic agent enter into the evaporation chamber by a closed feedback loop to provide desired concentration. CPU monitor the amount of volatile in the volatile chamber, the fresh gas and the target expired volatile concentration to regulate the volume of anesthesia agent delivered to the common outlet. It allows the rapid titration of the anesthetic depth with very low fresh gas flow, even at metabolic flow. So it causes minimal wastage of the anesthetic agent and prevent OT pollution. The Mackay injection vaporizer. This is the liner diagram of Mackay injection vaporizer. This is the liquid anesthetic reservoir. From here, the liquid agent are passed through this tubing to the heating vaporizing chamber. From here, because of it, there is rapid evaporation of the liquid agent and they mix with fresh gas flow and reach to the patient. Jaeger Diva vaporizer. So this vaporizer is consists of two modules. One is the interchangeable vaporizing module and another is the gas supply module, which is the part of anesthesia workstation. So vaporizing module includes the reservoir of anesthetic agent and dosing chamber, while the gas supply module consists of feedback control unit like this and that provide the dosing pressure and the system of valve like dosing valve. So agent stored here is by gravity enter into the dosing chamber. Then from here it is pressurized by the dosing pressure and then agent is passed to the dosing valve into the heating vaporizing chamber. The anesthetic agent then here is evaporate rapidly because of this heating vaporizing chamber and its vapor pressure is then introduced into the patient breathing circuit under microprocessor control. This is how they precisely work. Anaconda vaporizer. It is mini vaporizer. It's fit between the Y-piece and ET tube like HME filter. They are mainly used for ICU sedation and they are available for isoflurane and sevoflurane. The patient side is transparent and ventilator side is black. It does not require any additional power supply for its operation. They are available in two sizes, 50 ml and 100 ml. 50 ml is used for patient having body weight of 50 kg or tidal volume less than 350 ml, while the 100 ml is used for patient having tidal volume of 350 to 1200 ml. To what precisely device should be replaced daily? So last part of my presentation is one vaporizer at a time. So select a take is a safety measure to prevent two vaporizers simultaneously. And select a take technique is worked by this orange color extension rod. Thank you.
Thank you so much, sir. I think sir was busy in some case, so he was
Yeah,
not
I
able
still
to join. And
no,
thank you,
I
sir.
have joined, ma'am. I am still in OT.
Uh-huh.
So
Sorry, sir. I thought you pronounced sir. I'm really sorry. My bad.
no. It's okay.
Pranav sir is also there.
Thank you very
Thank
much,
you.
sir. It was very enlightening lecture, especially the basics part. Indeed, every year, whenever I study this, the structure of the vaporizer from inside, I'll mug it up, I learn it, and I forget it, and so on and so forth. It goes with every student also. And in this lecture, the newer thing I learned was the Mackey vaporizer. So I
Yes,
was
sir.
just thinking about the
Yeah,
Mackey one.
yeah, injection vaporizer. Yes, sir.
Injection vaporizer, sir.
Yeah.
It was very interesting lecture. Let me see the comments. Unfortunately, when you were in the midst of
Sir, there were no questions in the chat box.
yeah, okay. Okay, so we may proceed for the next. Thank you very much, sir.
Yes, sir. Thank you.
Nice lecture. Thank you.
Thank you, sir. Thank you, Pranav, sir. It was wonderful session. Obviously, vaporizer is one of the most difficult topic.
Very
and
difficult.
I hope all the students get enlightened.
Yeah,
So our
they should-
next lecture will be on local anesthetics. And last, it will be conducted as table viva by Dr. Deepak. Dr. Deepak Verma is a specialist affiliated with ABVIMS and Dr. RML Hospital, New Delhi. He received Principal's Appreciation Award for ISA Delhi in 2022 and 23. And his area of interest is pediatric anesthesia. We welcome you, Dr. Deepak.
Thank you for your kind words.
Thank you, Dr. Deepak.
Good evening to all. So today we are going to discuss one of the examiner's favorite drug, that is local anesthesia, which is important from exam point of view, both theory and table viva. In theory, generally, local anesthesia comes as a short question. Questions may be like classification of local anesthesia, mechanism of action, clinical features, and management of local anesthesia and systemic toxicity. Also, you can be asked about the ASRA guidelines related to last. So today I have with me Dr. Akshay and Dr. Vidisha, and they will help you to demonstrate about your approach during the drug viva. So before starting with the viva, let me tell you that you should carefully read the label of the drug while inspecting the vial and identify the drug properly. Then you should describe the chemical name, molecular structure of the drug, followed by the availability forms in the market. Then you need to describe the composition of the whole vial, followed by the physical properties of the drug like pH, pK, and the storage conditions of the drug. Then you should describe about the mechanism of action, followed by pharmacokinetics, pharmacodynamics, uses, side effects, drug interaction, and any special consideration related to the drugs. If you tell about the history of the drug, it will fetch you a very good marks. So under these headings, you need to describe any other drug that you come across during the drug viva. Remember, while you are describing the drug, examiner at any point of time can lead you to the series of questions related to your description. So Vidisha, do you have drug with you?
Yes, sir. I have with me a single-use 50 ml vial of the hydrochloride salt of lignocaine. Each ml of this drug will contain 21.3 milligram of lignocaine hydrochloride, 6 milligram of sodium chloride and water for injection. This particular vial is preservative-free. It belongs to the intermediate potency and duration amide amino group of local anesthetic with the chemical name 2-diethylamino N26-dimethyl phenyl acetamide. This was the first amino-amide type of local anesthetic discovered by Lofgren in 1943. The pK of this drug is 7.9. At the physiological pH of 7.4, it is about 76% ionized. It is 55% bound to alpha-1 glycoprotein in the plasma. The onset of action is about less than 4 minutes and the duration lasts for about 30 minutes to 3 hours. 95% of this drug is metabolized by the liver by the CYP enzyme system to active metabolite monoethyl glycine xylidide, which is further metabolized to inactive glycine xylidide and is excreted in the urine. Multiple preparations of this drug is available, which include lignocaine hydrochloride solution, lignocaine with epinephrine, preservative-free lignocaine, multiple types of ointments, jellies, topical solutions, and nebulization solution, transdermal patches, ophthalmic solutions, and eardrops. This drug acts by inhibiting the open and inactivated states of the sodium channel from the cytosolic side. It has multiple uses like peripheral nerve blockade, epidural analgesia and anesthesia, spinal anesthesia, test dose preparation, IV regional anesthesia, treatment of chronic and acute pain. It can be used for local infiltration and topical application. It has known to obtain the laryngoscopy reflex and can be used in TIVA. Antiarrhythmic properties are associated with this drug and it can be used for cough suppression. It has multiple side effects like allergies, transient neurological symptoms, and other neurological toxicity. It can also cause LAST if given at a higher dose.
Very well described, Vidisha. So now we will proceed with all possible questions that an examiner will ask related to local anesthesia during your viva. So Akshay, describe the basic structure of the local anesthesia.
So local anesthetic consists of a lipophilic and a hydrophilic part, which is connected by a hydrocarbon chain. The hydrophilic group is usually a tertiary amine, such as diethylamine, whereas lipophilic portion is usually an unsaturated aromatic ring, known as para-aminobenzoic acid.
Can you tell me which group of drugs also share the similar structure of local anesthesia?
Yes, sir. Antihistaminic and anticholinergic drugs are structurally similar to local anesthetics.
Yeah, rightly said. Vidisha, can you name first compound that was used for giving anesthesia?
In 1884, cocaine was the first anesthetic agent that was discovered by Carl Kohler and was used for anesthetic purposes by Halsted.
Okay. And can you name the first synthetic compound used for local anesthesia?
In 1905, procaine was the first synthetic ester type of local anesthetic discovered.
Yeah, very good. So Akshay, can you classify local anesthesia?
Yes, sir. According to structure, local anesthetics can be classified into esters or amides. Amides are bupivacaine, lignocaine, mepivacaine, prilocaine. And esters there are two types, that is benzoic acid esters and para-aminobenzoic acid esters. Benzoic acid esters are cocaine and benzocaine, while para-aminobenzoic esters are tetrocaine, chlorprocaine, and procaine. And sir, other is according to the duration of action, there are short, intermediate, and long-acting local anesthetics. Short actings are mepivacaine, procaine. Intermediate acting are lignocaine, bupivacaine, ropivacaine, and levobupivacaine. And long actings are tetracaine.
Okay. So do you know any specific ester local anesthesia which is not metabolized by plasma pseudocholinesterase?
Sir, cocaine. It is metabolized in liver.
Yeah, very good. Vidisha, please tell me the mechanism of action of local anesthesia in detail.
So local anesthetic agents, when they are given at a particular site, we usually inject the non-ionic or the lipophilic kind of drug. This enters the plasma membrane, and once inside the cytosol, it binds to a hydrogen atom to become a cation, which enters the sodium channel and blocks it from inside. As a result, no further sodium can enter the cell. This will lead to gradual blockade of action potential transmission through the nerve fibers, and ultimately will lead to complete blockade of action potential propagation.
So in short, if I summarize, sodium channels are essential for generation of the action of impulse, nerve impulse. So what happens when local anesthesia is deposited near the vicinity of the nerve, the unbound form, which is the most lipophilic part, it enters through the cell membrane into inside the cell. Now this accepts the hydrogen ion and gets into the cationic form, which then attaches to the sodium channels through the cytosolic side of the cell. And finally, it inactivates the sodium channel, and thus it gradually decreases the generation of the impulse and finally abolishes the nerve impulse and thus causes sensory and motor blockade. Okay. Akshay, whenever we give local anesthesia for motor and sensory blockade, you must have come across at times that there is only the sensory blockade, but motor blockade has not happened. Can you explain the mechanism?
Sir, according to core mental theory, the sensory fibers inside the nerve are situated more towards periphery, while the motor fibers are situated towards the center. So when local anesthetic is given, it accumulates around the nerves and blocks the action potential propagation according to the concentration gradient from periphery to center. That's why sensory blockage occurs first, and after that the motor blockage occurs.
Is there any addition to this mechanism?
Yeah, sir. Small fibers are blocked first, then large diameter fibers, and then, sir, myelinated fibers blocked first, then unmyelinated fibers. Because in myelinated fibers, local anesthetic acts only at node of Ranvier.
Yeah. So when you are talk about the thickness of the nerve fiber, Vidisha, can you tell me the order of blockade with respect to the thickness of the nerve fiber?
The B-type fibers are the first to be blocked. They are the preganglionic sympathetic fibers. This will lead to autonomic inhibition. This is followed by A-delta fibers, which are responsible for pain and cold sensations. This is followed by A-beta fibers, which are responsible for touch and for proprioception. This is followed by A-gamma and A-alpha fibers, which are responsible for motor activity, which is again followed by C-type postganglionic sympathetic fibers.
Okay, very nice. So you must have come across the word CM.
Yes, sir.
What do you
So
understand?
CM is the minimum concentration of a local anesthetic agent that is required to block the nerve conduction across a nerve fiber. This reflects the potency of a local anesthetic. In short, we can say that CM is analogous to the MAC of the inhalational anesthetic agents.
Okay. So what are the factors that determine the onset of action of local anesthesia?
So the nerve fiber type, the diameter of the nerve fiber, the tissue pH, the pK of the agent we are injecting, the lipid solubility of the agent, the frequency of stimulation of the neuron, myelination of the neuron, and addition of vasoconstrictors can all affect the duration of onset of the action of a local anesthetic agent, sir.
So you have talked about pK of the drug. What do you understand by pK?
The pKa is the pH of the drug at which the ionized and the non-ionized portion of the drug are at equilibrium.
So basically, if pKa is near to the physiological pH, you mean to say that unbound drug will be more available and will act rapidly in blocking the sodium channels. Okay.
Yes, sir.
Suppose the pK of lignocaine is 7.9, and while the pK of chloroprocaine is 9.1. So which will have the faster onset of action?
The lignocaine will have a faster onset of action since its pKa is closer to the physiological pH of 7.4. As a result, there will be more unionized form which will cross the plasma membrane and will be active to block the sodium channels.
Yeah, very good. So what is the duration of action? So what are the factors which determines the duration of the action?
So the duration of the action will be determined by the dose of the drug we are giving, the additives or the vasoconstrictors that we have added to it, the lipophilicity of the drug, the protein binding, the site of injection, and the intrinsic vasodilatory property of the drug.
So how does protein binding affects the duration of action?
So protein binding of a drug will determine how much is the free fraction that is available for usage by the tissue, and drugs that are more protein bound will work for a longer period of time.
And what about the doses and the volume of the drug? How does it affect the duration of action?
So more the volume of the drug we give, more is the duration of action.
Yeah.
Provided it is below the toxic range of the drug.
This is why we called all the blocks to be a volume dependent block. Okay.
Yes, sir.
And also by increasing the concentration of the drug, at times we can increase the duration of the action. And what is you have been talking about the intrinsic vasoactivity of the local anesthesia. What do you mean by that?
So certain local anesthetic agents have vasodilatory property of their own. When injected, they will cause vasodilation. As a result, there will be increased absorption of the drug from the injected sites.
What happened at the lower dose? There is a biphasic effect basically. At the low dose, initially there is vasoconstriction, but at the higher doses, there is vasodilatation.
Dilation.
Okay.
Yes, sir.
You have also talked about the adjuvants added to the local anesthesia to increase the duration of action. Akshay, can you tell me the few names of the adjuvants that we commonly use?
First is epinephrine. At the concentration of 1:2 lakh at 5 microgram per ml concentration, it produces vasoconstriction and increase the availability of local anesthetic to the desired site. Second is clonidine and dexmedetomidine act on alpha 2 receptors. Third is dexamethasone and yes sir. Fourth is dexamethasone.
Which adjuvant are you using in your institute?
Sir, epinephrine with concentration of 1:2 lakh.
And what about the adjuvant used while giving spinal anesthesia?
Sir, epinephrine with.
Are you adding some opioids? Are you adding epinephrine for spinal anesthesia?
No, sir. No, sir. Fentanyl.
Yes. Okay.
Fentanyl
is also commonly used adjuvant while giving spinal anesthesia. At times, when you are giving supraclavicular block, you must have added bicarbonate also. What is the purpose of adding bicarbonate?
Sir, bicarbonate causes alkalization of a local anesthetic, which shifts the pKa of the drug towards the physiological pH. By doing this, the non-ionized form of local anesthetics converts into non-ionized form, which causes increased absorption of local anesthetic and promotes the early onset of desired action.
Yeah, Vidisha, while describing the commercial preparation of lignocaine, you have described that the lignocaine exists in the form of hydrochloride salt. What is the purpose of this?
So the hydrochloride solution, that will increase the shelf life of the drug, prolonging its activity and usage.
Okay. And what is the preservative used?
So methyl paraben, sir.
One more additive is used in preparation of lignocaine with adrenaline. What is that?
Sodium metabisulfite, sir.
What is the purpose of that agent?
Sir, it is an antioxidant. It has
Yes.
an antioxidant effect and prevents the lignocaine solution from getting oxidized.
Thus increases the shelf life of the drug.
Shelf life of the solution. Yes.
Very good. So what is the maximum dose of lignocaine, Akshay?
Sir, therapeutically, it's 3 milligram per kg without ADR and
I'm
5
talking
milligram.
about lignocaine. It is 5 milligram per kg.
Yes, sir. 5 milligram per kg
Yes.
without ADR, 7 milligram per kg with epinephrine, and the toxic dose is 9 milligram per kg.
Yes. And what about the maximum doses used for bupivacaine?
So 2 milligram per kg.
Yeah, 2 to 3 milligram per kg.
3 milligram per kg.
Vidisha, why don't we add epinephrine with bupivacaine?
Sir,
Any
bupivacaine
specific
in
reason?
itself.
Yes.
Sir, bupivacaine in itself is a longer acting drug, sir. So there is no rationale behind adding a vasoconstrictor to prolongate its activity, since it's already acting for a longer duration of time.
Okay. While giving intercostal block, we are little worried about the amount of drug being given. Why so?
Yes, sir. Sir, intercostal areas are highly vascularized. So if we give a large volume of local anesthetic, more amount of local anesthetics can reach towards the intercostal area, which may causes the systemic local toxicity of local anesthetics.
So can you tell me the decreasing order of absorption of local anesthesia into the systemic blood while depositing at certain areas?
Yes, sir. Sir, the most is intravenous, and after that it's endotracheal, then intercostal, then sir paracervical, then caudal, then lumbar, then brachial plexus.
Vidisha, we are at times we are concerned about the doses and the volume of the local anesthesia given to pregnant females and infants with less than 6 months. Can you explain why?
In pregnant females, there is increased concentration of progesterone, which will increase the sensitivity to local anesthetic agents. there is engorgement of epidural veins, and there is decreased protein binding due to hemodilution. There is slower hepatic metabolism of the drug. All of these factors will lead to an increased concentration of local anesthetic in the plasma as well as increased action of the agent. In infants less than 6 months, there is less alpha 1 acid glycoprotein and albumin in the plasma. As a result, there is increased free form of the drug, and this drug will act more. Also, in infants, there is a immature methemoglobin reductive system. They are highly prone to methemoglobinemia if injected with a drug like prilocaine or benzocaine, sir.
Okay. Can you tell me about the metabolism of the local anesthesia? How are they metabolized?
So, the ester local anesthetic agents, they are usually metabolized in the plasma by butyryl cholinesterases, while the amide forms are metabolized in the liver by the cytochrome P450 system. Lignocaine is metabolized by oxidative dealkylation to, to MEGX, which stands for monoethyl glycine xylidide. This is further metabolized to glycine xylidide, which is water soluble and is excreted in urine. Bupivacaine undergoes multiple processes of metabolism, which includes N-dealkylation and is converted to pipecolate xylidide, aromatic hydroxylation, which converts it into 4-hydroxy bupivacaine, amide hydrolysis, and conjugation or glucuronidation. It is converted into water-soluble forms, which are excreted by the renal route.
Okay. Akshay, can you enumerate some uses of local anesthesia?
Yes, sir. The local anesthetics can be used as topical or surface anesthesia, local infiltration, peripheral nerve block, or IV regional anesthesia as bias block, and sir, epidural and or spinal anesthesia.
Are there any other uses?
Sir,
tumescent anesthesia. Have you ever heard
Yeah,
the
yeah.
word tumescent anesthesia?
Yes, sir. It can also be used in tumescent anesthesia also.
And what about the awake fiber optic?
Yes, sir. Lignocaine spray. Sir, there it acts as topical anesthesia.
Okay. And to obtain the laryngeal reflex during the laryngoscopy?
Sir, it can also be given as a translaryngeal block.
Why translaryngeal block during the laryngoscopy?
Sir, it is given in cricoid membrane.
During the laryngoscopy, you never give any blocks. Okay, you give IV lignocaine. Okay.
Okay, sir.
Yes. So Vidisha, you must have heard of test dose given after placement of epidural catheter. What is the purpose and what is the composition of that test dose?
The test dose is usually given to ensure the proper placement of an epidural catheter. Usually it can either be available to us in a preformed premixed state, which contains 1.5% of lignocaine and 1 in 2 lakh of epinephrine. It is usually available as a 3 ml solution. However, we can also prepare this in the OT. We have ADR in the concentration of 1 in 1000. We dilute this to a concentration of 1 in 10,000 by diluting it up to 10 ml. This is further diluted to 5 ml and the concentration becomes 1 in 50,000. We use 1 ml of this solution and 3 ml of 2% lignocaine to make a solution of 4 ml, which contains 1.5% lignocaine and 1 in 2 lakh of epinephrine. 1 ml of this is discarded and the rest 3 ml is given via the epidural catheter to recognize whether the catheter is in the subarachnoid, in the epidural space, or is intrathecal or intra. Monitoring the hemodynamic signs over a few minutes.
Okay. So, Akshay, you have talked about bias block.
Yes, sir.
Can you explain?
Sir, it is also known as intravenous regional anesthesia. It is given for the distal part of upper and lower limb with a lignocaine concentration of 0.5%, 3 milligram per kg For upper limb, it is given up to 30 to 50 ml, and for lower limb, it can be given up to 50 to 100 ml. Sir, during procedure, sir, first we raise the arm of patient and apply. The first we will cannulate the patient. We will put two cannulas, one on the dorsum part of hand of upper limb, dorsal part of hand, and second cannula we put in the opposite arm. And then, sir, after that we raise the arm and applies Esmer's bandage to drain the venous pooling of arm. And then, sir, we apply the dual cuff tourniquet and increase the pressure of a dual cuff tourniquet more than 100 mmHg up from systolic blood pressure until the radial pulsation abolish. And sir, after that, we will give lignocaine, and it will provide effect within 3 to 5 minutes, which lasts long up to 30 to 60 minutes. And after the procedure is done, we will gradually deflate the dual cuff tourniquet so that the large amount of local anesthetic that is collected inside the venous circulation of upper arm gradually reaches towards the systemic circulation so that local anesthetic systemic toxicity can be prevented.
So basically, if I summarize, this tourniquet is very similar to the tourniquet used by the orthopedicians for the limb surgeries.
Yes.
Okay, to avoid bleeding. And this only the difference is that the tourniquet that we are placing is the dual cuff. Okay.
Yes, sir.
So the operating limb, we first place the tourniquet and then we place the cannula on that same limb. Okay. And we also secure another cannula on the opposite limb so that in case of emergency we can resuscitate, or also for administering any other sedatives or any other drugs, or for giving IV fluids during the intraoperative period. This procedure this bias block is given only for shorter duration of surgery. Yeah, maximum up to one hour. Okay, because we need to deflate that tourniquet.
Yes, sir.
Okay, and rest of the procedure you have already explained. So, Vidisha, can you tell me what is this EMLA? Can you tell me the full form of this EMLA? EMLA.
The EMLA stands for a eutectic mixture of local anesthetics. The concept behind it is when two anesthetic agents are mixed together, the melting point of the combination is lesser than the melting point of the parent agents. As a result, when applied topically, this is absorbed more into the circulation and has more effects.
So what is the composition of EMLA?
It contains 2.5% of lignocaine and 2.5% of prilocaine, sir.
Okay. And what are the uses of this EMLA cream?
So EMLA cream can be used before venipuncture, before arterial cannulation, before insertion of Foley's catheter. It can be used before lumbar puncture. Even ENT surgeons use this cream for myringotomy.
Do we use for placing Foley's catheter, or do we use some other composition?
So we generally use xylocaine jelly, sir.
Yes, we don't use for Foley's catheterization. Sure. And it is also used by the ENT surgeons for which surgery?
Myringotomy, sir.
Yeah, very good. Why do we not use in the children or patients consuming sulfonamides? What are we afraid of?
So since it contains procaine, it can enter the systemic circulation, and it can be converted into orthotoluidine. This can cause methemoglobinemia, especially in children and in patients already taking sulfonamides and drugs like phenytoin, sir.
Okay. We have talked about tumescent anesthesia. Do you have any idea about it?
Yes, sir. So, tumescent anesthesia is an alternative to GA in liposuction surgeries. For this, in every liter of solution, we are adding 1 ampule of 1 in 1000 epinephrine, 50 ml of 2% lignocaine, and 10 milliequivalents of sodium bicarbonate. Sodium bicarbonate, sir.
Yes.
We are injecting about 5 liters of this solution in the subcutaneous plane of the area where we want to perform liposuction. As a result, this will create a very firm and tumescent, as we say. This will provide the surgeon with a good operating plane And from the anesthetic point of view, this will give us good analgesia. This will also give us less blood loss as there is vasoconstriction due to epinephrine activity. The patient can be ambulatory very soon after the surgery, sir. And since there is very less, we can give about 35 to 50 mg per kg of this lignocaine in this solution, sir. As there is very less systemic absorption, there is very less chances of systemic toxicity.
Okay. So, Akshay, suppose you are posted in a OT and you have received a case of a patient with right both bone fracture forearm. Okay. You have decided to place a supraclavicular block for same. You gave roughly around 40 ml of local anesthesia for the block, and after around 30 minutes, patient started complaining of dizziness and circumoral numbness. What is your diagnosis?
Sir, it can be due to local anesthetic systemic toxicity, in which when lignocaine crosses its toxic dose, then sir, CNS toxicity starts to appear, which started from perioral numbness, then sir, confusion, then sir, sometimes it leads to seizure, and then it can lead to coma. And
Vidisha, can you tell me the proper order of neurotoxicity that appears?
So at a lower dose, there is perioral numbness and dizziness.
Yes.
At a slightly higher dose, there is tinnitus and nystagmus and vertigo. At a further higher dose, the inhibitory interneurons of the brain are blocked, and there can be seizures, hallucinations, and other excitatory symptoms. At a further higher dose, the patient can end up in coma or in respiratory depression.
Okay. And what about the cardiovascular symptoms? If the cardiac toxicity occurs, what are the symptoms that will occur, Akshay?
Sir, at lower dose, at therapeutic dose, lignocaine can prevent arrhythmias, but at a higher dose, that is more than 5 milligram per kg, sir, it causes decrease in the myocardium activity by blocking the sodium channels and propagating the action potential. Then, sir, it can also cause the potent vasodilation, which further causes cardiovascular collapse.
Basically, if I summarize, initially there will be hypertension and tachycardia, followed by intermediate myocardial depression and hypertension. And ultimately, because of the severe vasodilatation and severe hypertension and dysrhythmia, patient may land into the cardiac arrest. Yes. So, Vidisha, what is CC/CNS ratio?
So it stands for the dose of the local anesthetic that causes cardiovascular toxicity upon the dose of the anesthetic agent that causes neurologic toxicity. This basically gives us the safety margin of a local anesthetic agent. Like we say, there is if the CC by CV ratio, if the CC by CNS ratio is low, there is low margin of safety, and there is more cardiotoxicity associated with the local anesthetic agent.
Okay. Can you enumerate other adverse effects of LAST, Vidisha?
So the other adverse effects may include neurologic toxicity, which can include anterior spinal artery syndrome, causing decreased motor and pain and temperature sensation in the lower limbs. It can also include cauda equina syndrome, which includes saddle paresthesia, bowel and bladder association, and pain in bilateral lower limbs, and can cause transient neurological symptoms, which causes paresthesia and pain in the lower back, buttock, and lower limbs. It can also have hematological side effects like methemoglobinemia. This is associated with certain agents like prilocaine and benzocaine. There can be hepatotoxicity. There can be a decreased response to the ventilatory effort to hypoxia.
Okay, so now you have diagnosed the case of local anesthesia systemic toxicity. So coming to the management, ASRA has laid some guidelines regarding management of LAST. So can you enumerate the silent features, Akshay?
Yes, sir. Sir, if a sign and symptom of last occurs, sir, effective airway management is crucial to prevent hypoxia and acidosis. And then, sir, if a seizure occurs, then it should be treated with benzodiazepine, and it can also be treated by propofol or small dose of propofol and thiopentone. But although propofol can further suppress myocardial activities and vasodilation, which may lead to cardiac arrest, so cardiovascular uh, monitoring should be done before giving propofol as a uh, treatment for seizure.
So basically,
And
the
then,
last cause is hypotension. There is a risk of hypotension, and propofol can cause further hypotension. So generally,
yes,
it is not preferred. Okay.
yes, sir. If cardiac arrest occurs, then we follow
What
ACS guidelines.
I'll stop you here. But if benzodiazepines and propofol are not effective in controlling seizures, what
Oh
are,
yes.
what is the other
Then, sir,
choice?
if we cannot prevent or control seizure by benzodiazepine or propofol, then we can give muscle relaxant.
Yeah, very good.
We can give muscle relaxant to the patient, and then, sir, if there is a cardiac arrest can occurs in patient, then, sir, we will follow ACLS guidelines, in which, sir, if there is a small modification in ESRA guidelines for managing last. In this, sir, epinephrine which we use, it should be used in small doses between 10 to 100 microgram, rather than using 1000 microgram in standard ACLS guidelines.
Okay.
Then, sir, in this, vasopressin, beta blockers, and calcium channel blockers should be avoided. And if there is a ventricular arrhythmia, then amiodarone should be preferred. And then, sir, after that, we can use lipid emulsion therapy. 20% of lipid emulsion at 1.5 ml per kg bolus given initially. After that, 0.25 ml per kg per minute of infusion. Start for at least 10 minutes after the circulatory stability is attained. And then, sir, even if after giving lipid, circulatory stability has not achieved, then we can further give bolus of 1.5 ml per kg. And, sir, we can increase the infusion rate to 0.5 ml per kg per minute. And, sir, maximum dose up to which lipid emulsion can be given is 10 to 12 ml per kg. And, sir, if there is a failure to respond for lipid emulsion or vasopressor therapy, then cardiopulmonary bypass should be considered as alternate treatment for the local anesthetic systemic toxicity. If it is available in our hospital, then we can consider this procedure in our hospital. Otherwise, consider transfer to higher centers.
Yeah, very good. You both have performed very well. And even I have tried to touch all the important questions related to the local anesthesia, but because of shortage of time, it is not possible to cover each and every drug like bupivacaine and ropivacaine. So you all need to have go through those drugs in detail. So rest of the things have been covered. So best of luck for your exams. Okay.
Thank you, sir.
Thank you.
Thank you so much, Dr. Deepak. Your topic covered each and everything, and it was very enlightening. All the topics which should be included as per the post graduation perspective was covered in this topic. Thank you so much, Dr. Deepak.
Thank you.
So it is the end of day 2 of Appec 2025. Thank you. To all the residents. There will be a quiz in a while. Just bear with me one more minute. Within two groups in your WhatsApp group, your quiz will be there. Please do the quiz as soon as possible. First two winners will get the full reimbursement of their registration fees and their account only. So to all the delegates, this quiz is very important. You will get the full reimbursement. Today, winners we already announced. It's Dr. Shubhajit and Dr. Hima. Congratulations to you two. And thank you so much. Please fill up the feedback form also. It is very important to fill the feedback form so we'll know how to improve ourselves. Thank you to all the delegates. So it's the end of the session. Thank you so much.